Hello students, this is Dr. Patil. Welcome to Physics Wallah MedEd on your very own YouTube channel where you learn for your NEET PG and FMGE exam. You're connecting with us today on this mega recall of the today's conducted FMGE examination. We have a lineup of 19 faculty members. We will be appearing live turn by turn covering all the key questions that appeared in today's exam. But before we delve into those questions, let us understand how was today's paper in comparison to previous exams. So with us, we have got Dr. Vijay, who cleared his FMGE exam in the previous session. So, and he and myself and our other faculty team have interacted with some of the students who appeared for the FMGE exam. So let us see how was this paper. Dr. Vijay, today's paper in comparison to last session of FMGE, how do you rate it? Was it more easier, difficult, or same as the previous FMGE exam?
Pramit. Hey, Pramit.
Okay, I guess there is some connection issue with Dr. Vijay. I run a poll on my Telegram channel with the FMGE students asking them, how do you rate today's exam? And most of them thought that this is moderate, not very difficult and not very easy. And when I run through the questions that students are sharing with me, my perception is that getting to 150 may not be a very tough task if you have done a serious preparation for 6 months. Like if you've done a dedicated preparation for 6 months, you should be able to reach that magical number of 150. Most of the questions were on the anticipated lines, right? I don't see this exam as a radically different exam. Whatever, like topics that are routinely anticipated. For example, if I have to talk about my own subject, medicine, mostly we generally say that ABG is a standard topic for questions. And this exam also had a question on ABG. I've not yet got a full recall what exactly the question was, but yes, the ABG is a time-tested topic, and that holds good even for this exam, right? Similarly, most of the other faculties I have interacted say that the topics are frequently repeated, and this exam also had a lot of frequently repeated topics and questions based on that. Okay, so I will take you through the Vijay's opinion once he connects with us. Till that time, let me rate some of the important topics that I have so far collected. So there was a question on aphasia, again, a very common and the standard topic repeatedly tested. And aphasia gives the examiner a chance to interlink between the medicine, physiology, and anatomy. And I guess this question was probably an integrated question, right? Then JVP is a standard topic. And this time also there was a question on JVP. Then similarly, pathology medicine integration is very common these days. So there was a question on Parkinson's disease and probably the inclusion bodies theme. But they did not directly ask what kind of inclusion bodies we see in Parkinson's disease, right? So they would have given you a clinical stem. So that is medicine part. You will answer the question going inside the pathology, but the question opened with the medicine stem. And that is why I say integration is crucial. Okay. Then there were questions about the ABG, as I've already told you. SLE is a standard topic. So there were questions on SLE. Myasthenia gravis clinical case-based question was there. So in neurology, every year, there will be one question about localization or identification of the disease based on the clinical picture. So as anticipated, there was a question. I have reiterated it multiple times, even on the FMG YouTube sessions that we did, that neurology, one clinical STEM question would be there. Then stroke question was there. Scoring systems are important. In fact, we did a separate session for scoring system on the YouTube. And there was one question on curve 65, and I'm sure in other subjects also there will be questions on the scoring systems. Then there were questions related to electrolyte abnormalities, which had been a standard question, a standard template of framing questions from past several FMG exams. And this time it was about the refeeding syndrome. But yes, electrolyte-based questions we do anticipate very frequently, right? Okay, I guess we have got Dr. Vijay here. Vijay, you're able to hear me?
Yes, sir.
Okay, Dr. Vijay, you cleared your FMG exam in the last session, and you have interacted with your friends and juniors who appeared today. So how do you think today's paper was placed in comparison to previous session? Was it easy, difficult, or same as the previous paper?
This time's paper, I'll say most of the reviews were like moderate. Some were easy, but mostly majority were moderate. So compared to last time, this time was last time was a little bit on the hard side. But, I think this time is fine, moderate. So
okay, so from the student's perspective, how do you rate it? Like, see, FMG exam is not a competition. You just need to reach that 150 number, right? So is it easier this time to reach 150 number, or do you think last time it was easier to reach 150 number?
I think this time was easier because last time was like a 9.8 strike ratio, so 9.8 passing percentage. I think this time it will be much more.
Okay, I have heard some students saying that generally the December session is slightly easier.
Yes.
What do you think about it?
Yes, it's
Because you have
always.
seen previous year questions and previous year topics of all previous sessions.
Yes, I think December is the easier, so easier side. So.
Okay. When you interacted with students, what was their view on paper one? Was it like easy or paper one was more difficult than the previous papers?
Part one, paper one was like mostly single liners. Pharma was there, PSM questions was there, and mostly some say easy part one because it was single liner. So, and the part two was more on the clinical side, on the clinical cases and.
Okay. Was there any undue weightage given to any subjects in the paper one?
Yes, PSM and pharma. Lots of pharma questions were there, and PSM was also there.
Yeah, I think as we know, right, PSM had been an important topic for all the exams, be it NEET, PG, INI, CET,
Yes, in India, PSM.
And this is a take-home message, students. If you're preparing for the subsequent FMGE exam, PSM is one subject that you cannot afford to ignore. Okay, and what's your take on the paper two?
Paper two was more on the clinical basis. So I think students who have clear concepts and everything, they found part two easy. Students has a good memory, so they found part one easy. So part two was more on the clinical side with the concept. So.
Okay, in a couple of minutes, Dr. Sudha Sitaraman will be joining us. She is our Opthal faculty. We'll take her opinion about the exam. Meanwhile, students, if you have encountered difficult questions which were difficult to dissect, you can start sharing them with us on the PW Telegram as well as on this YouTube feed, and our faculty members will take cognizance of that. And when they come live for the recall, you will be able to get more well-constructed questions. Okay, so spending time on previous year topics just 1 or 2 weeks before the exam, is it a good strategy looking at the way this paper has panned out?
I think in this time, I think it was a good strategy because in the last paper we see a little bit different kind of pattern was there. Like some topic was completely missing. The topics which were in the past I think 3 to 4 exams were repeated, but in the last exam they were missing. But I think in the this exam it was a rapid revision of those frequently asked topics or was very like a good strategy for these papers.
Yeah, even I would believe, because when I'm seeing the questions, most of the questions we have addressed in our YouTube sessions. Like 1 year of preparation and last 1 month concentrated on just the YouTube sessions that we did would have given good enough numbers to reach 150. Okay, we will be soon connecting with Dr. Sudha Sitaraman. She is our Opthal faculty, very familiar to most of the students. Hello, ma'am. Welcome to the YouTube live stream.
Hi, Dr. Santosh. And hi, Vijay.
Hi, Sudha.
Yeah, hi.
Ma'am,
yeah.
In your opinion, how was today's paper?
I think it was kind of moderate. We have not been able to, I mean, students have just finished off the paper. It's been a long day for them. It's like, it has been such a stressful past week and then this whole day. And it's nice that at least they're coming up and sharing their questions with us. So, abhi tak we have not got all the questions, but generally, jo feedback hai, it was definitely easier than the January paper, I mean, than the last paper, that is the June one, which had, which was really out of the way. But it was like unexpected. But ye wala attemptable tha, aise the students, that's the feedback that I have got. So I'll just ask Vijay also. So Vijay, was this bifurcation followed this time? How did, what is your opinion? I mean, what is the information you've got after interacting with your friends? Like first paper wale first paper mein aaye the, second paper wale second paper mein aaye the, ya mix ho gaya tha last time?
Most of the reviews I get were like everything was mixed up. Like in the part one, like usually the pharma question majority are in the part two, like not part two, in the clinical side, in the clinical question. But this time in the part one, which was a single liners, there was a lots of pharma questions and also. So all subjects were mixed up. Like,
So see, this is
lots of
this is a lesson. Yeah. So this is like a lesson, I think, for everybody, any students who may be watching us, who may be preparing for next exams also, that the demarcation of first paper and second paper actually does not exist now. It is there just on paper, but actually the questions are mixed. And why I am saying this is because though you know that 2 घंटे बाद मुझे यही देना ही था, but it's like psychological. You expect to see these questions in the paper and you see something else and you unnecessarily get tensed. So that is something I think students will have to avoid from now on. You have to be prepared कि किसी भी पेपर में कुछ भी आ सकता है. और वैसे भी 2 घंटे बाद हमें देना ही था. But somehow I feel that if you see something in a paper which you didn't expect to see, you kind of get unnecessarily hassled. So that you must not do. This is for everybody who is going to take the paper, say in June or next December. And first paper was largely one-liners, right?
Yeah. Most of the students, it was kind of one-liner.
But were they, I mean, Vijay, what is the take? Were they the regular kind of one-liners या बिल्कुल ही अजीब सा कहीं से कुछ भी दिया था?
There was a few weird subjects also in the single liners part one. So,
Okay.
yeah.
And how about the clinical questions? Were they long, lengthy, image था उसमें, or they were like doable kind of? Yeah. What did your friends tell you?
Mostly focus more on the clinical side, like on the concepts and everything. So part two, like images and like history thesis and everything was there. But more on the side.
Most of the exams का वो standard rule वही है, मतलब basics, fundamental strong है तो all the questions will start falling in place. But one point I would like to reiterate जो सुधा मैम ने बोला कि demarcation को हम दिमाग से हटाना चाहिए. Not only because we get hassled by seeing some medicine questions or some surgery questions inside paper one, but we also kind of become like tubular vision या tunnel vision develop कर लेते हैं कि हाँ, we will not be thinking कि हाँ ये कुछ medicine से related हो सकता है या surgery related हो सकता है, and we will just start thinking only from the perspective of basic sciences, and then option fit नहीं बैठता है and we end up doing silly mistakes there. तो दिमाग से हटा के जाना है. 2 पेपर है 19 सब्जेक्ट्स को मिला के. That's the best strategy to get into the examination hall. Okay, so we will be joined by Dr. Ranjit at 6:10 for the pathology recall. Meanwhile, students, if you can share me questions that were bothering you from the neurology, cardiology, or respiratory medicine, I will be able to take them up. As of now, I got to know that there was a question on aphasia, which I have repeatedly told you that that's a standard topic, right? In fact, I have given you a very mathematical approach to aphasia, right? Plus minus ka simple approach. The question was on Broca's area. I have not got the constructed clear question, but if the options were about fluent and non-fluent aphasia, then you clearly know that the Broca's answer should be non-fluent aphasia, right? Similarly, JVP is a topic that has been repeatedly asked. So can you share me the options that you had on the JVP? Options they were there on the JVP. If you can share, then I will be able to share you the answer. Okay. And then I guess there was a question on Parkinson's disease with the infusion bodies. Standard question. All of you know what should be the answer. That is obviously Levy bodies. Okay. So Piki says there was a question on absent Y descent. I think I have given you a simplest way to remember where we get absent Y descent. The simplest way was no, thank you, right? T here stands for thank you ka T stands for tamponade. Y का U stands for Y wave, Y descent, and no means नहीं है, right? Tamponade में Y descent नहीं होता है. That clears the confusion about where do you get absent Y descent. So if that was the question, then you, Piki, you have got the right answer, right? The answer would have been cardiac tamponade. Piki has shared a question to you, Sudha ma'am. Can you take it up on the chat? It's there on the YouTube comment section. I mean the chat box.
Just 1 minute. Could you read out the question?
The question is, I think, spiral of 𝐒𝐿𝐿och's order was there, Sudha ma'am.
The spiral of 𝐒𝐿𝐿och's
Yeah.
order. What exactly is the?
Piki, can you reframe your words, or if you can let us know what are the options?
Spiral of 𝐒𝐿𝐿och order as in, did they ask?
𝐿𝐿𝐿𝐄𝐝, yes. In case of Broca's, yes, you will have non-fluent aphasia. So that should have been the right answer. Or they had given non-fluent and where do you see, then option would be Broca's. Good. You have done the, you picked up the right answer.
Okay, so spiral of Tilo, what was it? What is the, I mean, did they ask which muscle is closest to the limbus and which?
Sagar Hotshot is saying, based on order of insertion, IO spiral Tilox.
Okay, that means which is closest to
Muscle
the
order in Tilox.
and which is farthest from the limbus, right? So you know
Yeah.
that medial rectus is closest to the limbus and superior rectus is farthest from the limbus. So I mean, there must have been some order of muscles which you have to, which they would have given. Like, did they say medial, then inferior, then lateral, then superior, or they gave some other order and you were supposed to choose that order? Was that the question?
Let me see what the student says. PK says exactly don't remember, but there it was on muscles of eye and the order.
Yeah. So basically, they must have asked which is the closest to the limbus and which is farthest from the limbus, and they would have given I mean, they would have given an order based on that, and you would have had to choose according to that. And also, I have just I mean, got a question that there was a question on retinoblastoma, which is like expected every year. So there has hardly ever been an exam where there has not been a question on retinoblastoma. So that way, I think ophthalm, there was probably a couple of questions. There was one question from conjunctiva. I think 𝐌𝐞𝐝𝐿 keratoconjunctivitis, that is Sprink et al. There was one question from cataract. I think cataract in trauma or something like that. There was this question on retinoblastoma. And there was something, I think, which was from neuroophthalm. I have still not got the question. So essentially, I think it is basically the previous year's topics only which have been asked, maybe not the exactly previous year's questions, but the previous year's topics. So I feel that what all of us as faculty have been reiterating, that the topics are repeated, it is not the question. So if you go on reading those topics which are like important, maybe you will get something around that. Like eye muscles. Eye muscles are something over the past 4 or 5 exams. Every year we have had a question on eye muscles. So that is also the lesson. So 2 lessons we have kind of picked up from here. One is forget the demarcation of paper 1 and paper 2 and think of your whole syllabus as a whole. And second, always concentrate on the previous year's topics. That is going to get you there. Maybe not the exact question, but something around it will come. So that is the take home from
yeah, thank you, ma'am. Dr. Sudha will be joining with full recall in some time. So meanwhile, we will have Dr. Ranjit coming live. So Dr. Ranjit will go through the recalls from the pathology. And if you have any recalls or any doubts on pathology, you can certainly pose it to him. Thank you, ma'am. I will connect to you once you are ready.
Yeah. I'll come back with with more questions in some time, hopefully.
Sure, ma'am. So guys, how was your pathology experience in today's paper? So I'm waiting for Dr. Ranjit to join. So meanwhile, if you can share some pathology questions, he will be able to quickly take them up and help you solve the questions. Hello, Dr. Ranjit. Welcome, over to you.
Thank you, Dr. Santosh, and thank you, Sudha ma'am, for an absolutely wonderful starting point here. Hello, Piki. Hello, Shubham. Hello, hope everyone is doing good after exams. Like Dr. Santosh was talking and everyone was talking, one common thing which I've heard from multiple aspirants is that this exam looks like exam before COVID, like very less number of image-based questions, a little bit of straightforward questions, few of them, and obviously a few bones as well, right? So there's a first look of pathology. I am not exactly sure about the exact recalls or options, so I would request inputs from you guys. I'll add on to it, and definitely all of us will come up with a perfect recall, the PDF of the recall with the correct answers and explanations very soon. Fine. So let's start. So there are 2 things here. Few students said that there's a question on CMR, which was what is Philadelphia translocation? The translocation 922. If the question was in one-liner, yes, Philadelphia is in reciprocal translocation. So what do you mean by reciprocal translocations? You have chromosome 9, and let's say you have chromosome 22. This part gets cut here, and this part comes here. That's what a reciprocal translocation means. And Philadelphia is in balanced translocation as well, right? So there's no problem in there's no loss of chromosome in Philadelphia. It just cuts and just gets translocated, right? So if it's once in one-liner, the answer would be Philadelphia chromosome is a reciprocal translocation. Can anyone recall what's the right one? Yeah, great. If the question was, which is the next investigation for CML, chronic myeloid leukemia, the answer, I'm sure you know, it's FISH. FISH is a better option. Karyotyping is okay, but if FISH is there, FISH will be a better option. Lab score is not required in a clinical point of view, but if you want to differentiate CML from leukemia reaction, yes, lab score is required. Fine. I feel this was the right recall. That's what most of the students said. I just put in case if this question was CML and the next investigation choice, go with that. Fine. Like Dr. Sudha ma'am was also discussing, there's an overlap of few things. If there was an histopathology mentioned here of flexner of intestinal rosettes, yes, Shubham, it is not a gene amplification. There's a reciprocal translocation. Because of this, the tyrosine kinase activity gets amplified. The gene does not get amplified in case of CML. Fine. Okay. So it's a 5-year-old, some age, and it's in right eye, and histopathological image shows flexner of intestinal rosettes. It's a very, very common repeated topic, which is retinoblastoma. Whatever you can write it either from ophthalmology or from this. Fine. There is no rosettes. I'll just leave this question on to Sudha ma'am. Fine. Okay, great. So this again, we must have read this in case of a G6PD deficiency, hemolytic anemia. G6PD is an enzyme which is going to be involved in the HMP shunt or your hexose monophosphate pathway or your pentose phosphate pathway, right? The glucose 6-phosphate dehydrogenase, the enzyme is involved. Because of this involvement of the enzyme, there's less recycling of your free radicals, reactive oxygen species. Because of that, there's going to be more damage to the RBCs due to free radicals or reactive oxygen species, right? Again, this is again, I can say that you can easily write this question either from biochemistry or the applied aspect of G6PD deficiency. You must have read in hematology in case of hemolytic anemia, fine? Just a question for all of you guys. What do you think would be the microscopic finding in case of G6PD deficiency? Before on, we go to the next one. Okay, thank you, Becky. The microscopic finding of G6PD deficiency would have been classical. It's a bite cell, right? Okay, let's go on to the next question. So this question, I have framed it from an old recall because I got a recall saying that there was a question on testicular tumor case history. I was exactly not sure what is the case history for testicular tumor. I'm just going to add this here, fine? So you have a young male with testicular lesion, underwent a high inguinal orchidectomy, fine? And the histology shows a nesting pattern of tumor cells, and the tumor cells are positive for OCT3/4, fine? OCT3/4 is a very, very important marker, which is going to be positive in case of a seminoma, right? So teratoma does not have any markers. Just to refresh a few things, teratoma will have all 3 germ layers in teratoma. Embryonal carcinoma, it's again more of a high-grade tumor with lots of necrosis and very high big cells and lots of mitotic figures. Choriocarcinoma, it'll be positive for beta HCG, fine? So OCT3/4 nano will be positive in case of seminoma, and its counterpart dysgerminoma again. Again, if you guys can help me with the exact recall, because the only thing which you got was a testicular tumor thing, fine? Okay, this question was not there. Okay, but Bashar, I'll take it away. There's a question on testicular tumor and a clinical history. If you can help me with the recall, I'll be able to answer your question, fine? Okay, great, Piki. Which are the CNS tumors at fried egg appearance in histopathology? I think this was there. If there was a fried egg appearance, add on to this, there's one more option was chicken wire capillaries, right? So fried egg appearance and chicken wire capillaries, there's a classical finding in case of oligodendroglioma, right? So we had read about patterns of neoplasia. Oligodendroglioma has a classical fried egg appearance and chicken wire capillaries. Glioblastoma will have the pseudo-palisading necrosis. I'm sure you know. Medulloblastoma is a small round blue cell tumor along with rosettes, your hemorrhoid rosettes, and schwannoma will have your Antony A, Antony B, and Verroque body. Fine. I hope this question was there, and it's a very simple question. It's a straightforward answer. If you have read this in the patterns of neoplasia in a YouTube lectures, I'm sure you must be able to recollect them. Okay, great, Bashar. So if it's a fried egg morphology with an image-based question, again, the option or answer is going to be the same. It's oligodendroglioma. I'll just rephrase that and do it. Was this question there? Because I just put this up because there's students said there's a question on B12 folic acid deficiency. I don't know what is the exact thing, so I just made up an image. Again, this is an old recall, so I just made up an image. If it was a question on history of B12 or folic acid deficiency or a microscopic slide, Do let me know. If it's a microscopic site and hypersegmented neutrophil, it has to be in megaloblastic anemia. I'm just waiting for your comments. What is the exact recall on B12 or folic acid deficiency? Was the scenario whether it was in pancytopenia with neurological deficit, or it was just an image-based question? There's totally 4 questions from vitamin topic. Yes. Okay, PK, I would want to can anyone help me with that? If it's in vegetarian, B12 is not a concern. If it's in vegetarian, if it's in vegan, yes, it's a concern. A child having anemia and exclusive breastfeeding. I think I'll leave this to a pediatrician. They'll if it's a vegan mother, yeah. If it is a vegan mother, the chance of B12 deficiency is more. And folic acid deficiency has nothing to do with veganism, right? Because folic acid is one of the richest source of folic acid is fruits, right? If you're a vegan with no milk or no meat, both will have good quantities of B12. If either milk is not consumed or meat is not consumed, you will have a risk of B12 deficiencies, fine? Okay, Shubham, I'll definitely rephrase that. I'll give you the right answer. If it is vegan, then veganism is equivalent to your B12 deficiency. Again, this question, I want input from you guys. I was said that there's a question on cast. Was the urine cast or a urine crystal? I just put up a random image here. This is your envelope shaped crystals where you'll have, it's in calcium oxalate stones. Sorry. Okay, what is the question on urine? Was it cast or crystals? If it is crystals, I'll show you a few crystals. Let me know what are the crystals there. You have crystals. There's an envelope-shaped crystals, which is seen in calcium oxalate stones. There's your coffin lip-shaped crystals, seen in 𝐒𝐿 calculi. Okay. And you have hexagonal-shaped crystals, seen in cystine stones. And you do have your rhomboid-shaped crystals, seen in case of an uric acid calculi. Can anyone recollect the image-based question which came on urine microscopy? If it's no diagram was there, what was the question, Amit? If there's no diagram, was the question on which part of the glomerulus was crystals formed? There's no photo? Okay. Okay, Shubham. But I got some of your friends told me there's a question on urine cast or crystals, images, but I'm not sure. Like I said, I'll take your inputs and all of us will come back to you with an absolutely right recall. This is just a first look. Hopefully, we'll be able to make it better in subsequent recalls, fine? Okay, and a young child with a history of skin rash presented to the OPD. I'm not sure if the image was given of the rash. There's a question on SLE. That's what the students said. They've created something around it, which of the antibody will be positive in patient with an SLE. In SLE, obviously, most specific antibody is anti-Smith antibody. Just to go with other options, you will see celiac disease, you will have anti-TTG antibodies. SSA, right? The easiest way to remember this antibodies, SS stands for Sjogren's syndrome, right? So SS stands for Sjogren's syndrome. It's Sjogren's syndrome A. And ribonucleoprotein can be seen in multiple things. It can be seen in myopathies, sometimes even in case of Sjogren's syndrome, and rarely in case of lupus as well, right? There's a bit of a non-specific finding. First 3 options are very clear, and it has been asked in the previous exams as well, right? So there's a question on SLE and its related antibodies. I hope this will be one of the things they have framed here. If there is any discrepancies, like all of us are saying, please let us know, and we'll be able to give a perfect recall for you. Again, this was a question framed by myself. The history, what I got was multiple myeloma, clinical history. I don't know what was the clinical history in multiple myeloma. If you can help me in telling what's the exact clinical history, I'll be able to write exactly tell it's myeloma or an MGUS or a case of an or a smoldering myeloma. Fine. A. It is about CML, Shubham. Fine. If it's about CML, was there 2 questions on CML? One was on Philadelphia chromosome. Okay, there are 2 inputs I'm getting. If it's CML, you will have massively enlarged spleen. I'm just giving you the pointers for CML. Obviously, it'll be an elderly person. If it's myeloma, myeloma will will not have splenomegaly. Myeloma will not have lymphadenopathy. Fine. If it's massive splenomegaly, yes, the answer is CML. But if it's just a back pain with plasma cells presence in the bone marrow, I would say it is for your multiple myeloma. Fine. Philadelphia is, like we discussed in the initial start, Philadelphia chromosome is there. If it's a clinical scenario with massive splenomegaly, there are only two options which can have massive splenomegaly. One is CML, the other one is hairy cell leukemia. And the way to differentiate CML and hairy cell leukemia, just with few information available, is CML will have leukocytosis. There'll be lots of WBCs, your garden party appearance, basophilia. Hairy cell leukemia will be pancytopenia. Fine. So these are the two things which will happen if it's massive splenomegaly as a history. Then I would say go with CML. Okay. Dr. Amit, the Philadelphia chromosome was a reciprocal translocation. We had discussed that in the initial start. Fine. Okay, then I'll take a CML. I will rephrase this thing. Because I got an information as a multiple myeloma, so I created a history like a multiple myeloma. If it's splenomegaly with leukocytosis, the answer will be CML. Great. Leukocytosis, anemia, and massive splenomegaly, there's no doubt it is to be your CML only. Fine. Amit, gene replication, no, if there's a reciprocal translocation given in case of CML, that will be a perfect answer. Fine. Okay. I think there were two questions on CSF finding. That's what we have got. One was with an India positivity. I'll add that. And the other one, they said there's lymphocytes. Lots of lymphocytes and pleocytosis with a clinical history of CML, with a clinical history of meningitis. We'll prefer it to be TB meningitis because here there'll be lots and lots of neutrophils. Fungal meningitis might have a little bit of mononuclear cells, but not exactly very severe. Fine. Okay. And drug-induced meningitis will generally not have any WBC in the microscopy. Fine. I'll leave the glutamine for your biochemist. No, Ali, Philadelphia chromosome is 922, buckets is 814, right? It's difficult. S phase is the most sensitive phase, Cheetah. I'll add on to that. Fine.
Hello.
Hello. Reactive arthritis, Retus B27. Okay. And I don't know what is the question on your papillary carcinoma thyroid. There's just an information said a papillary carcinoma thyroid question was asked. Can you guys help me in saying, is it the most common thing or the microscopic finding or a clinical history? What was the suggestive of papillary carcinoma thyroid? So I just created the commonest one, which is an orphan Annie I nuclei. Fine. An orphan Annie I nuclei will be seen in case of papillary carcinoma thyroid. There are a few other pointers. Samoma bodies will be said there in case of papillary carcinoma thyroid. It's the most common thyroid neoplasm. You have no question about papillary carcinoma thyroid, then I'll ignore this totally. Fine. There's a translocation involving a red chromosome. Okay. Was there a question in papillary carcinoma thyroid? No question. Fine, great. I'll ignore the papillary carcinoma thyroid question ultimately. And there are a few more information I wanted. Again, these are just one line information which I got. I don't know what was the right thing. Non-Hodgkin's lymphoma, there's an image-based question. Was there an image-based question or not? And there's a question on inflammatory cascade. Inflammatory cascade is a very huge thing. Was this about prostaglandins? Was this about leukotrienes or cytokines? Anyone who's able to recall that? And I was said there's a question on acute myeloid leukemia as well. There's no question on non-Hodgkin's lymphoma. I'll strike it off. If you guys say there's no question, I'll just strike it off easily. Inflammatory cascade and AML. Anwar, Piki, Shubham, Preet. Retus syndrome, yes. B27 HLA. Okay, no question on any of this. Amazing, right? So I'll just wipe it off because, like I said, there's a very initial recall. It's been just an hour for us. So we might be a little bit shaky in the start. Definitely, we'll get more and more valid stem of the questions and options, and we'll give you back the PDF, which you can use it for future NExT or NEET exam preparation. Fine. Okay, Bashar, I'll take it. Fibroadenoma. You have a clinical scenario plus an histopathological slide, right? Bashar, can you help me with one more thing? Was a slide of an biopsy or an FNAZ? Was it having the antler horn appearance? Or was it having something like this with lots of cells in it? Or was it a biopsy? Okay, biopsy. Fine. I'll definitely add on this question. I think clinically a mobile lesion in a young female is definitely going to be fibroadenoma. And in microscopy of fibroadenoma, what you will see is you will see predominantly a pink structure because it's more of a stromal lesion like this. And in between this pink structure, you will see compressed ducts. That's how fibroadenoma looks like. You'll have compressed ducts between the pink structure. That's how fibroadenoma looks like. Fine. Thank you, Bashar. Okay. There's a question. This I'll discuss first, and then we'll go to the cannonball secondaries, because cannonball secondaries for lung metastasis, X-ray finding, I'll leave. There are multiple people who will be discussing the questions for you. Fine. Yeah, cannonball appearance, I would say it's for lung metastasis. Lewy body biopsy was there. Again, Bashar, I think Lewy body biopsy was along with the clinical history. I'll leave it to Dr. Santosh. He'll be a better person to answer on that. Fine. Okay. So TIBC was reduced. Was this question there? Anyone? If the question was there, was sideroblastic anemia in the options? There are only two conditions where TIBC will be reduced with respect to anemia. Yeah, Lewy body will be seen in Parkinson's. Yes, Shubham. Okay, great. See, TIBC, the options are IDA, increased or reduced. See, that's a very important thing for me. If TIBC is reduced, I would prefer the answer to be a sideroblastic anemia. Was it reduced or was it elevated? Because in iron deficiency anemia, TIBC will be elevated. No, not all thing will go into IDA, right? If TIBC is reduced, the answer is going to be sideroblastic anemia. I'll give both the variations. Since I was not there at the exam hall, you'll be the right person to judge it, right? If it's going to be TIBC, which will be elevated, the answer will be, the commonest one obviously is an iron deficiency anemia, right? Hemolytic anemias, sideroblastic anemias, TIBC will be reduced. Okay, if it's increased TIBC like peaky sets and ferritin is reduced, it has to be an iron deficiency anemia only, fine? Okay, I'll ignore this part. Most of the students are saying that ferritin was reduced and TIBC was elevated. That's a classical case of an iron deficiency anemia. There's no double thoughts about that. Fine, perfect. So I'll go with this one and I'll strike this off. Fine. So it's a classical case of an IDA. Was there an image there, or it was just the parameters, lab parameters? It's IDA then. Okay. And I think there's a question on India-ing. Though Dr. Manta will give you much detail in inputs on India-ing positivity, I'm just going to just cover the image here. It's a classical finding. What's the answer? CSF finding India-ing. What will be the answer? I hope this image was there as well, right? Yes, Arif. It's classical crypto. Great. So that's all the first set of questions what I have. There's no image. Okay. So I've taken all your inputs. I've written down here as well. I'll recreate the PDF and I'll definitely share it with you in the coming maybe a few days. And hopefully you have done well. If Dr. Santosh, you're there, and if the next person is ready, please help us with any variations there, and definitely we'll come up with all the possible both part A and part B questions combined with the answers soon. Fine.
Thank you, Dr. Ranjit. I think we will be joined by Dr. Jagdish, who is our ENT faculty, and we will be running the ENT recall soon. Thank you, Dr. Ranjit. That was a wonderful recall, and I hope that helps students. Dr. Jagdish, over to you for the recall on ENT, and I hope you will be able to also lighten the mood of our students who are a bit stressed after the exam.
Yeah, thanks, Dr. Santosh. So I am actually streaming from my laptop. So if there are any questions or from the comments, please share it with me verbally. I'm not able to see them.
Sure, sir.
Yeah, guys. So I'm here in England. I'm in the airport in Heathrow, about to board a flight and doing this recall. And I felt that, you know, if you're looking at FMGE questions, one should be abroad, and we should get all the answers from foreign land. And I'm right now here, and my only purpose to come here was to do this. But anyway, from ENT standpoint, guys, I have about 14 questions. And I believe everything almost has come from either the PYQs or everything that we have covered. I don't think the examiners put too much effort in thinking of creative new questions for ENT. So it has been very, very standard. So it won't take too long. And we'll just go through these questions one by one. I think what kind of stridor in croup was asked. And, you know, croup has always been celebrity question. Many times, they ask about it. It has a very classical thing that, the glottis and subglottis starts getting inflamed because of an infection. And that's why it is called laryngotracheobronchitis. And it has a very characteristic biphasic stridor. So anytime there is a stridor at the glottis level or the subglottis level over here, right? Just below the glottis and subglottis, they will be biphasic. If it is supraglottic, it will be inspiratory. And if it is in the trachea below, it will be expiratory. And it has a classic steeple sign over here. As you can see, the narrowing of the airway, and the steeple sign is like the steeple of the church. So it has that narrowing on the top, as you see in the church, that kind of a steeple sign. This time, I think radiological was not asked. I think biphasic stridor was asked. All right. This is also, I think, an image-based question. Singer's nodule, teacher's nodule, screamer's nodule, all of it, which we do nowadays as, teachers. We can have this risk of developing these vocal cord nodules that typically, develop at the junction of the anterior 1/3 and posterior 2/3. I think it was a diagnostic image question. I'm not sure if it was treatment-based. Generally, treatment is conservative. You wait for some time, give voice rest, and it goes away. But teachers rarely can give voice rest to themselves. They have to shout and they have to talk. So this will end up in surgery. How do you differentiate from polyps? Polyps will usually be unilateral, hemorrhagic polyps, or they would be related to some traumatic event, or it could be, some viral pathologies like respiratory papillomatosis. But I think this was straightforward. Now, other question, laryngomalacia, another celebrity question always asked. Omega shape epiglottis, as you see, one of the most common characteristic. Here, what's happening is the upper part of the airway is very flimsy. The child, this is a congenital problem, so the child will be fine after 1 year of age. Once, the cartilaginous strength comes in, otherwise it just flops and blocks the airway. So another thing that you see in laryngomalacia is when you make the baby lie down on the back, the stridor worsens. Crying also makes the stridor worsen, unlike, you will see in conditions like coronal atresia, where crying will improve the, breathing. So I think this is another image-based question of laryngomalacia that was asked. Otosclerosis dip at 2 kHz, called as the Cara-Hart's notch, especially in the bone conduction, not in the air conduction, is another classic question of otosclerosis, more predominantly in women, and it worsens with pregnancy and viral infections like measles. So a lot of questions typically come from otosclerosis. So this time also otosclerosis presence confirms another celebrity question. If there is a 4K dip, then in both air conduction, bone conduction, that is noise-induced hearing loss. But this is very straightforward. I think a graph was shown of this Cara-Hart's notch for you to identify. Meniere's disease has a very typical upward sloping. As you can see, the sloping of hearing loss is more in the lower frequency, not in the higher frequency, because the pressure changes are more in the apex of the cochlea. And when the pressure changes are more in the apex of the cochlea, the apex is for low frequency hearing. And that's why in Meniere's disease, in the beginning, you will see the upward slope. After that, it becomes flat. And then eventually, in the long run, it will become a downward slope in severe Meniere's disease. I believe this was also an image-based question, and pretty straightforward as well. This Montgomery T-tube, something around airway and tracheostomies are usually asked, but this Montgomery T-tube is generally done when there is tracheal reconstruction done after trauma, or, where a large part of the trachea has been removed. And you want this benefit of both the upper and lower airway support. When you have a longer segment, then the tracheostomy tube cannot alone, be enough. So we use a T-tube. And T-tubes, the benefit is that it preserves speech, because air can go, and you can use the side port, which is marked by B over here, to suction out and clear out secretions. And if you block that, it will become, the person will be able to speak. So it is functionally better, and you can leave it for longer periods of time, unlike the metallic Jacksons. Your Chevalier-Jackson metallic tube cannot be left for, too long. It starts developing, some granulations after a few months. And your Portex tube, which is made of PVC, you can only use for a few days to maximum a week. And afterwards, eventually, either a silicone tube has to be used, or a Montgomery's T-tube, can be used. Another, this one on the nasopharyngeal carcinoma triad, I think this has, been asked numerous times. This is called as Trotter's triad in the sinus of Morgagni, where, the nasopharyngeal carcinoma, it invades this space between the skull base and the buccopharyngeal fascia. And what goes is a very important structure, the eustachian tube, and some nerves from the branches of the mandibular branch of trigeminal nerve. So the triad of classical unilateral conductive hearing loss, guys, not sensorineural hearing loss. And because it's a mandibular division, you will see temporoparietal pain, not retroocular pain or orbital pain, where sometimes they give us the option to confuse you. And of course, palatal palsy, because the nerves that supply the eustachian tube, levator palli velatini muscles and tensor villi palatini are also affected. So there will be ipsilateral palatal palsy, conductive hearing loss, and temporoparietal neuralgia. And that is called Trotter's triad. Trotter is a person who has done a lot of work in the nose. So you have the Trotter's method where you stop bleeding as well. All right, so this is also done. After parotid surgery, most common nerve, of course, you can see the dominating nerve completely spreading, saying that this whole parotid is mine, is this facial nerve. A very complex nerve comes all over the place, goes here and there, and then gets itself injured almost everywhere. So this facial nerve is under 1 centimeter below and anterior to the tragus cartilage. Is called as a tragal pointer. This part over here is called as a tragal pointer. So just 1 centimeter below and anterior, you will see the facial nerve. And some of the other branches get injured most commonly in parotid surgery, causing a facial palsy. I think there was a question on tracheoesophageal fistula, which is the Blom-Singer's prosthesis. This is something that is put in patients after the larynx or the voice box is removed. And when you use this, it is a single valve that then passes the air from your lungs into your food pipe, so that when it goes into the oral cavity, the patient can start phonating and talking. Because they don't have any larynx, the air from the trachea is not going up into the mouth. So this one-way valve will then shunt the air into the food pipe and then into the mouth, so that person can phonate. So I believe this was an image-based question of Blom-Singer's prosthesis. There's a question on DCR. I could not understand what question was asked, but I was only told that something on dacrocystorhinostomy was asked, which is the surgery of the lacrimal sac and duct. I don't know what the question was asked. Dr. Santosh, are the students telling what question was asked related to this?
They've not commented yet, but there was one question coming from Arif Anwar. He is saying, which organ is affected in modified radical pharyngectomy? Jugular vein, accessory nerve, SCM, and hyoid muscle.
In modified radical mastoidectomy?
He mentioned pharyngectomy.
Modified radical pharyngectomy. Jugular vein, I don't know. Actually, modified radical pharyngectomy, to my knowledge, is not some. If it is modified radical mastoidectomy, what are the options?
Options are jugular vein, accessory nerve, SCM, and hyoid muscle. Dr. Arif, can you reframe if there are any change in the words, or was it exactly the radical pharyngectomy? They were asking about which bone is removed in dacrocystectomy.
The bone that was going to be removed in dacrocystorhinostomy would be, as you can see, that this sac opens under the inferior turbinate over here, and there is this agar-nasi cells, which are the most prominent, your cells of the ethmoidal bulla, ethmoidal sinuses. So for us to get into this space, we have to remove sometimes a part of the inferior turbinate or the agar-nasi, based on what are the options that were asked. And we use a Kerrison's punch. The Kerrison's endo-DCR punch is the instrument that has also been asked numerous times in FMGE. And that punch is usually used to punch into the agar-nasi cells or the medial part, lateral part of the inferior turbinate.
Students have mentioned two options, sir. One lacrimal, the other one is maxillary bone.
So lacrimal,
maxillary, ethmoid.
Yeah, ethmoid would be the answer then, because we enter through the ethmoid bone, which is a part of the your ethmoidal sinuses, right? So we punch into the agar-nasi cell to then access this tube there. So I think out of all these options, the ethmoid bone would be the option that I would go with.
Okay. Okay, sir. Dr. 𝐒𝐿𝐿ogs, you mean they had given options as pairs? Okay, so as of now, we understand that, okay, there was a question on DCR surgery, and the question was about either which bones are removed or which bones are not removed, right? So we
Oh.
will reconstruct this question and come out with the exact answer, what it should be, once we get the proper clear stem. Okay, but at least we have identified one very important topic, which will be again recurring in the subsequent exams. So we can proceed with the next question.
Absolutely. There's a question on the preauricular sinus and what is the birth defect that leads to it. So preauricular sinus, sorry, there's an announcement going on. I'll just hold on for a second. Yeah. See, preauricular sinus is a problem when these hillocks, these hillocks of His, which you can see, these 6 hillocks, they form from the first and second pharyngeal arches. And when these hillocks fail to fuse properly, they leave this little sinus at the, crux of the helix over here, which can drain and get infected later on. So if your options are showing first and second pharyngeal arches, or if they're showing hillocks of His, those would be the options that I would go with, where there is, both mean the same. The hillocks of His, they come from the first and second pharyngeal arch. The first pharyngeal arch contributes to some hillocks, and the second pharyngeal arch contribute to the other hillocks. So usually they won't give both options. They will give either hillocks or they will give first and second pharyngeal arch fusion, and that would be the answer.
Your so according to students, options where there where first and second arches was mentioned. So as you said, sir, that would be the answer.
Yeah. First cleft will not be the answer. If you're getting confused, first cleft forms the external auditory canal. There was, I think, a question on foul-smelling nasal discharge, and there were options given like atrophic rhinitis, rhinosporidiosis. So I think this is very clear that foul-smelling nasal discharge very characteristic of atrophic, rhinitis, caused by Klebsiella ozane. And it causes a very roomy nasal cavity with a lot of crusting, and that's why the person smells very bad but cannot feel the smell on their own because of the olfactory bulbs being involved. So it's called merciful anosmia. So this image B is a normal nasal cavity, and A is where you see atrophic rhinitis. I think there's also another question on juvenile nasal angiofibroma. I think 15-year-old boy. The moment they put 15-year-old boy, that is the only option that comes to mind with nose bleed. I don't know what the exact question was. So, Dr. Santosh, if you see anybody clarifying what the
students,
question
can you comment down what was the exact question so that sir can help you out with the proper answer? So you can go on adding the points. I will update you about the students' comments.
Yeah, so typically in juvenile nasopharyngeal angiofibroma, they ask, what is the reason for the excessive bleed, and this is because of lack of elastic tissue and musculature, in the area. They also ask the site of origin of juvenile nasopharyngeal angiofibroma, which is the spinopalatine foramen, the anterior lip of the spinopalatine foramen. And of course, adolescent male, just from a history standpoint, is also a question. It can also occur in females. It is not exclusive in males. So sometimes, that question has also been asked. Females also can have juvenile nasopharyngeal angiofibroma. And one of the questions that is asked in those times is the first area to spread in females when they have JNA is in the maxillary sinus. Whereas in the males, it spreads more into the nasal cavity. So I think that's about it. And if we don't know what the exact question is, once we figure that out, we will share that as well. There was another question on severe maxillofacial trauma and what is the procedure that will be carried out, whether we'll do a tracheostomy, oropharyngeal airway, nasopharyngeal airway, or cricothyroidotomy. And typically in severe maxillofacial trauma, we do first secure the airway by a tracheostomy. I see that this time a lot of questions have been asked related to emergency ENT, because I guess the understanding is that you guys are going to do internships after clearing this exam, and then you should know some basic ENT first aid, and I think that's why airway questions have dominated this time. Nonetheless, all of this has already been covered, but it's interesting to see this trend. So tracheostomy would be the thing. You won't be able to use an oropharyngeal and nasopharyngeal airway in abnormal maxillofacial fractures, and cricothyroidotomy is a small hole that is made just between the hyoid bone and the cricoid cartilage in the cricohyoid membrane, so that you can save some time when somebody has something stuck in the airway. So that will not be applicable here because that's a stopgap solution. Only 6 hours you can do cricothyroidotomy. You have to then convert it into a formal tracheostomy.
Most of the students have answered tracheostomy itself. Amit Rajanand, yes, sir, has clearly told that tracheostomy would be the answer of choice.
Yeah, all right. All right,
Dr. Jagdish, thank you for the recall. Students, as we have already committed, We will be coming out with a full-fledged, properly done recall, and you will be receiving the PDF through our Telegram channel. For now, any questions that you feel are not exactly how we presented, please communicate with us on this chat feed or either on the Telegram, and we will answer that. Thank you, Dr. Jagdish.
Yeah, thanks, Dr.
Next
Santosh.
up, we have Dr. Vivek, who will be covering the physiology questions. So, Dr. Vivek, over to you. Dr. Vivek, you're able to hear me, sir? You can start with your questions.
सबसे पहले तो प्लीज रिलैक्स। आप बहुत दिनों से पढ़ाई कर रहे थे, स्ट्रेस में थे, अब ये सब कुछ वो स्ट्रेस जो था वो एग्जाम में जा चुका है और अब रिलैक्स करने का टाइम है। तो खैर इट्स अ रिलैक्स टाइम, बट स्टिल वी कैन रिकॉल द क्वेश्चंस, अभी फ्रेश है आपके माइंड्स में, एंड देन विल सी व्हाट आर द आंसर्स। एंड यू नो द प्रॉब्लम विथ physiology is very typical problem. Audio is there, Dr. Santosh sir?
Sir, you're audible now. Yeah.
Okay. So the problem with physiology is very unique problem. That is, it comes in every other subject. So after the exams also, every subject is seen as the physiology question. And therefore, it sometimes is very tough for me also to cull out physiology questions and actually discuss their answers. But so far, since it's very early, I got 5 questions or 5 topics, let's say, on which the questions were asked, or it appears to be asked. I'll just put up those 5 things first, and then we'll discuss the questions and answers also. And I will need your help in the collection of the questions properly. So there was a question on TLC, or rather spirogram was given. And okay, so spirogram was given and some thing was marked, and it was asked what that volume or capacity is. We will see that. Then glutes. These first two questions are the typical questions. Every exam, FMGE exam or any other exam, these 2 topics are always asked. You know this by now. Glutes, always one question is there. So probably insulin dependent glucose transporter was there. Then JVP, another question on which is always asked in all the entrance exams. Then there was something related to the surfactant. I could not get that question. So by the time our discussion goes through, probably you can tell me what that question was and whether it was related to the physiology. And then something related to the Broca's area or aphasia, non-fluent aphasia or something like that. So these are the things that I could gather so far. So let's have a look at these questions and their answers. And then if you can recall any more. Okay. So, this is a very wise thing that they do. Normally, we tend to memorize the figures like tidal volume 500 ml, inspiratory reserve volume 3000. They gave you the diagram and asked you probably this line. What is this volume or capacity? And the answer, it appears to be the total lung capacity. I mean, I'm saying appears because the question that is given by the students was this line. So total lung capacity, was that sorry, was that the question? This particular thing was asked. Okay. Since there is some time lag, so I'll be looking to your comments and the questions that you send. But till then, I'll just discuss the questions. Look, simple thing, tidal volume is given in the middle. And the thing that you were supposed to know in the spirogram is that the lever goes up during inspiration and comes down during expiration. So yes, inspiration, expiration. Inspiration, expiration. Then forceful inspiration and forceful expiration. So forceful inspiration, the lever goes up. and reaches this point. And forceful expiration, the lever comes down and reaches this point over here. So how do you know when they mark something, how do you know what volume or capacity is this? तो उसके नीचे जो भी बचा हुआ है ना, वो आपको लेना होता है as volume or capacity. Yani for example, this line, if they ask this line, below that line, only residual volume is remaining. So obviously, this line belongs to the residual volume. If they ask you this line, that is the end of quiet expiration. Quiet expiration ends here. So whatever remains in the lungs, functional residual capacity. So you just have to see what remains below that line. Okay. And therefore, then you can mark. So similarly, this line was given and was asked what volume or capacity is that. Now, obviously, it's the topmost point and maximum forceful inspiration has been taken when you reach here. And that means you are at total lung capacity. All 4 volumes are present in the lungs when you reach this point. So that was the question, I guess. Okay. So that was one question. Then I can see the question. Okay, next we'll take the question that I already have. Glute question was there, and which glute is present in the muscle? So this is a quick recap of the glutes. Glute 1 is ubiquitous, present everywhere, omnipresent. Glute 2, pancreatic beta cell for the glucose entry, and then glucose exit from any cell occurs with the help of GLUT 2. Then GLUT 3, neurons have GLUT 3, and this was the question. Muscle has which type of GLUT? I think which GLUT is present in the muscles? Dr. Arif has mentioned it already. So obviously, insulin-dependent glucose transporter is GLUT 4, and this is of course present in 2 tissues, muscle and adipose tissue. So that was the answer. And then GLUT 5, fructose, GLUT 5, 5 fructose. You can remember like that. Okay. Then motor unit and myosin. So Dr. Arif, can you just elaborate on this question? Motor unit and myosin. What was the question actually? I'll just note it down. Okay. Till then, I'll just go on to the next question that I have so far. JVP, there was one question related to the JVP, and it was asked why descent is absent in which of the following conditions. And I think obviously if that was the question, then the answer was cardiac tamponade. You know this already. This is quick revision. You must have marked this correctly, that there are 3 upstrokes. So atrial systole, isovolumic contraction, isovolumic relaxation. Okay. Atrial systole, isovolumic contraction, isovolumic relaxation. After isovolumic contraction means after C wave, what will come is ejection. So X downslope is about the ejection. And then after isovolumic relaxation, that is after V wave, what will come? Filling. So this obviously Y downslope is for the ventricular filling. And this wave is absent, or I mean, that was asked as a question. Then it would be the cardiac tamponade. I guess that was the question. Anything else that is related to the physio so far? Dr. Arif, I would be glad to get that question, motor unit and myosin. It appears to be a physio question because as I said, there are technically any question can fall under physiology. But since all other faculties are also going to discuss those questions, so I am leaving some of the questions for medicine faculty and so on. Right. And then there was this question, of course, patient can, I mean, the question was related to the non-fluent aphasia. So basically, Wernicke's area is in the superior temporal gyrus. It is the sensory area for speech. It gets connections from the parietal lobe, from the visual cortex, from the auditory cortex, I mean, from all the cortices, sensory cortices. And then it decides on what to speak. And then there is arcuate fasciculus, which send the signal to the Broca's area, the motor area for the speech. Inferior frontal gyrus is where Broca's area is located. And then it will generate those signals for the muscles of speech or apparatus for speech. So there was this question in which the person can understand but cannot speak properly or fluently, and therefore it was a motor aphasia related to the Broca's area for speech. So these were the questions that I could gather so far. Anything else? No, I think yeah, there was one more. Somebody mentioned about the surfactant and the ARDS. So if whether it was related to the acute respiratory distress syndrome or surfactant as in physiology, if you could recall that. So far, there are no questions that are forthcoming on this. Anyways, but Dr. Arif, motor unit and myosin, if you could gather anything related to that. What was that motor unit question? All right, but till then, till you can just recall the question from your memory, I just say a few things about the surfactant. As you know, the alveoli are lined with two types of cells, the type 1 pneumocyte, which covers 93% surface area of the alveolus and is involved in the gas exchange. And only about 5% area, means corners of the alveolus, is where these type 2 pneumocytes are located, and they synthesize and secrete the surfactant. So surfactant is secreted by the type 2 pneumocytes, and also Clara cell. Clara cell also synthesizes surfactant-like material. It was not asked, so leave it aside for now. Let's focus on the surfactant. Its precursor is tubular myelin, and its absence would cause an excessive surface tension within the alveoli. Alveoli will collapse and resulting in that ARDS or acute respiratory distress syndrome. So these are the 5 questions that I could collect so far from you all, and I would appreciate if you could get a few more so that then we will prepare that entire PDF and then we'll send it back to you.
Thank you, sir. Thank you for the wonderful recall. So next up, we have Dr. Sudha Sitharaman. She will be taking us through the questions from ophthalmology. Over to you, Sudha, ma'am.
Thank you, Dr. Santosh. Could you please let me know if I am audible and visible, and whatever I've written, whether that's visible to everyone?
You're audible, ma'am.
Okay, thank you, Dr. Santosh. So, see, we have, as I said right at the beginning, it's been a long day for all the kids, and they are like really tired, and some questions have been recalled, but obviously we cannot expect that we will have all the options so early. But we'll compile all the questions for you, and we will create a proper PDF, which we'll be sharing with you with you in some time. But these are the questions that I have got in Ophthal. The first question that I could gather was I think there was a question about cataract in blunt trauma. What is the type of cataract that is seen in blunt trauma? I mean, I think what the question said was that there is a patient who has suffered some kind of trauma, and then there was an image, and it was asked that what is the type of cataract that you see in this. So basically the key word in the question was that there is trauma and there is cataract, and there was an image of an opacity which shows that it is a rosette cataract. So was that the question? Will anybody help me with this? I think this was one of the questions. So if the rosette cataract, that's what students told me. They said that there was a question where some kind of patient had suffered some kind of trauma, and then there was a typical image of a rosette cataract, flower-shaped cataract, which is a rosette cataract. Okay, there was no image. But okay, but the word blunt trauma was mentioned, Sarah. There was no image, but the word blunt trauma and cataract was mentioned. So if blunt trauma is mentioned and they have mentioned the cataract, then the answer has to be rosette cataract. Okay, so this is one question that I got. The second question apparently was a question on spring catarrh, which is like a must-know question. So this is something which we say that you have to know like the back of your hand. That is one question in Ophthalmology which we must not ever get wrong. So I'll just try to give you what options could have been. They may have said that there is a boy who is like about something around 7 to 10 years old, and there is a complaint of itching with which the mother has brought the child, or they may have mentioned that he has this seasonal itching in the summer months or something like that. They may have given a picture of cobblestone papillae, something like this. Was that the question? Was that the question? Something like this? Like there is a boy who's complained of itching, seasonal in the summer months, and the picture of cobblestone papillae. Was there an image in this question? Okay, it was a direct question, nothing like this. So was the question something like, or was it the question on shield ulcer, that in which condition do you get to see shield ulcer? Was it the question like that in which condition do you get to see shield ulcer? Now, shield ulcer is like one of the complications that we have in vernal keratoconjunctivitis or spring catarrh. So one of these was asked, or both these were asked. I am not too sure because I got two kinds of responses from two sets of students. Some students said it was a clinical question where they must have got confused. Or another set of students said that it was a direct question which said, in which condition do you get to see shield ulcer? So can any of you tell me, Arif or Sarah or any one of you, what was exactly the question on spring catarrh or shield ulcer?
X is present. So
okay, the question was the shield ulcer is seen in, right? Okay, so shield ulcer, as I told you, it is seen in spring catarrh or vernal keratoconjunctivitis. So it was a direct question, one-liner. And was there any clinical question on spring catarrh? Was there any question of a child with itching, male patient, something like this? Okay, so whatever, this is like another of the question that was asked. Now there is one question, that the third question that I could gather was a question on white pupillary reflex or leukocoria, which is also again like one of the important topics that we always say that this is also something you cannot leave. So like these are all say previous year's topics. So what was the question on white pupillary reflex? Did they mention something like this, that there is a 1.5-year-old child or a 2-year-old child who is brought with complaint of white pupillary reflex, and they have given some USG findings, some USG findings which says that there is an intraocular mass, there is intraocular calcification, something like this was mentioned. If anything like this was mentioned, then the answer would be retinoblastoma. But I'm not sure what exactly is the age of the patient that was mentioned and what was the findings mentioned. Okay, so there is a patient who has a history of family history, and there is history of enucleation. Okay, so there is a history of enucleation. The patient has undergone enucleation, something like this. Okay, so basically what I gather from what you are telling me is that the question was around the keywords of retinoblastoma, that there is a child who is around 1.5 to 2 years old. The presentation of the child is with a white pupillary reflex, that is a leukocoria. When you do a USG for the child, you see an intraocular mass with calcification. There is a family history. There are other people in the family who had similar conditions and who have undergone enucleation previously. previously, something on these lines, which all points to the diagnosis of retinoblastoma. So again, see, and I don't know whether they had also mentioned histopath findings of flexner intestinal rosettes. If they have mentioned that, then that is like all the key points there in the same question. Okay, so see, this is another previous year's topic, or I can even call it a previous year's question. This has come in different ways in different exams. So this is also something which I think most of you would have answered. Then people told me that there was a question on night blindness or nyctalopia in a child, and it was asked that what is the deficiency of which vitamin is likely to cause this, or the deficiency of which nutrient is likely to cause this in a child? Was that the question? Did they have an image of white hot spot or something? Was it something like that, image of white hot spot, or did they just ask that a child deficiency of which nutrient in a child is likely to cause night blindness, or did they mention that it's a child who has history of malnutrition or something like that? So Shubham, Alvina, Arif, what was the question exactly? What was the question on night blindness? I think it must have been something simple, because usually they ask something like this only, the deficiency of which nutrient, or they give an image of white hot spot, or they have given a picture of anterior staphyloma and they have mentioned that the child is malnourished, something like that. Okay, so I have not yet got any answer. So I believe that something like this must have been there if it was a clinical question, or it could have been.
Shubham mentions that there was no Bitot spot, but there was simple xerosis.
Okay, so they have mentioned that there is a patient who has xerosis and it is a child, and there is deficiency of which vitamin is likely, of which nutrient is likely to cause this. So the answer obviously is vitamin A. Again, see, this is also a question that has been asked in different ways in different exams. Now, the next question is something which I and Dr. Santosh gathered when we actually opened the session, and that is the spiral of Telox. Now, see, this is not exactly something which has been asked before. Probably they asked what is the order of insertion of the muscles, right? What is the order of insertion of the muscles? Now, I would say that this is a slightly out of the way question, but it is also answerable, because we usually learn two one-liners, that which is the muscle that is closest to the limbus. The closest to the limbus is the medial rectus. This we memorize, and we also memorize another one-liner which is farthest away from the limbus. So the farthest is the superior rectus and the closest is the medial rectus. So ये दोनों तो हम memorize हमेशा करते हैं. Now the ones in between are inferior rectus and lateral rectus. So the order is this, MILS actually, medial, inferior, lateral, superior. So this I would say is like medial, inferior, lateral, superior, because medial rectus is closest to the limbus and superior rectus is farthest. ये दो हम memorize करते हैं. बीच वाले, I don't know how many of you remembered. So this I would say was a slightly difficult question. But if they had actually given you the image, na, थोड़ा सा common sense से, this is something which could have been worked out. So this is another question that I got. Now I heard that there was no image. Arrange it in order, but there was no image, or was there an image in this question? There was an image of the insertion of the four rectus muscles. Image was there. Okay. So thank you, Arif. So basically, if the image was there, then from common sense, we can kind of work it out, that which is, what would be the order of the muscle. So that's another question. But this, I would say, is a slightly new question. Ye iske pehle exactly FMG mein to at least this question has not been asked. They do keep asking questions on extraocular muscles. So this is a doable question, but this exact question has not been asked. Now, there was one question on cystoid macular edema. This is also, I have something that I have understood. Now, I don't know what exactly could have been the question, but if it is a clinical question, it is likely that they would have mentioned that probably the patient has undergone cataract surgery. There is a history of cataract surgery in this patient, they would have mentioned. They may have mentioned that the patient is a diabetic. They could have mentioned this. And they could have mentioned that there is post-operative inflammation, something like that. And post-operative inflammation they may have mentioned. Then they may have mentioned that the patient is presenting with a decrease in vision about, say, 6 weeks after cataract surgery, something like this. And they may have mentioned that the typical honeycomb appearance is seen. So the key word in this question, I would say, is diabetic and honeycomb appearance. So I don't know whether these are the things that were mentioned in the question, but usually if you have a question on cystoid null macular edema, ये सारी चीजें mentioned होती हैं. So I don't, if these have been mentioned, then probably this is the answer. Okay, so it was mentioned. Thank you, Sarah. So basically, all this, something around this would have been asked, that the patient presents about 4 to 6 weeks after cataract surgery. He is a diabetic patient, presents with decrease in vision, and typical honeycomb appearance is seen. So this is the question on cystoid macular edema. Right now, I have gathered that there was a question on monocular blindness or ipsilateral scotoma or sudden loss in vision in one eye. Something of this kind was mentioned, because I was constantly asking the students with whom I was interacting that how is it possible that we have no question from the visual pathway in Ophthal. So some students said that there was a question which said that there's a sudden loss of vision or there is an ipsilateral scotoma that the patient is suffering from, and what is the likely site of the lesion, something like this. And the options were optic nerve, optic chiasma, optic tract, and occipital cortex or something like that. So if the patient is presenting with a monocular blindness or an ipsilateral loss of vision, then the site of lesion is obviously the optic nerve. So now I don't know whether this was the question, but this is what I could gather, because I was not getting any question from the visual pathway. I kept on asking, and somebody told me there was something like this. Was this the question? Okay. Was there any question on ptosis? What was the question on ptosis? If it is a question on optic, was the question on optic neuritis? So if it is a question on optic neuritis, then usually this is not how it is framed. If it is a question on optic neuritis, then the question is sudden loss of vision. And then there is, usually they will mention that that there is pain on eye movements, and they usually mention that there is RAPD. So was this how the question was framed? Sudden loss of vision, pain on eye movements, or RAPD, something like this. If this is what is there in the question, then the answer is optic neuritis. So something on these lines. So this is also like if it is either a question from neuroopthal, that is optic neuritis, or it is a question from the visual pathway. But both these are, again, I always say that these are topics that you have to know. You cannot leave out these questions and go for the exam. Leave out these topics and go for the exam. So basically, this is what I was able to gather, because as I said, students are tired. It's been a long day for them, and they were able to faintly give us these are the topics. But the basic lesson is that it is the previous year's topics only. It is the previous year's topics. Maybe the questions were a little turned here and there, but the questions may not have been the same, but the topics were the same. Right, so that is what we have in Ophthal. I'll just try to compile all the questions with the options and come out with a proper recall, with a proper PDF for all of you in a few days' time. So thank you, Dr. Santosh. I think we can hand it over to Dr. Pradeep Pawar sir now.
Thank you, ma'am. So thank you for the wonderful recall, students. I hope ma'am was helping you to recall important questions. Now, next up, we have Dr. Pradeep Pawar, who will be recalling the anatomy questions. Over to you, sir. Am I audible, sir?
Am I audible? Sir, am I audible?
You're audible, sir. You can go ahead with the questions.
Okay. So, hello, students. How was the anatomy today? Good. So, let us start with the first MCQ. What are MCQs I have gathered? I've put this on the paper. Let us have a look at this. I'm sure this MCQs you must have been able to answer. We have gone through this MCQs in our lectures also. So now this was the image and this is what was pointed. So what was this, students? The first MCQ, what was this? That's the lesser trochanter of femur, correct? Lesser trochanter of femur. And what was the muscle attached to it? This one. What's that? The psoas major. That's the psoas major. The psoas major begins from the bodies of lumbar vertebrae. The psoas major goes below the inguinal ligament and the psoas major gets attached to the lesser trochanter of femur, correct? Yes, psoas major is the options. Very good, very good. So what is the action? Flexion of the hip joint or flexion of the vertebral column. Excellent. So one you are sure of. Okay, that was the first question for anatomy, psoas major. Very good, very good. Conjoint tendon. What is conjoint tendon? Conjoint tendon kisse banta hai? It is formed because of the internal oblique and transverse abdominis. Arif, it's the internal oblique and the transverse abdominis, and this conjoint tendon forms the roof as well as the posterior wall of the inguinal canal, roof and posterior wall. Psoas minor muscle lies on the psoas major. It lies on the psoas major. It may or may not be present. It may or may not be present. Psoas minor may or may not be present. Again, begins from the bodies of lumbar vertebrae, goes along with the psoas major, gets inserted on the lesser trochanter of femur. Same. It's similar to psoas major. Yes. Okay, fine. Conjoint tendon वो है Arif, ठीक है ना? Internal oblique and transverse abdominis. I'm just seeing the comments that you are writing. Chalo, good, 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 good. So supracondylar fracture of femur or supracondylar fracture of humerus, sorry, the nerve involved. क्या लिखा है बच्चों? Supracondylar fracture, the nerve involved. क्या लिखा है answer इसका? What have you written? The medial nerve. Yes, that's a medial nerve. Supracondylar fracture of the humerus. The nerve involved is medial nerve. And the artery involved is brachial artery. Yes. Any comments on this, students? Any comments? So that was the second question. Bolo bachcho. What was it? Supracondylar is what I've got. Okay, fine. We go to the next question. If you are able to recollect, you tell me this is what I've got. What I have got. Okay, fine. If you are able to recollect anything, you can let me know. Fine, fine. It's okay. It's okay. That's okay. Transpyloric plane. Transpyloric plane. Okay, okay. Just see this transpyloric plane passes through which vertebral level? Yes. What is that? Transpyloric plane passes through which vertebral level? That is the lower border of L1 vertebrae. L1 tha na? Transpyloric is lower border of L1 vertebrae. Shubham. Acha, malunion of supracondylar fracture. That's fine. That's fine. Okay, fine. And what are the structures which lie at this transpyloric plane? Transpyloric plane pe kya structures hota hai? Yes, the pylorus of the stomach, then the hilum of the kidneys, the second part of the duodenum, the fundus of the gallbladder, the origin of superior mesenteric artery, and the formation of portal vein. L3 was asked. That is fine. Okay, image diya tha. That's okay. That's okay. Okay, so this is what I've got for the transpyloric plane. Okay, ye to pucha tha na. What is this tendon? Identify this tendon. Ye image tha. What was this tendon? Yes, Shubham. Yes, Arif. Yes, Harish. What is this pointed tendon? It is the 𝐒𝐿. Ye tha. Very good. So this must be 100% right that you have got. So this is the anatomical snuff box. And what is this pointed tendon? Ye kya hai? This is the abductor. So, one moment. This is the abductor pollicis longus. Ye hai extensor pollicis brevis. And what is this? Extensor pollicis longus, right? So that's the extensor pollicis longus. Excellent. Very good. Forms the medial boundary of the anatomical snuff box. And where is the insertion of this extensor pollicis longus, students? It is inserted on the base of the distal phalanx of the thumb, right? Yeah, so image was given, fine. So it is inserted on the base of the distal phalanx of the thumb. It forms the medial boundary of the anatomical snuff box. Extensor pollicis longus nerve supply is posterior interosseous nerve. Fine. Okay. Easy tha ye, Arif. This was an easy MCQ. Okay, that's okay. That's okay. ये था फर्स्ट कार्पो-मेटाकार्पल जॉइंट बच्चों, फर्स्ट कार्पो-मेटाकार्पल जॉइंट इजी. हाँ, हेसेलबैक्स ट्रायंगल बोलते हैं. आई नो हेसेलबैक्स ट्रायंगल इज देयर, विल डिस्कस इट लेटर. हाँ बोलो बच्चों, फर्स्ट कार्पो-मेटाकार्पल जॉइंट, व्हाट हैव यू रिटन? व्हाट इज द टाइप ऑफ जॉइंट बच्चों? व्हाट इज द टाइप ऑफ जॉइंट? It's a saddle type of synovial joint, correct? It's a saddle type of synovial joint. And what is this? Okay, and what are the bones which takes part in the formation of joint? So ye correct hai na? So this you must have answered. It's a saddle type of synovial joint formed between, yes, the base of the first metacarpal bone and trapezium, right? Yes. Fine, very good, very good. Saddle type of synovial joint. Excellent, very good. So you've got this right. So एक malleus का image दिया था बच्चा, malleus का image दिया था, and which arch it is derived from, correct? Yes, this is another easy MCQ. What have you written for this? The image of malleus, and which pharyngeal arch is it derived from? The first pharyngeal arch. First pharyngeal arch. Very good, Harish. Very good. So this also you must have got correct. Now, first pharyngeal arch, the nerve of the first arch is the mandibular nerve, the bones, the malleus, the incus, the sphenomandibular, the stylomandibular, the sphenomandibular ligament, sorry, and the anterior ligament of malleus. Stylomandibular is from the second pharyngeal arch. Correct? So, ये भी बराबर है. Image of malleus, first pharyngeal arch. Very good. देख लो. Anatomy was that way easy comparatively. Preauricular sinus, bachcho. This was an MCQ. Preauricular sinus, which is situated in front of the ear. And what is this due to? It is due to non-fusion of the tubercles, right? ये छोटे-छोटे जो tubercles होते हैं, they do not fuse or the tubercles are not formed. So that is the preauricular sinus. Yeah, that was an image of the preauricular sinus right in front of the ear. एक छोटा सा opening है, that's a preauricular sinus. Very good. Okay, that's fine, that's fine. What else was there? The lateral boundary of Hasselbalch's triangle. Students, what is the lateral boundary of Hasselbalch's triangle formed by? So Hasselbalch's triangle ke boundaries kya? What is this muscle? The rectus abdominis. Yes, that's the inguinal ligament. And what is this structure which forms the lateral boundary of the Hasselbalch's triangle? This is the inferior epigastric artery. That's the inferior epigastric artery. Forms the lateral boundary of the Hasselbalch's triangle. Correct? Ye bhi easy hai. So this you must have answered. So you can now judge how many questions you have answered. एक दूसरा MCQ था बच्चों, common carotid arteries felt at what level? Where do you feel for the common carotid artery? Yes, what have you written this? Where do you feel for the common carotid artery? You feel at the level of cricoid cartilage, in front of the sternocleidomastoid or between the sternocleidomastoid and the trachea, in front of the cricoid cartilage, at the level of cricoid cartilage. Because common carotid artery divides at the superior border of the lamina of thyroid cartilage, correct? It divides at the superior border of lamina of thyroid cartilage. Common carotid divide hota hai, so it will be below this lamina of thyroid cartilage, that is in at the level of cricoid. Clear? Cricoid. Likha hai na ye, Shubham? Yes, Arif? Okay. And there was one slide showing omphalocele. Omphalocele. When does the herniation of the midgut loop occurs? 6 weeks. And when does it return back? 10th week. If the loops of intestine come back, if they do not come back, and they are covered with this amniotic covering, what is that? Omphalocele. And suppose if the loop is open without any covering, that is gastrocystis. Ek slide tha, there was one slide of omphalocele. Omphalocele, correct? Angle of the mandible nahi hai. Angle of the mandible nahi hai. Okay, fine. So this were the questions in anatomy. We'll be compiling the actual questions with the options and will be presenting to you in a matter of days. Okay. Thank you. Thank you to all of you.
Thank you, sir, for a wonderful recall of the anatomy questions. The students, I hope sir has addressed your doubts, and I think as I can see at the comments, most of you have got the questions right. So good for us. Hopefully we will have a very good result. Now, next up, we have Dr. 𝐒𝐿𝐿𝐿 Kumar, who is our faculty for pharmacology, and who will be taking you through the pharmacology recall.
Thank you. Thank you to all.
Thank you, sir. Thank you. Dr. Ankit, am I audible to you? So guys, meanwhile, while we wait for Dr. Ankit to join, let me also recall some of the medicine questions. So there was one question which a student has shared me just few minutes back. So there was a question on refeeding syndrome. So can anybody tell me what were the options given? What were the options on the refeeding syndrome? Probably it was a question on electrolyte abnormality. Okay, so we have Dr. Ankit live. I will take this question once we connect for medicine. Over to you, Ankit sir.
Thank you very much, sir. And I hope, sir, what you have said is absolutely true. As compared to the last year, this year, FMGE exam was moderate to easy. Last year, 6 months ago, it was on tougher side. So I hope all of you students have given your best. And this time, I hope most of the students will be able to make through. So what are the questions I'm able to recall around 12 to 13 questions, but some students are saying that pharma was even on the larger side. There were some questions which probably I am not able to recall yet properly. So I need your full support and let's discuss certain questions which I have already asked from the students. So the first question was a 2-month pregnant lady with P. falciparum malaria. A 2-month-old pregnant lady with P. falciparum malaria. What is the treatment? Beta, if you remember, if a mother is having Plasmodium falciparum malaria, remember the drug of choice in first trimester is quinine plus clindamycin. Quinine plus clindamycin. While in second and third trimester, it is artemisinin based combination therapy, which is generally artesunate with sulfadoxine pyrimethamine combination. And if the female is having complicated malaria, so in complicated malaria, the female lands up in emergency and she may die because of severe sepsis. And remember, here the drug of choice is IV artesunate. Now, which drugs are contraindicated in pregnant female? The drug which is contraindicated, yes, Dr. Arif, you are absolutely right. Doxycycline, which is a tetracycline, is absolutely contraindicated in pregnancy. And the second drug which is absolutely contraindicated in pregnancy is primaquine. So कौन से drug हम pregnancy में नहीं देते? The first is doxycycline and second is primaquine. Yes. So beta, if it is a direct question, the best or the safest option will be quinine. I hope quinine was in the option because quinine is the one of the safest anti-malarial drug in pregnancy. Fine. So I hope you have marked these questions correctly. Now, another question on pregnant female. So pregnant female with asthma and she is hypertensive. You can see the blood pressure is more than 130/80. If now the blood pressure is more than 130/80, can we say it is hypertension in pregnancy? Now, if you want to treat hypertension in pregnancy, the drugs which we give is LHMC. You have heard about a very famous college, Lady Harding Medical College. So these drugs are given in pregnancy. So normally the drug of choice is labetalol. So what is the drug of choice for hypertension in pregnancy? Labetalol. But beta, we know any drug that ends with the word LOL is a beta blocker. Now my question from you people is, क्या हम beta blocker orally asthma में देंगे? Female को asthma भी है. So remember, beta blocker are contraindicated in asthma. तो अब आप मुझे बताइए, अब आप बच्चे मुझे बताइए, क्या नॉर्मली हाइपरटेंशन इन प्रेगनेंसी में हम लैबिटालॉल ड्रग ऑफ चॉइस देते हैं? लैबिटालॉल ड्रग ऑफ चॉइस है. बिल्कुल सही कहा आप बच्चों ने, डॉक्टर आरिफ. पर आपने एक चीज देखना भूल गए. एस्थमा देखना आप भूल गए। एस्थमा में हम बीटा ब्लॉकर नहीं देते। एस्थमा में बेटा ड्रग ऑफ चॉइस होता है कैल्शियम चैनल ब्लॉकर, लाइक नेफेडिपीन। नेफेडिपीन इज द ड्रग ऑफ चॉइस इन एस्थमा। तो इस क्वेश्चन का बेटा आंसर था, इस क्वेश्चन का आंसर क्या था? नेफेडिपीन वाज द करेक्ट आंसर। द अदर टू ऑप्शंस व्हिच कैन बी गिवन इज हाइड्रालाजीन, हमने देखा था कि हाइड्रालाजीन ऑप्शन में नहीं था, और मिथाइल डोपा। एक और ऑप्शन था बेटा, द ड्रग विच इज एब्सोल्युटली कॉन्ट्राइंडिकेटेड इन प्रेगनेंसीज, एस इनहिबिटर्स। एस इनहिबिटर बिल्कुल भी हम प्रेगनेंसी में नहीं देते, ये प्रिल वर्ड से एंड करते हैं। ये तो सर कुछ भी हो जाए हमें प्रेगनेंसी में अवॉइड ही करना है। सो बेटा इसका आंसर था आपका कैल्शियम चैनल ब्लॉकर, नेफेटिपीन वाज द करेक्ट आंसर। आई होप यू हैव अंडरस्टूड। ठीक है, नेक्स्ट क्वेश्चन पे आते हैं बेटा। माउंटेन सिकनेस का ड्रग ऑफ चॉइस, एनीवन? माउंटेन सिकनेस बहुत सिंपल है। माउंटेन सिकनेस हमने बहुत बार पढ़ा है। माउंटेन सिकनेस का ड्रग ऑफ चॉइस होता है बेटा एक डायूरेटिक जो कार्बोनिक एनहाइड्रेस एंजाइम को ब्लॉक करता है, दैट इज एसिटाजोलामाइड इज द drug of choice for mountain sickness. It's a very repetitive, very simple question and many times asked. ठीक है, many times asked, बहुत बार पूछा जा चुका है सवाल, इजी है। नाउ बेटा नेक्स्ट इज, यहां पे मुझे आपकी थोड़ी सी हेल्प चाहिए। डाइसल्फिराम लाइक रिएक्शन, तो बेटा इसमें क्या पूछा गया था? कैन यू हेल्प मी? क्या इनमें ड्रग्स की लिस्ट पूछी गई थी कि कौन कौन से ड्रग डाइसल्फिराम लाइक रिएक्शन करते हैं? इट वाज आस्क्ड। तो अगर मैं आपको लिस्ट बताऊं, डाइसल्फिराम लाइक रिएक्शन करते हैं ड्रग साइक्लिक जीएमपी। कौन से ड्रग्स करते हैं? साइक्लिक जीएमपी। सी फॉर एक डायबिटीज वाला ड्रग क्लोरप्रोपामाइड। अच्छा, सो डाइसल्फिराम लाइक रिएक्शन में पेशेंट ने अल्कोहल लिया, अगर पेशेंट अल्कोहल कंज्यूम करे डाइसल्फिराम से तो पेशेंट को क्या होते हैं? सिम्टम्स आने शुरू हो जाते हैं, लाइक वॉमिटिंग होनी शुरू हो जाती है, एब्डोमिनल पेन होता है, चेस्ट पेन होता है, और कई बार तो पेशेंट हाइपोटेंशन और डेथ भी हो जाती है। कई बार तो पेशेंट की हाइपोटेंशन या डेथ भी हो जाती है। तो इसीलिए डाइसल्फिराम हम उन पेशेंट्स में देते हैं जो अल्कोहल पीना छोड़ चुके हैं, who have stopped drinking alcohol and they should not start again, क्योंकि दोबारा पिएंगे तो हार्मफुल सिम्टम्स आएंगे। एग्री? जी से था बेटा ग्रेसियोफल्विन, एक एंटी फंगल ड्रग। एम से होता है बेटा मेट्रोनिडाजोल, ये तो बहुत ही फ्रीक्वेंटली आस्क्ड क्वेश्चन है। एंड पी से एक एंटी कैंसर ड्रग प्रोकार्बाजीन। एक सिफेलोस्पोरिन का भी बेटा आपने नाम याद रखना है, सीफोपराजोल। तो साइक्लिक जीएमपी में सी बेटा 2 है, तो कोई भी बंदा डाइसल्फिराम लेता है तो ये हैंगओवर जैसे फीचर्स आने शुरू हो जाते हैं उससे, ये बात आपने याद रखना है। ठीक है, अच्छा अच्छा, कोई इनडायरेक्टली पूछा था इनमें से बेटा कौन सा ऑप्शन था? ग्रेड 6, क्या आप बता सकते हो विच ऑप्शन वाज गिवन इफ यू रिकॉल दिस क्वेश्चन? विच ड्रग वाज कॉजिंग डाइसल्फिराम लाइक रिएक्शन? यस, ओके ओके, तो ये फीचर्स पूछे गए थे डाइसल्फिराम लाइक रिएक्शन के, और पूछा गया था कौन सा ड्रग करता है। बिल्कुल, तो बेटा मैंने आपके सामने जो लिस्ट है लिख दी है, इनमें से कौन सा ऑप्शन आपको मिला था एग्जाम में? कैन यू टेल मी विच ऑप्शन यू गॉट इन योर एग्जाम एंड लेट्स सी इफ यू हैव मार्क्ड इट करेक्टली और नॉट। विच ऑप्शन वाज गिवन? सिफेलोस्पोरिन दिया हुआ था। सो यस, सिफेलोस्पोरिन। हमने एक ट्रिक भी किया था ना कि सिफेलोस्पोरिन में सीफोपराजोन, पराजोन में मतलब पीने नहीं देता, हमने न्यूमोनिक पढ़ा था, सीफोपराजोन पीने नहीं देता। ठीक है, नेक्स्ट क्वेश्चन बेटा, हाइड्रेटेड सिस्ट पूछा गया था आपसे, और हाइड्रेटेड सिस्ट मतलब आप जानते हो इकाइनोकोकस से होती है, इकाइनोकोकस ग्रैन्युलोसस। इस वॉर्म को आप दूसरे नाम से डॉग टेप वॉर्म भी बोलते हैं, क्योंकि डॉग्स वगैरह से स्प्रेड होती है। इसका बेटा ड्रग ऑफ चॉइस शायद आपसे पूछा गया था। ठीक है, आरिफ जी आपने सही मार्क किया, इसका ड्रग ऑफ चॉइस होता है बेटा एल्बेंडाजोल। अगर एल्बेंडाजोल ऑप्शन में नहीं है तब आप जाते हो मेबेंडाजोल के साथ। वॉज दिस आस्क्ड? यही पूछा गया था बेटा, यही पूछा गया था। सो हाइड्रेटेड सिस्ट में ड्रग ऑफ चॉइस क्या है बेटा? हाइड्रेटेड सिस्ट में ड्रग ऑफ चॉइस है एल्बेंडाजोल। फाइन, इजी, ओके। हाँ बेटा, एबी डॉक विच क्वेश्चन वॉज फॉर वाइवेक्स? एनीवन? एबी डॉक क्या क्वेश्चन था? कैन यू रिकॉल एंड राइट दैट क्वेश्चन? पी वाइवेक्स वाला जो आप मुझे बता रहे हैं, आई विल राइट दैट क्वेश्चन इफ यू विल टेल मी राइट नाउ। इफ यू विल टेल मी दिस क्वेश्चन राइट नाउ, आई विल राइट। कौन सा क्वेश्चन था पी वाइवेक्स पे? ओके, चलिए, आई विल वेट फॉर योर ऑप्शन, आप यू टेक योर टाइम। एक और क्वेश्चन था बेटा कि विच ऑफ द फॉलोइंग रिड्यूस ओरल आयरन एब्जॉर्प्शन? कौन कौन से मॉलिक्यूल्स ओरल आयरन की एब्जॉर्प्शन को कम करते हैं? तो बेटा एक बात आपने याद रखनी है, ओरल आयरन की एब्जॉर्प्शन को रिड्यूस कौन कौन करता है और इंक्रीज कौन कौन करता है, ये आपको पता होना चाहिए। पहले इंक्रीज की बात करते हैं। रिमेंबर, आयरन की एब्जॉर्प्शन विटामिन सी इंक्रीज करता है, ठीक है। ये आयरन को 2+ फॉर्म में कन्वर्ट कर देता है, एब्जॉर्प्शन बढ़ जाती है। एंड कैन वी से आंवला इज द रिचेस्ट सोर्स ऑफ विटामिन सी, हमने 11th-12th में भी पढ़ा था। लेमन is also a very good source of vitamin C, so they will increase. Okay, next is which of the following molecule reduce iron absorption? That is tea and coffee. क्या इनमें से कोई ऑप्शन मिला था आपको? टी एंड कॉफी। सेकंड, प्रोटॉन पंप इनहिबिटर, एंटासिड्स, क्योंकि वो एसिडिटी को कम करते हैं। HCl जो होता है बेटा आयरन की एब्जॉर्प्शन के लिए रिक्वायर्ड है, ठीक है। ओके, अच्छा बेटा आपसे सवाल पूछा गया था। ओके ओके, नेक्स्ट क्वेश्चन एक और रिकॉल हुआ है। बच्चों ने कहा पी वाइवेक्स इन फर्स्ट ट्राइमेस्टर। अब बेटा आपने एक बात याद रखनी है, अगर पी वाइवेक्स इन फर्स्ट ट्राइमेस्टर है तो ड्रग ऑफ चॉइस है आपका क्लोरोक्वीन। अगर ट्राइमेस्टर नहीं भी मेंशन तब भी ड्रग ऑफ चॉइस है क्लोरोक्वीन। बट अगर वर्ड आ जाए पी फैल्सीपैरम इन फर्स्ट ट्राइमेस्टर, रिमेंबर पी फैल्सीपैरम जो है, प्लाज्मोडियम फैल्सीपैरम, वो ना क्लोरोक्वीन से रेजिस्टेंट हो चुका है, तो पी फैल्सीपैरम के केस में हम देते हैं क्विनीन। क्विनीन जो है वो क्लोरोक्वीन रेजिस्टेंट केसेस में भी इफेक्टिव होता है। ओके, नेक्स्ट क्वेश्चन, थायजाइड्स दे एक्ट ऑन विच चैनल? ओके, नेक्स्ट क्वेश्चन, तो हमने कितने कर लिए बेटा अभी तक? 1 2 3 4 5 6 7 8 क्वेश्चन लिखते हैं बेटा। थायजाइड्स एक्ट ऑन विच चैनल्स? यही था बेटा क्वेश्चन। तो बेटा थायजाइड्स क्या होते हैं? डायूरेटिक्स होते हैं। सो दे एक्ट ऑन सोडियम, बहुत सिंपल सवाल है और बहुत बार पढ़ा है हमने। क्लोराइड सिम्पोर्टर, एक ट्रांसपोर्टर होता है सोराइड, सोडियम क्लोराइड सिम्पोर्टर, ये इसको इनहिबिट करता है, ठीक है। डीसीटी में, डिस्टल कॉन्वोल्यूटेड टिब्यूल के कॉर्टिकल पोर्शन पे हमने डायग्राम बना के भी पढ़ा था। सिमिलरली अगर आपसे लूप पूछा जाता, लूप डायूरेटिक, लूप डायूरेटिक इनहिबिट करता है सोडियम पोटेशियम 2 क्लोराइड ट्रांसपोर्टर को, ये भी डीसी, ओके, और ये इनहिबिट करता है थिक असेंडिंग लिम्ब पे, मेडुलरी पोर्शन पे, ठीक है। इनमें से कोई ऑप्शन था बेटा? इनमें से कोई ऑप्शन था? यस, ये ऑप्शन था इजीली। नेक्स्ट एक और सवाल जो बच्चे ने अभी मुझे मैसेज किया बेटा। ओके, एक फीमेल को कॉन्ट्रासेप्टिव फेलियर हो गया, सॉरी, अ फीमेल हैड इंटरकोर्स, अनप्रोटेक्टेड सेक्सुअल इंटरकोर्स, unprotected sexual intercourse, and it has been more than 5 days. तो which contraceptive would you use? ये सवाल है बेटा। Which contraceptive would you use? I believe this was the question which was asked. यही क्वेश्चन पूछा गया था। सो रिमेंबर, अगर 5 दिन से ज्यादा हो चुके हैं अनप्रोटेक्टेड सेक्सुअल इंटरकोर्स को, तो हम देते हैं आईयूसीडी या फिर एक पिल उलीप्रिस्टल की हम मेडिसिन देते हैं। बट अगर यही 3 डेज होता तो आप देते लिवोनोजेस्टेरॉल की टैबलेट या फिर ओसीपी की डबल डोज। तो आपका आंसर जो है, या तो आईयूसीडी इंसर्ट कर दो या उलीप्रिस्टल दे दो, इनमें से कोई ऑप्शन था। अच्छा, आईयूसीडी था, ठीक है। सो ये ऑप्स गायनी का सवाल बन जाएगा बेटा, ये फिर फार्मा का सवाल नहीं है। इट इज अ क्वेश्चन ऑफ ऑप्स एंड गायनी। अगर उलीप्रिस्टल होता, then it would have been a question of your pharmacology। 10th नंबर के क्वेश्चन पे आते हैं बेटा। एक सवाल था, एक आदमी को लोकल एनेस्थेटिक दिया। कौन सा लोकल एनेस्थेटिक दिया? ब्यूपीवाकेन बेटा क्या है? लोकल एनेस्थेटिक। कितना दिया? 0.5%। क्यों दिया? ब्रेकियल प्लेक्सिस के ब्लॉक के लिए दिया, हाथ ताकि मूव ना कर पाए। एंड इसके बाद द पेशेंट डेवलप्ड हाइपोटेंशन एंड एरिथमिया। पेशेंट को क्या शुरू हो गए? हाइपोटेंशन और एरिथमिया। क्या बता सकते हैं व्हाट इज हैपनिंग राइट नाउ? एनी स्टूडेंट हु कैन टेल मी दैट व्हाट इज हैपनिंग राइट नाउ? व्हाट डू यू थिंक इज हैपनिंग राइट नाउ? What is happening right now? Remember, bupivacaine or any local anesthetic, and among local anesthetic, bupivacaine तो सबसे ज्यादा क्या है? It is cardiotoxic। मतलब लोकल एनेस्थेटिक की टॉक्सिसिटी हो गई है। एग्री? लोकल एनेस्थेटिक की टॉक्सिसिटी हो गई है। सो रिमेंबर, इफ देर इज टॉक्सिसिटी ऑफ लोकल एनेस्थेटिक, द एंटीडोट इज, कोई वैसे इसकी स्पेसिफिक एंटीडोट नहीं होती, पर इसकी एंटीडोट होती है 20% इंट्रालिपिड। इंट्रालिपिड क्या करता है बेटा? लिपिड इमल्शन होता है जो ब्लड में और हार्ट में ब्यूपिवाकेन होता है, ये इसको खा जाता है। इट ईट्स ब्यूपिवाकेन, ताकि ब्यूपिवाकेन ऑर्गन पे काम ना कर पाए। एग्री? सो दैट ब्यूपिवाकेन cannot bind to organs like heart, and it prevents or reduce the cardiotoxicity. So beta, this is the very commonly question we have discussed many times, so it's a direct repeat. So the best management is this one, क्योंकि बेटा एरिथमिया तो बहुत डेंजरस है। बेस्ट मैनेजमेंट इज ऑलवेज एंड ऑलवेज इंट्रालिपिड। इंट्रालिपिड देने के बाद हम सिम्टोमेटिक ट्रीटमेंट करते हैं बाय एंटी एरिथमिक ड्रग लाइक एम्योडरॉन, वी डू सीपीआर एक्सेट्रा। ठीक है? सो आंसर क्या है? 20% इंट्रालिपिड इज द करेक्ट आंसर। फाइन, 20% इंट्रालिपिड इज द करेक्ट आंसर। नाउ बेटा, वन क्वेश्चन आई वांट टू आस्क यू, कैन यू हेल्प मी इन रिकॉल? आपसे पूछा गया था ड्रग ऑफ चॉइस फॉर मेलिग्नेंट ग्लोकोमा। बेटा मेलिग्नेंट ग्लोकोमा क्यों होता है? सर्जरी के बाद होता है। कई बार हम लेंस और पीछे उसके ऊपर सीलियरी प्रोसेस डैमेज हो जाता है और पीछे विट्रस ह्यूमर में सामान जाना शुरू हो जाता है, एक्वस ह्यूमर। सो वुड यू, क्या आपको इनमें से बेटा बेस्ट मैनेजमेंट विल बी इंट्रालिपिड। बेस्ट पूछा है आपसे, फर्स्ट मैनेजमेंट नहीं पूछा। अगर आपसे फर्स्ट मैनेजमेंट पूछा होता तब आप रिसस्सिटेट करते। आपसे बेस्ट मैनेजमेंट पूछा है ना? नाउ मेलिग्नेंट ग्लोकोमा में बेटा ड्रग ऑफ चॉइस होते हैं साइक्लोप्लीजिक मिड्रियाटिक्स। ये ऑप्था का भी सवाल हो सकता है, एंड आई होप इट इज मोर ऑफ एन ऑप्थेल्मोलॉजी क्वेश्चन, बट ड्रग पूछा गया है, दैट इज व्हाई आई एम टेलिंग यू द ड्रग ऑफ चॉइस फॉर मेलिग्नेंट ग्लोकोमा। सबसे पहले हम देते हैं साइक्लोप्लीजिक मिड्रियाटिक, जिसमें 4 ड्रग होते हैं। क्या कोई बच्चा बता सकते हैं इन चारों में से कोई ड्रग आपके पास ऑप्शन में था? ACTH 4 ड्रग होते हैं साइक्लोप्लीजिक मिड्रियाटिक में। एट्रोपिन होता है, साइक्लोपेंटोलेट, ट्रोपिकामाइड एंड होमाट्रोपिन। क्या बेटा इनमें से कोई ऑप्शन में था आपके पास? एनी ऑप्शन आउट ऑफ दिस यू कैन टेल मी, एनी ऑप्शन यू गॉट फ्रॉम दिस मेलिग्नेंट ग्लोकोमा में? एनी ऑप्शन यू गॉट बेटा? Any option? Okay, if you're not, okay, you can't recall, don't worry. You can recall later on. I know there is a lot of burden right now. Pilocarpine nahi dete beta. There is a lot of burden on you. You must have gone through a lot. So this is the time to relax and chill. Don't worry. If you recall later on, you can message us on PW MedEd app on Telegram channel. So remember, बेटा अगर आप पाइलोकार्पिन मार्क करके आए हैं, पाइलोकार्पिन इज गिवन फॉर एक्यूट एंगल क्लोजर ग्लोकोमा, एसीजी, वो एंगल क्लोजर ग्लोकोमा में दिया जाता है। ठीक है, ठीक है, एंगल क्लोजर ग्लोकोमा में दिया जाता है। यहां पे सबसे पहले हम देते हैं साइक्लोप्लेजिक मिड्रियाटिक, या ऑप्था में पढ़ेंगे ऐसा क्यों। ठीक है, मैम विल टीच यू वेरी नाइसली, सुधा मैम विल टीच यू वेरी नाइसली। ओके, नाउ क्वेश्चन नंबर 12 पे आते हैं, देखते हैं कोई हमें और याद आ रहा है कि नहीं आ रहा। ओके, एनी अदर? बेटा कोई वेंट्रिकुलर टेकिकार्डिया के ड्रग्स पूछे थे? वेंट्रिकुलर टेकिकार्डिया का कोई ड्रग ऑफ चॉइस या क्या क्वेश्चन था? इफ यू कैन रिकॉल प्रॉपर्ली, कैन यू रिकॉल what was the exact question on drugs of ventricular tachycardia, if you can recall properly? And because beta, if I'll tell you, the drug of choice for ventricular tachycardia is amiodarone, but beta हम ventricular tachycardia में we give basically सोडियम चैनल ब्लॉकर। कोई भी ड्रग जो सोडियम चैनल ब्लॉकर होता है हार्ट में, हम वो वेंट्रिकुलर टेकिकार्डिया में दे सकते हैं। यस, आज की डेट में बेटा ड्रग ऑफ चॉइस है एमियोडारोन, बट यू कैन यूज अदर ड्रग्स आल्सो लाइक लिग्नोकेन। पहले लिग्नोकेन होता था पर अब एमियोडारोन बन चुका है, प्रोकेनामाइड। Okay, you couldn't recall, but if you recall, amiodarone was in the option. Yes. If you have marked amiodarone, मैं आपको ट्रिक्स बताता हूं कि अगर आपको कुछ भी समझ नहीं आता एरिथमिया में, तो मार्क कर दो आप एमियोडारोन, क्योंकि एमियोडारोन सब एरिथमियास में ड्रग ऑफ चॉइस बन चुका है। एक को छोड़ के क्यूटी प्रोलोंगेशन वाले को, टॉर्साइडिस डिपॉइंटिस को छोड़ के एमियोडारोन हर जगह पे ड्रग ऑफ चॉइस बन चुका है। यस, नाउ आई थिंक नाउ ध्रुव आरएफ यू आर एबल टू रिकॉल देम प्रॉपर्ली। सो राइट नाउ बेटा एट दिस मोमेंट आई एम एबल टू रिकॉल 12 क्वेश्चंस, बट सम स्टूडेंट्स वर सेइंग कि फार्मा थोड़ा सा इससे ज्यादा भी आया हुआ है। डोंट वरी, सिट रिलैक्स, वी हैव प्लेंटी ऑफ डेज। अगर आपको कोई रिकॉल आता है, यू कैन मैसेज मी डायरेक्टली, पीडब्ल्यू टेलीग्राम ग्रुप, and we will be very happy to answer and clear all of your doubts. Okay? अच्छा, PSVT का भी बेटा पूछा गया था। ओके, चलो एक 13 नंबर का क्वेश्चन ले लेते हैं। तो PSVT तो बेटा आपने बहुत अच्छे से पढ़ा भी होगा, पैरोक्सिस्मल सुप्रावेंट्रिकुलर टेकिकार्डिया। इसका बेटा इनिशियल ड्रग ऑफ चॉइस होता है IV एडिनोसिन। तो आपने ABC वर्ड याद रखना होता है इसमें। तो इसमें सबसे पहले हम देते हैं एडिनोसिन, और उसके बाद मेंटेन करते हैं पेशेंट को बीटा ब्लॉकर्स पे। पर एडिनोसिन और बीटा ब्लॉकर बेटा दोनों के दोनों कॉन्ट्राइंडिकेटेड होते हैं एस्थमा में, क्योंकि इनसे एस्थमा का अटैक प्रेसिपिटेट हो जाता है। इन दैट केस वी गिव कैल्शियम चैनल ब्लॉकर लाइक वेरापामिल और डिल्टियाजाम। आप वेरापामिल लिख लीजिए। सो दिस इज which was given. Okay, ECG was given, so don't worry, Santosh sir is there with you. He will be discussing the ECG of PSVT. Drugs part I have already discussed. Okay, so he will be very nicely teaching you the drugs. So at this moment, I'll hand over to the next subject and Santosh, back over to Santosh sir.
Thank you, sir, for a wonderful recall. I think pharmacology, sir had already made it easy through the YouTube session, and most of the questions you can relate to what he had covered in the YouTube sessions. So hopefully that has helped. Thank you, sir. I will take it forward from here. So guys, I guess that was very enlightening and helpful. And in fact, you remember in the YouTube sessions, I had told you that if now as a clinician, if a student or my PG students or residents call me, sir, there is a patient with palpitations, I have sent you an ECG. Can you look and tell me what to give? Nowadays, I don't really look at the ECG, because with sleepy eyes, I tell them give amiodarone, because amiodarone is a broad spectrum antiarrhythmic. पहले क्या होता था, we had specific antiarrhythmics as drugs of choice for specific situations, but now because amiodarone works in majority situations, right? I am a bit relaxed when I receive night calls of arrhythmias. Okay, so next up we have Dr. Sandeep, who will be taking us through the recalls from surgery. Dr. Sandeep, I guess I'm audible to you. Over to you.
Hi, sir. Good evening. Good evening. Thank you very much. Hi, guys. I hope the exam was not that difficult. It wasn't something that we weren't expecting. हर चीज के बारे में डिटेलली डिस्कशन हुआ था, हर एक बारे में हमने बात किया था. We did a rapid revision series also. Majority of the topics or the questions are from the same content. ठीक है. Now, before we dig down into the recall, I don't have the completely framed questions. I'm preparing a document which are roughly around 25 to 30 questions is what has been told. I've got around 20 questions or 20 broad topics. So we'll try to look across in the same context. Okay. About the exam, it wasn't something which was some out of the box or, like a bomb or something. 60 to 70% of the questions were from your previous year topics, which are picks put there across here. 15 to 20% of the topics were expected exam questions or important topics, which we cannot miss out. 5 to 10% are the bouncers, which are going to be expected. Now they played around with bit of the subjects, for example, microbiology, people have told that it have come tough this time. Pharma, there are more questions than usual. Medicine has been again challenged more into the core concepts rather than the route learning. So these are the things that we've been expecting, but then कुछ नया नहीं था. बाकी ठीक है, अभी मैं आपको ये सब बोलूंगा, you'll be like, सर एग्जाम था तो अभी कुछ याद नहीं है. वी आर एग्जाम लिखने के बाद ना हर स्टूडेंट का दिमाग नम हो जाता है. क्यों? क्योंकि आपने वो जो कंसंट्रेशन दिया है ना, that 3 hours, that is you've taken extensive amount of that concentration. एग्जाम देने में ना you've drained your brain down. उसके आगे पीछे कुछ बचा नहीं. ठीक है, तो अभी नम फील करना नॉर्मल है. एक और एडवाइस है, आज के बाद ना रिकॉल हो जाएगा, सबको पता चल जाएगा कि कितने पानी में या फिर क्या है क्या नहीं है. ऑल दैट यू हैव टू डू इज फ्रॉम टुमारो टिल योर रिजल्ट्स आर आउट, डू नॉट लुक बैक. ठीक है, आराम से एंजॉय करो, खाओ पियो, घर जाओ, मीट योर पेरेंट्स, स्टे विथ योर फ्रेंड्स, गो अराउंड, वॉच मूवीज. द अमेजिंग मूवीज दैट यू हैव टू वॉच. बहुत सारी मूवीज आई हैं लास्ट 6 महीने में, आराम से टाइम स्पेंड करो. ठीक है, मेक श्योर कि यू यूटिलाइज, दिस इज योर मी टाइम. ठीक है, ये सिर्फ आपका टाइम है, यू डिजर्व इट. You have worked every ounce of energy, blood, sweat that you have, you deserve to have on that context. ठीक है, चलो. So let's move on with the recall, the question that we had. The first question that I got is from the Fournier's gangrene. बहुत बच्चों ने बोला कि सर Fournier's gangrene का image आया था, तो quick feedback कि image ऐसा ही कुछ था. You have a scrotal image which was discolored. Quick feedback, guys. Was it something like this? Looking for your feedbacks, guys. Quick feedback. Anything? ठीक है. Now, Fournier's gangrene में हमने already discuss किया हुआ था. This was basically a synergistic gangrene where you have both aerobic as well as anaerobic bacteria. You will have both aerobic as well as anaerobic bacteria. It is also referred to as the necrotizing. It is also referred to as the necrotizing fasciitis of perineum. It is the necrotizing fasciitis of perineum. Okay, so it's an aerobic and anaerobic necrotizing fasciitis of perineum. Remember, testes are spared in these context. Testes are spared across here. It has got a rice watery discharge. It has got a rice watery discharge and a pungent foul smelling discharge. It's a pungent foul smelling. It is having a pungent and a foul smelling discharge that you'll see across here, right? Okay, so you have the aerobic anaerobic combination, necrotizing fasciitis of perineum, testes are spared, rice watery discharge, pungent foul smelling. Remember, these are the patients who are at risk, patients who are immunocompromised, specifically talking about diabetes, right? In terms of management, it is going to be debridement. And this debridement is going to be an extensive debridement with wound dressing, and then you move across here, right? So it is going to be diabetes is an important risk factor. The management is going to be debridement per se. So I'll be looking for the options if you can contribute. Otherwise, moving down to the next question. We had another question which says that a neonates with air bubbles in the left hemithorax, they've given the options as congenital diaphragmatic hernia, other components. If they're talking about left hemithorax with multiple air bubbles on birth, the baby is going to be present with congenital diaphragmatic hernia. Now, when you talk about, we have already discussed the congenital diaphragmatic hernia. Now, in congenital diaphragmatic hernia, you need to understand that we have two components. One is the Bosch-Talek hernia. Another one is the Morgagnian hernia. 90% of your congenital diaphragmatic hernias are Bosch-Talek. Only 10% of them are your Morgagnian hernias. 10% of them are your Morgagnian hernias. This is left-sided. This is right-sided. This arises on the posterior surface. This arises on the anterior surface. The most common component to herniate here is going to be stomach, whereas the most common component to herniate here is going to be transverse colon. Now, your Bosch-Talek hernia, presents to you with a classical triad, which is called as the RDS. R stands for, because of left-sided pulmonary hypoplasia, there'll be respiratory distress, which we have already discussed. Because the left side is occupied by that of the stomach, it will push the heart onto the other side. There'll be presence of dextrocardia. Along with dextrocardia, it will have that hollow abdomen or a boat-shaped abdomen that is called as the scaphoid abdomen. Important points that you all know. That bag and mask ventilation is contraindicated because when you ventilate it, it will cause barotrauma to the lungs, overinflation of the stomach, and cause excessive distension, which will be more traumatic, right? Apart from that, these patients, they have to be taken up for immediate surgery for decompression. But even on that, the prognosis is really, really bad, right? So this is about your congenital diaphragmatic hernia. Okay. Now, another question that came into picture is about your proximal esophageal herniation. If it is herniating directly into the thorax, right? This is what we call as hiatal hernia. And this variety is what we call it as the sliding hiatal hernia. Now, remember, sliding hiatal hernia may or may not be because of GERD, but every patient of sliding hiatal hernia will present to you with GERD, right? The investigation of choice for hiatus hernia is going to be your barium swallow. It is not CT, it is barium swallow, right? Management is to bring back the content, or basically you have to pull it down, do a fundoplication and repair the defect. That is for your proximal esophageal herniation. The complications of ERCP, that is your endoscopic retrograde cholangiopancreatography. I've gotten 4 options: duodenal perforation, cholangitis, hemorrhage, pancreatitis. All of them are the complications of ERCP. So I would want more input on this, right? Any inputs? Yes. If they're asking you more specific, remember 15% of the patient who undergoes ERCP lands up with pancreatitis, right? They'll end up with pancreatitis. So that's a known complication. Cholangitis is also a known complication. Hemorrhage is also a known complication. Duodenal perforation is also a known complication. Okay? So it should be all except the option has to be somewhat varied. I'll be expecting the option. Let's look into the same context. Now, we spoke about refeeding syndrome. That was a question: which electron imbalance is not seen? So when you talk about refeeding syndrome, this is usually seen for a patient who is, being given massive amounts of TPN, for patients who have been at prolonged fasting. Now, in prolonged fasting state, a patient who's been for prolonged fasting state, what is going to happen? In a prolonged fasting state, obviously the sugar input, that is the carbohydrates input, is less, the sugar is going to be, or sugar intake is less. Because of less intake of sugar, the insulin is going to be less, right? Insulin produces less. Now, we say this patient is being given TPN, that is total parenteral nutrition, and the maximum composition of the TPN is carbohydrates. So there is sudden surge of sugar. Now, in response to the sudden surge of sugar, there will be sudden increase in insulin, and this increase in insulin is overwhelming increase in its normal component. Now, because there is an excessive amount of insulin that is going to draw in, and insulin is an anabolic hormone, so what is going to do? It is going to push, it is going to activate the sodium potassium ATPase pump, push the potassium back into the cell. So there will be decrease in potassium, that is hypokalemia. The cofactors is magnesium as well as phosphate. So hypomagnesemia as well as hypophosphatemia is noticed. Along with that, you will also notice thiamine deficiency. It's also a cofactor. So thiamine deficiency is also noticed. So hypokalemia, hypomagnesemia, hypophosphatemia with thiamine deficiency is what you see as your refeeding syndrome component, right? So if they ask you all of except look for these three, if these are present, then this cannot be the answer. Anything else in this should be your answer, right? So that is in terms of a refeeding syndrome. Now they asked you MEN1 syndrome. Again, I think which among the following does not belong to MEN1 should be the question, or all except is the composition. So we have the multiple endocrine neoplasia MEN1. I've been telling you in my class that everything starts with P here, starts from the top, that is your pituitary adenoma. That is your pituitary adenoma. If it is associated with pituitary, then you have parathyroid adenoma. You have the parathyroid adenoma and pancreatic adenoma, right? I think the option had medullary cancer thyroid, which does not belong to MEN1 syndrome, which does not belong to MEN1. So these are the components that you will see in MEN1 syndrome, right? Now, if I expand this to MEN2, in MEN2, you will not have pituitary adenoma, but you will have, number one, your parathyroid adenoma. You will have parathyroid adenoma. It is associated with pheochromocytoma. Pheochromocytoma and medullary cancer thyroid. Then we have the MEN3 syndrome. MEN3, you don't have parathyroid adenoma, but you will have pheochromocytoma. You have the pheochromocytoma, medullary cancer thyroid, morphinoid habitus, and mucosal neuromas, right? Mucosal neuromas. Then you have MEN4. It is MEN1 with reproductive organ tumors. It is MEN1 with reproductive organ tumors. It is your reproductive organ tumors. Okay? Sure. So if the pheochromocytoma is in the option, then the answer will be pheochromocytoma, right? Now, question number 7, the seventh question that we have, all of the following structures are preserved in modified radical neck dissection except, right? Now, when you talk about the modified radical MR, these are your modified radical neck dissections. So if you quickly take across on the neck dissection, we have something called as the radical neck dissection. And to counter that, you have the modified radical neck dissection. One is radical, another is modified radical neck dissection. In radical, I'll be removing level 1 to level 5 group of lymph nodes. In modified also, I will remove level 1 to level 5 group of lymph nodes. Along with that, I will remove spinal axillary nerve. I will remove the sternocleidomastoid muscle. The sternocleidomastoid muscle and the internal jugular vein. Whereas in modified radical neck dissection, if it is type 1, I will preserve spinal axillary nerve. If it is type 2, I'll preserve spinal axillary nerve as well as internal jugular vein. If it is type 3, I will preserve all three, that is spinal axillary nerve, internal jugular vein, and the sternocleidomastoid muscle, right? So all three can be preserved in your modified radical neck dissection. Okay. Chalo. So based upon that, you should have answered the right answer. Now, question number 8 that we have. I have a 35-year-old lady with a mastectomy done for 10 centimeter margin resection. 10 years, she developed lymphedema. What could be the possible diagnosis? Now, if you remember, I told you very specifically in my classes also that whenever you do a modified radical mastectomy, whenever you're taking the patient for MRM, we have early and a late complication. You have an early post-operative complication and you have a late post-operative complication. We have early or a late post-operative complication. Now, in an early complication, we all remember, I told you a mnemonic to remember the component that is called as SWAB. S stands for seroma formation. S stands for seroma formation. W stands for winging of scapula. That is because of damage to the long thoracic nerve. A stands for upper limb edema, that is arm edema. And B stands for blackening, that is your flap necrosis. In late, we have a complication that is called as the Stewart-Travis syndrome. Now, what is this Stewart-Travis syndrome? It occurs usually 5 to 10 years after MRM. So, if the patient has undergone a modified radical mastectomy, after 5 to 10 years of MRM, patient will present to you with lymphedema of the upper limb. Now, this lymphedema is not a usual lymphedema. This is basically a lymphangiosarcoma. This is basically a lymphangiosarcoma of the upper limb. This is the lymphangiosarcoma of the upper limb, and this is what we call it as the Stewart-Travis syndrome. This is what we call it as the Stewart-Travis syndrome, right? So these are the components for your modified radical neck dissection as well as your breast cancer. Okay. Triage, I think they asked you in terms of order of preference, which color code. Red has to be given highest preference. Then you have yellow, which is second in preference. Then you have the green, which is the orphan child of casualty. And black is least important because it is moribund. This is the order of preference. So I think you would have gotten it correct, right? You would have gotten it correct. Clear? Sure. Now, question number 10, they've given an image, which is something like this, which is your subdural hemorrhage. I hope you're able to get this pretty easy. You can see this would be something like this, right? You can see it would be something like this, right? This is your subdural hemorrhage. Now, if they ask you in subdural hemorrhage, important points is what is the most common source of bleed? The most common source is going to be your cortical bridging veins. It is your cortical bridging veins, right? Whereas for extradural hemorrhage, it is going to be the middle meningeal artery. Here it is your cortical bridging veins. The type of opacity, they can ask you concave or convex or crescent shape opacity. It is a small bleed. It expands on a gradual process. It can result in raised intracranial pressure components. If it is extensive, you have to go with craniotomy. Those are the components that you have to remember. Dysphagia more for solids when compared to liquids with other features as to esophageal cancer. They ask you what is the investigation of choice. The answer is going to be upper GI endoscopy with biopsy. That is for diagnosis. Now, if they ask you for the T staging, then it is your endoscopic ultrasound. If they ask you for METs, then it is going to be CT of the thorax. If they ask you for distant METs, it is going to be PET CT. It is going to be a PET CT, right? Sure. Hydrated cyst, they have asked you a question on management. I don't have the options intact right now. When you talk about the hydrated cyst, the surgical management is going to be pair therapy. The pair is going to be your puncture aspiration of the hydrated fluid with installation of scolicide agents and reaspiration. If they ask you for prophylaxis of hydrated cyst, then it is going to be albendazole. If it is not available, then you go with mebendazole. That is the objective here. Now, in hydrated cyst, remember the causative organism is going to be echinococcus granulosis. The mode of infestation is by eating an improperly cooked meat infested with echinococcus granulosis. As simple as that. Okay? Chalo. There was a question on omphalocele. They gave you an image where a baby was there and there was a membrane, and there was within the membrane there was bowel component, right? If membrane and bowel components are there, it is going to be omphalocele. Without the membrane, right-sided defect, and the bowel component is outside, it is going to be your gastrocesis. They've given you about the Boyd's classification, that is for intermittent claudication in your peripheral vascular disease. Now, Boyd's is going to be in phase wise. I don't think they've asked you the phases of or the grades of Boyd's. They've simply asked you the Boyd's classification is for. It is for intermittent claudication, right? Extrahepatic biliary atresia, they've asked you the age of presentation. It is usually within the first week of life, right? That is your extrahepatic biliary atresia. If it is untreated for 3 years, it will result in 100% mortality. We have the types of it. We know the surgery. It is, see, the investigation of choice for your biliary atresias is going to be your HIDA scans. Ultrasound is the first one. HIDA is going to be one of the most prominent diagnoses that you will do. Okay. MRCP is more sensitive across here. So remember, are the 3 components: ultrasound, MRCP, HIDA, right? The surgery we do, Kasai's procedure, that is one thing that you remember. Hasselbalch's triangle, I think they've asked you the boundaries. Hasselbalch's triangle, the medial boundary is going to be lateral border of the rectus abdominis, inferiorly by inguinal canal, and laterally by your inferior epigastric artery. That is a Hasselbalch's triangle. That is the most common site for your direct inguinal hernia to pop out into the component. Maximum graft versus host, this is we've seen in which type of transplant. It is going to be your bowel transplant. The small intestinal bowel transplant has the maximum graft versus host disease, right? Shock wave blast injury, if they have asked you, most common tympanic membrane, most severe is going to be lungs. If you are inside the water and submerged in the water, head is out, head is in. If head is out, most common and most severe, most common and most severe in terms is going to be bowel. But if a head is submerged, most common is going to be bowel, most severe, most common is going to be tympanic membrane, most severe is going to be bowel if the head is also submerged inside the water. Okay. Urethral injury, I think they gave you an image. If the injury, there will be this urethral component, this is the bladder you see, and there will be this U-turn, this is a loop that is present, right? If the injury is from this loop, it is your bulbar urethral injury. If the leak is above this, it is going to be your membranous urethral injury. If the leak is from this hunch, it is going to be a bulbar urethral injuries, right? So these were the topics that I've gotten. We'll try to reconstruct the whole topic list again with the options as well. If I'm able to get through, I'll put up in our PW MedEd channel as well as on the Instagram. Or we have on the Telegram groups as well. And please reach out with the options that we have. We'll try to construct it more component question, because the question per se is not difficult. It is the option that decides the level of difficulty that we have challenged, right? So this was the instant recall that I could actually collect it from you guys. I would really appreciate if you can send more, because I heard there are 25 to 30 questions. I've compiled 19 and those are topics, right? So with this, I conclude my recall session. If you have any topic list or any questions, please feel to reach out. Anything else, we are always there for you guys. All the best. You have done the best you could. So stay happy, right? Over to you, Santosh sir.
Thank you, Dr. Sandeep, for a wonderful recall. So guys, I hope that has solved some of the confusions or doubts you had on some tricky questions. So next up, we have Dr. Mamta Java. Dr. Sandeep will be dropping off now, and then Dr. Mamta Java will connect in place of Dr. Sandeep. She will take us through the MCQs from microbiology. She is our esteemed microbiology faculty. Dr. Mamta, am I audible to you?
Good evening, sir. Good evening, everyone.
Over to you, ma'am.
Thank you, sir.
You're live, ma'am.
Okay. Hi, everyone. A very good evening. So, starting with the very first question of today's exam. The question was something like this. A patient got bitten by a mite and presented with fever and a body rash along with an eschar, what's the likely diagnosis? Now, I could gather only one option in this question, which is scrub typhus. This was kind of a very, expected question. By the way, all the questions which I'm going to discuss today, you won't be surprised at all to see that all of them are expected questions asked from the commonly asked topics only. There was luckily no bouncer at all. So the option which I got in this question was scrub typhus, which by the way is the right answer. B, C, D options could not be recalled. Will be very, very thankful and grateful if you could please chip in with your options. Okay, guys, so scrub typhus, you all know it's the most common rickettsial disease in our country in India. So it's a very, very important topic to be done for exams, and not just for exams. As medicos, you should be really, really familiar with this very, very important topic caused by the organism Orientia susugamushi. T is silent. The organism's name is Orientia susugamushi. It was previously classified under Rickettsia, but now it has been found to be genetically quite different from the other rickettsial species. So it has been given a special status in the sense that it has been separated from the other rickettsial species. And that's one important reason. And also remember, it lacks the LPS layer. It lacks the lipopolysaccharide layer. So that is what makes this organism pretty unique. Now, the question mentions about a patient being bitten by a mite. Now, remember the vector of this disease. Remember, all rickettsial diseases are zoonotic diseases. The important exception being the epidemic typhus, which is not a zoonotic disease. The reservoir of epidemic typhus are human beings. ठीक है, इसको और क्या बोलते हैं? इसको जेल फीवर भी बोलते हैं. The vector is human body louse or Pediculus humanus corporis, and as the name suggests, it is Pediculus humanus corporis. So ये किसको target करेगी? सिर्फ human beings को, and that is why this disease, epidemic typhus, is an exceptional rickettsial disease in the sense that it is not a zoonotic disease. ठीक है, अब इसका जो vector होता है, the vector is not the mite per se, but the larvae of the mite, which are known as chiggers. ये एक image based question पहले भी आया हुआ है. ठीक है, the larvae are known as chiggers, and it is the chiggers actually which are the vectors per se, and that is why the disease it is also known as chiggerosis. ठीक है, be familiar with this picture. This exact picture has been asked in previous exams also, and this is how the scrub typhus eschar looks like. By the way, the classical triad, if we talk about the classical triad of this disease, remember it is MER. M से है maculopapular rash, जो question में दे ही रखा है. E से eschar, जो भी हम देख रहे हैं. ठीक है, MEL actually. Then L stands for lymphadenopathy or LNpathy. लेकिन ये जो classical triad है, that is seen only in 40 to 50% of the cases and not all the cases. And what else you need to know about this disease is what is known as zoonotic tetrad. I have put up a picture of scrubby or bushy vegetation. So basically, remember, if we talk about this tetrad मतलब चार चीजें आपको याद करनी है. ठीक है, तो एक तो हो गया हमारा mite. Number one is mite, which are the vectors. ठीक है, the trombiculate mite. Now talking about these mites. These mites lay eggs in rainy season, that is the wet season. तो दूसरा point हम याद करेंगे mite को ही ध्यान में रखकर कि mites lay eggs in rainy season और wet season. तो ये second component हो गया. तीसरा component जो हम यहाँ पे देख रहे हैं, scrubby या bushy vegetation, which is very conducive habitat for the reservoirs of this disease, that is the rodents. So scrubby vegetation हो गई. ठीक है, and fourthly the rodents or the field mice and similar small mammals which are going to serve as the reservoirs of this disease. Right, so this was the very first question. If anyone could please chip in the options. Akib Altaf, Rocky Mountain spotted fever क्या इसी question में दूसरा option था? Are you talking about this question only? Yes, Arif, Nipah virus ka question I have added. Will be extremely grateful, guys, if you could please help me with these options whenever you recall them. You can DM me on Instagram. ठीक है. And then there is something called as Susu-Gamushi triangle. इस पे अभी तक आया तो नहीं है question, but as I said, this is the most common rickettsial disease in our country. तो ये topic आपको अच्छे से पता होना चाहिए. तो this triangle basically spans in the west up till Pakistan and Afghanistan, south में northern Australia, and east में northern Japan up to far eastern Russia. तो ये सारे hotspots हैं of this very disease. चलो second question पे आते हैं. Amsel's criteria for bacterial vaginosis: white homogeneous vaginal discharge, vaginal pH more than 4.5, positive with amine test, all of above. Now, I could not exactly gather the options, but it was sure that there was a question on the Amsel's criteria. तो तीन क्राइटेरिया, तो बेसिकली ना 4 क्राइटेरिया होते हैं, तो 3 तो हमने यहाँ पे दे ही रखे हैं. चौथा criteria is this, that is the clue cells. What are clue cells? These are the vaginal epithelial cells which are studded or decorated with the bacteria. Bacterial vaginosis, you all know, it is not an infection. It is basically an alteration in the vaginal flora, whereby we get an increase in the number of certain bacteria, like for example, Gardnerella vaginalis. ठीक है. अब इस पे एक और क्वेश्चन आता है कि भाई दिस इज ऑल्सो एन एग्जाम्पल ऑफ एन ऑर्गेनिज्म विच शोज मेटाक्रोमैटिक ग्रैन्यूल्स. जनरली जब हम मेटाक्रोमैटिक ग्रैन्यूल्स का नाम लेते हैं या सुनते हैं, हमारे माइंड में क्या आता है? सीडी, दैट इज कॉलोनीबैक्टीरियम डिप्थीरिया. दिस इज अनदर एग्जाम्पल ऑफ एन ऑर्गेनिज्म विच शोज दीज ग्रैन्यूल्स. सो ऑल्टरेशन क्या रहती है? There's going to be an increase in the number of Gardnerella vaginalis in this condition, which otherwise are found in low number in the vagina. Apart from this, एक तो ये हो गया, दूसरा हो गया, remember mobile uncus. Thirdly, several other anaerobes, like for example, Prevotella and some species of Peptostreptococcus. ठीक है. Then चौथा Mycoplasma hominis. Mycoplasma hominis. तो इन सबका नंबर बढ़ जाता है. And कम किसका होगा? There is going to be a decrease in the number of Doderline bacilli, that is lactobacilli, which are endowed with the responsibility of maintaining an acidic pH in the vagina. ठीक है. तो ये चीजें आपको याद रखनी है बैक्टीरियल वैजाइनोसिस के बारे में. और क्या यहाँ पे इंपॉर्टेंट है, इसका ड्रग ऑफ चॉइस याद रखना है. ओरल मेट्रोनिडाजोल होता है. ठीक है. 500 mg BD फॉर 7 days. अभी इससे रिलेटेड एक और क्वेश्चन है आगे कि इन विच ऑफ द फॉलोइंग कंडीशंस बोथ द पार्टनर्स नीड नॉट बी ट्रीटेड. तो उसमें एक ऑप्शन बैक्टीरियल वैजाइनोसिस भी था, जो कि आंसर नहीं है. मतलब बोथ पार्टनर्स, आई मीन ओनली द फीमेल हैज टू बी ट्रीटेड. ठीक है. Any inputs on the option? Is this question framed correctly or not? All right, RF, yeah, we will come to that question. चलो आगे बढ़ते हैं. Which plasmodium species affects the brain? Now, no points for guessing. अब यहाँ पे हम क्या मार्क करेंगे? See, Falciparum vivax, malariae, ovale are the important species for causing the disease malaria. ठीक है. अब देखो, F से Falciparum, F मतलब फेटल, मतलब सबसे खतरनाक मलेरिया यही करता है. एंड वन इंपॉर्टेंट कॉम्प्लिकेशन ऑफ प्लास्मोडियम फैल्सिपैरम मलेरिया इज सेरेब्रल मलेरिया. सेरेब्रल मलेरिया जो कि कैसे होता है? इट अकर्स बिकॉज ऑफ प्लगिंग ऑफ द ब्रेन कैपिलरीज, बिकॉज ऑफ द आरबीसीज जिनके अंदर पैरासाइट्स छिपे हुए हैं. तो बेसिकली देयर इज गोइंग टू बी सीक्वेस्ट्रेशन ऑफ द पैरासाइट्स in the cerebral blood vessels, which in turn is going to lead to vascular occlusion and therefore cerebral anoxia. ठीक है. तो basically ऐसे patients को क्या होगा? There is going to be a diffuse symmetric encephalopathy in these patients, a horrific complication of cerebral malaria, and generalized seizures are encountered in up to 10% of the adults and 50%, 50% kids. ठीक है. This is very, very important. And also remember, amongst all these species, Plasmodium falciparum किसी भी तरह के RBCs को spare नहीं करता. It affects all the stages and ages of RBCs. More than 2% of RBCs are infected, and that itself is a reason why it causes, very severe malaria. ठीक है. एक और species होता है, 5th species, Plasmodium knowlesi, जिसके बारे में वैसे भी we know less. It's said to be a species which infects the monkeys, लेकिन कुछ cases Asia से reported हैं. So this was the third question. I hope this question has been framed correctly. Anyone begs to differ, please correct me. अच्छा, बाय द वे यहाँ पे एक और चीज हमें याद रखनी है प्लाज्मोडियम के बारे में. रिमेंबर, बीपीटी और बैचलर ऑफ फिजियोथेरेपी, दीज आर द थ्री. बी से है बबेसिया, पी से है प्लाज्मोडियम. बोथ ऑफ दीज आर कजन ब्रदर्स और सिस्टर्स, कुछ भी बोल दो. बोथ ऑफ दीज आर इंट्रा इराइथ्रोसिटिक प्रोटोजोन्स, प्रोटोजोआ और पैरासाइट्स. टी से है हमारा टॉक्सो प्लाज्मा गोंडाई. अब ये तीनों बीपीटी से हमें क्यों याद करने हैं? बिकॉज दीज आर द थ्री एग्जांपल्स ऑफ प्रोटोजोआ विच आर नॉन मोटाइल. एनएम प्रोटोजोआ, जनरली प्रोटोजोआ क्या होते हैं? मोटाइल होते हैं. इनफैक्ट उसी के आधार पर, मतलब ऑर्गन ऑफ लोकोमोशन के आधार पर हम प्रोटोजोआ को क्लासिफाई करते हैं. तो प्लीज रिमेंबर दीज आर द थ्री सिग्निफिकेंट एग्जांपल्स ऑफ non-motile protozoa. चलो, moving on. चौथा question, an HIV positive patient presented with neck rigidity. Now I'm doubtful in this. Many students have recalled that neck rigidity was mentioned in this question, and thereafter the question went on to mention about negative staining with India ink being positive. But generally ना, ये पता ही आपको कि by the way, answer is Cryptococcus neoformans, क्योंकि HIV positive patient में most common cause of meningitis is Cryptococcus neoformans. But usually neck rigidity बहुत less common रहती है. The most common presentation of the patient in such cases is headache, chronic headache. तो अगर कोई पेशेंट कहता है कि मुझे बहुत दिन से सर में दर्द है और उसका HIV स्टेटस आपको पता है कि HIV पॉजिटिव है, ये द वेरी फर्स्ट thing which should come to your mind is infection with Cryptococcus neoformans, which is an example of an encapsulated yeast. It's a true yeast. It's a pathogenic yeast with a PS capsule, polysaccharide capsule. It's an example of a fungus which is urease positive. And इसके context में एक और buzzword है Maltese cross appearance. Maltese cross appearance, which refers to the arrangement of its capsular material seen under polarizing microscope. माल्टीज क्रॉस अपीयरेंस जब हम बोलते हैं, जनरली हमारे माइंड में एक और चीज आनी चाहिए, दैट इज बबेसिया, जो भी मैंने ऊपर बताया कि इट्स एन एग्जांपल ऑफ अ नॉन मोटाइल प्रोटोजोआ. ठीक है, तो ये तो प्रीटी सिंपल क्वेश्चन था. नाउ आई हैव पुट अप दिस पिक्चर. Look at this. So India ink is an example of a negative stain. So is nigrosin. These are negative stains. मतलब कि जो चीज तुम्हें देखनी है उसको वो कलर नहीं पकड़ेगी, बैकग्राउंड कलर ले लेगा. तो बेसिकली द बैकग्राउंड is going to take up a dark color. So a good contrast is going to be created. So this is how the India ink preparation of Cryptococcus neoformans looks like, and the arrow is pointed towards a budding yeast of Cryptococcus neoformans. And जो आप halo देख रहे हो around all these circles, those halos are representative of the polysaccharide capsule. ठीक है, very very important. So Cryptococcus neoformans, remember, is the most common cause of meningitis in immunocompromised patients like HIV patients. ठीक है. Now guys, next question. Now if someone could please help me complete the stem of this question and the options also. So all I could get was there was some patient from Kerala and some contact with palm tree, and options में एक option था Nipah virus. So I think अधिकतर लोग बस यही देखकर उन्होंने निपाह वायरस मार्क किया, which by the way is right, but I will appreciate अगर कोई और ऑप्शंस भी इसके रिकॉल कर दे इस क्वेश्चन के. एनीवन? सो बेसिकली ना, अब देखो निपाह वायरस की अगर बात करें तो निपाह को हम यूजुअली इसका नाम अकेले नहीं लेते हैं, हम इसको साथ में पढ़ते हैं. निपाह एंड हेंड्रा, ये दो अलग अलग वायरसेस हैं. And these are examples of zoonotic paramyxoviruses. ठीक है, zoonotic paramyxoviruses. Paramyxoviruses are examples of RNA viruses. ठीक है, अब देखो पैरा से याद रख लो बड़ा. पैरा के बहुत सारे मीनिंग्स हो सकते हैं. एक मीनिंग होता है बड़ा या बिग इन साइज. मिक्सो से सोच लो मिक्सिंग. तो बेसिकली पैरामिक्सोवायरसेस का एक इंपॉर्टेंट सीपीई या साइटोपैथिक इफेक्ट होता है कि वो सेल्स को मिक्स करवाते हैं, मतलब सेल्स को ज्वाइन करवाकर बड़े बड़े सेल्स बनवाएंगे इन द फॉर्म ऑफ विच आर नोन एज जायंट MNG, मतलब जायंट मल्टी न्यूक्लिएटेड जायंट सेल्स. दिस इज एन इंपॉर्टेंट cytopathic effect. So this is a very important fact about these viruses. Now coming to Nipah and Hendra viruses, which are zoonotic paramyxoviruses, these are important causative agents of encephalitis. और इनके जो natural reservoir होते हैं, they are fruit bats, ठीक है, और flying foxes. इनके reservoirs या फिर natural hosts होते हैं. Now talking about देखो Nipah virus, Now Nipah virus transmit कैसे होता है to humans? It is transmitted to us, that is humans, via direct contact with the infected reservoirs, जैसे कि fruit bats, pigs और people, that is human being. और it is also, देखो क्वेश्चन में ना palm tree का कुछ ऐसे मेंशन था, एग्जैक्ट लैंग्वेज आई कुड नॉट गेट, बट जो फ्रेश डेट होता है ना, उसका जो फ्रेश डेट पाम सैप जो यूजुअली कलेक्ट करते हैं, लाइक बांग्लादेश में काफी कॉमन प्रैक्टिस है, तो दैट सैप इज फाउंड टू बी समटाइम्स इन्फेक्टेड विद दिस वायरस, क्योंकि फ्रूट बैट्स आर नोन टू लिक दैट सैप की स्ट्रीम, या कभी कभी फ्रूट बैट्स वहां पे ना उस पेड़ के ऊपर यूरिनेटेड डेफिकेट भी कर देते हैं, एंड फ्रूट बैट्स आर द reservoirs, and that is why so that is why this sap coming in contact with this infected sap also is an important method of getting infected. ठीक है, तो ये मोड ऑफ इन्फेक्शन तो इसका ये हो गया. नाउ जस्ट लिटिल बिट अबाउट दिस वायरस. इंक्यूबेशन पीरियड इसका रहेगा 4 से 14 दिन. ठीक है, दोनों वायरसेस निपा और हेंड्रा करते हैं एनकेफेलाइटिस, जिसमें पेशेंट को क्या होगा, फीवर, हेडेक, मायाल्जिया एंड सीएनएस सिम्टम्स रहेंगे, डिजीनेस, ड्राउजीनेस, ठीक है, सीजर्स, एंड सीवियर केसेस में द पेशेंट कैन लैंड अप इन कोमा विद इन 48 आवर्स एंड डेथ भी हो सकती है. तो बेसिकली रिमेंबर, डायग्नोसिस के लिए जो गोल्ड स्टैंडर्ड होता है हमारा, दैट इज नथिंग बट द रियल टाइम पीसीआर. और इसके लिए सैंपल्स आप क्या कलेक्ट कर सकते हो? यू कैन कलेक्ट थ्रोट एंड नेजल स्वैब्स, you can collect CSF sample और urine and blood. लेकिन ये सारी चीजें ये सारे samples should be collected in the early stage of the disease. तो ये तो gold standard हो गया. इसके अलावा later stage में diagnose करने के लिए antibody detection comes to our rescue with the help of ELISA. And remember, कोई antiviral drug available नहीं है इन दोनों के against. अगर हम वैक्सीन की बात करें, देयर इज अ सब यूनिट वैक्सीन अवेलेबल, अगेंस्ट फॉर द हेंड्रा वायरस विच यूजेस द हेंड्रा जी प्रोटीन. एंड इस वैक्सीन की खास बात यह है कि इट ऑल्सो प्रोड्यूसेस क्रॉस रिएक्टिव एंटीबॉडीज अगेंस्ट द निपा वायरस ऑल्सो. ठीक है, सो गाइज दैट्स अबाउट दिस क्वेश्चन. एनी इनपुट्स अबाउट द ऑप्शंस? एनीवन? All right, next question. Both partners should be treated in bacterial vaginosis. नहीं, ये मैंने अभी ऊपर बता दिया था. Trichomoniasis, yes. देखो, trichomoniasis के केस में a single 2 gram oral dose of metronidazole is effective. ठीक है. कैंडिडियासिस और हर्पीस में भी दोनों पार्टनर्स को ट्रीट नहीं करते हैं. अब देखो, जेनाइटल हर्पीस की अगर हम बात करें ना, जेनाइटल हर्पीस के लिए we give oral acyclovir for a duration of 7 से 14 दिन, मतलब 1 से 2 हफ्ते. इंट्रावीनस एसाइक्लोवीर दी जा सकती है फॉर सीवियर डिजीज और इफ देयर आर एसोसिएटेड न्यूरोलॉजिकल कॉम्प्लिकेशंस. ठीक है. एंड जो वजाइनल कैंडिडियासिस है, जो यूजुअली डायबिटिक फीमेल्स में देखा जाता है, एंड रिमेंबर वजाइनल कैंडिडियासिस में एक और इंपॉर्टेंट क्वेश्चन क्या पूछते हैं कि यहाँ पे ना वजाइनल पीएच इज अनऑल्टर्ड, मतलब कि इट रिमेन्स द पीएच रिमेन्स लेस देन 4.5, मतलब इट रिमेन्स एसिडिक. ठीक है. एंड यहाँ पे भी देयरफॉर देयर इज नेगेटिव विफ अमीन टेस्ट. ठीक है. अब वजाइनल कैंडिडियासिस के केस में जो प्राइमरी ट्रीटमेंट होता है, दैट इज ओरल फ्लूकोनाजोल और इट्राकोनाजोल. ठीक है, फॉर 1 डे. टॉपिकल ट्रीटमेंट, टॉपिकल क्रीम ऑफ क्लोट्रामाजोल भी दे सकते हैं माइल्डर केसेस. ठीक है, तो हमारा आंसर यहाँ पे है बी. और ट्राइकोमोनियासिस कॉज्ड बाय व्हाट? ट्राइकोमोनास वजाइनालिस. इसका एक एफएमजी का एक बहुत फेमस क्वेश्चन है ट्राइकोमोनियासिस के ऊपर, ट्राइकोमोनास वजाइनालिस के ऊपर, कि इसमें ओनली टी दैट इज ट्रोफोजोइट स्टेज अलोन इज सीन, देयर इज नो सिस्ट स्टेज, नो सिस्ट. और इसकी जो ट्रोफोजोइट होता है दैट शोज ट्विचिंग मोटिलिटी, ट्विचिंग ऑल्सो नोन एज जर्की मोटिलिटी और वॉबलिंग मोटिलिटी. ठीक है. All right. Next question. Reservoir of Kala Azar. Humans, pig, cattle. One option was not recalled. Any inputs on the option in this question? Anyone? Anyone, guys? Chalo, never mind. So Kala Azar is an internationally accepted term. It is nothing but visceral leishmaniasis. Okay? Visceral leishmaniasis caused by leishmania donovani. जब हम जनरली लीशमेनियासिस के बारे में बोलते हैं we count it as or include it as a zoonotic disease. तो ये basically zoonotic disease है. Mainly a zoonotic disease ये होता है, and it has got it affects whom? It has got a lot of animal reservoirs और वो affect भी होते हैं, like you know, dogs, foxes, jackals and rodents. ठीक है, और ये सारे animal reservoirs play an important role in transmission of several species of leishmania, but exceptionally जो Indian exception देखी जाती है Indian subcontinent में, where it is anthropophilic. India में, हमारे देश में humans are the only reservoirs, so India में it is anthropophilic. This species leishmania donovani, so सिर्फ humans are going to be affected. तो reservoir हम क्या mark करेंगे? Humans इस question में. ठीक है. And this organism leishmania donovani, you know, इसके दो important morphological forms हैं, इन पे भी question आते हैं, the amastigote form and the promastigote form. तो देखो अभी तक जितने भी question हमने discuss करे हैं ना, वो सारे के सारे ऐसे नहीं कि कोई out of the world questions हैं, सारे के सारे expected questions हैं. तो topics तो वही हैं, बस घुमा फिरा के भी मैं नहीं बोलूंगी, तो basically you know common questions हैं, कुछ ऐसे touchwood bouncer नहीं आया इस बार. अब let me just highlight MASTI. It doesn't mean the हिंदी वाली मस्ती और fun. It actually refers to flagella. तो जब हम बोलते हैं amastigote form, A मतलब without, तो amastigote forms जो होते हैं they are found in human beings. ठीक है, human beings, they affect the reticuloendothelial system, that is the macrophages and also the endothelial cells as well. ठीक है. And the promastigote form जो होता है वो पाया जाता है sandfly में, which is the vector. Now this is how the sandfly looks like. और ये again एक image based question आ रखा है, तो मैंने ये image लगा दी है यहाँ पर. ठीक है, तो sandfly और remember phlebotomus, ये इसका scientific name है. So this was a pretty easy question as well. आगे बढ़ते हैं. Now I'm not really sure of this question about hydatid cyst. इस पे एग्जैक्टली क्या क्वेश्चन था? अगर इस पे एक ही क्वेश्चन था ट्रीटमेंट पे, तो वो ऑलरेडी सर्जरी में कवर हो चुका है. नहीं प्रतीक, आई डोंट थिंक ऐसी ये बाउंसर अभी तक तो कोई भी नहीं है. बाउंसर देखो, ये सारे क्वेश्चंस अगर आप प्रीवियस ईयर क्वेश्चंस भी करोगे ना, प्रीवियस ईयर टॉपिक्स, तो ये सब कुछ है, कवर्ड है. ठीक है, तो चलो गाइस अगला क्वेश्चन. इस पे इफ यू कुड प्लीज हेल्प मी नो कि इस पे एग्जैक्टली क्या क्वेश्चन था. सिर्फ एक ही क्वेश्चन था ट्रीटमेंट पे, जो बाय द वे सर्जरी में ऑलरेडी कवर्ड है, अभी संदीप सर ने अभी कवर करा है. ठीक है, तो या तो व्हाट आई कुड गैदर वाज कि अ पेशेंट वाज डायग्नोज्ड टू हैव लिवर सिस्ट ऑन इमेजिंग एंड ऑन क्वेश्चनिंग रिवील्ड हिस्ट्री ऑफ कॉन्टैक्ट विद डॉग. व्हाट कैन बी द लाइकली कॉज? वाज दिस एनी क्वेश्चन? अच्छा, ओके प्रदीप, यू आर सेइंग सो देयर वर टू सेपरेट क्वेश्चंस ऑन एकाइनोकोकस. एक तो ट्रीट, अच्छा मतलब दो अलग अलग क्वेश्चंस थे, राइट? तो चलो, ये तो सिंपल स्ट्रेट फॉरवर्ड सा क्वेश्चन है कि एकाइनोकोकस ग्रैन्युलोसस इसका पॉजिटिव एजेंट है ना? तो एकाइनोकोकस ग्रैन्युलोसस DH डेफिनेटिव होस्ट होता है डॉग, इंटरमीडिएट होस्ट आर शीप. तो फिर हम इसके बारे में क्यों पढ़ते हैं? क्योंकि ह्यूमंस कैन बिकम एक्सीडेंटल इंटरमीडिएट होस्ट. बहुत ही कम ऐसे पैरासिटिक इन्फेक्शंस हैं वेयर ह्यूमंस सर्व एज द एक्सीडेंटल इंटरमीडिएट होस्ट. अधिकतर पैरासिटिक इन्फेक्शंस में हम मतलब ह्यूमन बीइंग्स बिकम व्हाट? वी सर्व एज द डेफिनेटिव होस्ट. अच्छा, मतलब ट्रीटमेंट पे क्वेश्चन था. तो चलो गुड, दैट ऑलरेडी हैज बीन कवर्ड देन. ऑलराइट, सो बेसिकली ये अब वही ना, देखो टॉपिक पूरा पता होना चाहिए, चाहे आपसे ट्रीटमेंट पूछा जाए या फिर कुछ और पूछ लें, डेफिनेटिव होस्ट पूछ लें, या फिर जैसे फॉर एग्जांपल हाइड्रेटेड सिस्ट की मैंने पिक्चर यहाँ पे लगा दी है, मोस्ट कॉमन साइट होता है लिवर, सेकंड मोस्ट कॉमन साइट होती है लंग्स, तो इस पे भी काफी क्वेश्चंस आ रखे हैं। तो बी वेरी वेरी फेमिलियर विद द टॉपिक्स। एग्जैक्ट क्वेश्चन यूजुअली रिपीट नहीं होता है एज इट इज, हार्डली एवर इट इज रिपीटेड, बट वो टॉपिक आपको पूरा अच्छे से पता होना चाहिए, राइट? सो दिस इज हाउ द हाइड्रेटेड सिस्ट लुक्स लाइक। सबसे बाहर देखो, बाहर से हम अंदर जाते हैं, पेरीसिस्ट, तो ये आप देख रहे हो ब्लड वेसल्स जो रेड में है और फाइब्रोब्लास्ट जो व्हाइटिश है। सो पेरीसिस्ट इज प्रोड्यूस्ड बाय द होस्ट रिएक्शन, पर इसके अंदर वाली लेयर होती है एक्टोसिस्ट, विच इज एन acellular laminated hyaline layer. It resembles the white of a hard boiled egg. और इसके अंदर होती है एंडोसिस, इसको जर्मिनल लेयर बोलते हैं। जर्मिनल लेयर एकदम पर्याप्त, एकदम ओके अप्रोप्रिएट शब्द है, टर्मिनोलॉजी है इसके लिए, क्योंकि जर्मिनल का अर्थ क्या हुआ, इसका मतलब क्या हुआ, किसी चीज को उत्पन्न करना, पैदा करना। तो एंडोसिस्ट किस चीज को गिव राइस, आई मीन किस चीज को प्रोड्यूस करेगा, इट गिव्स राइस टू दीज ब्रूड कैप्सूल्स। इसके अंदर प्रेजेंट होंगे स्कोलिसिस और प्रोटोस्कोलिसिस, विच आर गोइंग टू फॉर्म द हेड्स और द स्कोलिसिस इन फ्यूचर, ठीक है? All right, and कभी ना ये these brood capsules, they can get detached from the endocyst की layer and they can deposit at the bottom, उसको बोलते हो hydrated sand, और इस पे भी क्वेश्चन आ चुका है। All right, okay, thank you so much Prateek for this input. Let me just add it quickly. तो इसमें क्या लिखा था, right upper quadrant pain. Thank you. तो चलो बेसिकली पूरा टॉपिक आपको पता होना चाहिए। Entamoeba also was there in the options. Oh, okay, thank you so much. चलो guys, next question. There was probably a question on TB meningitis, ऐसा मुझे स्टूडेंट्स ने बताया है। अब आई एम नॉट श्योर कि TB meningitis ऐसे क्वेश्चन में लिख रखा था फिर उसके फीचर्स पूछे थे, या फिर इट वाज लाइक दिस कि भाई CSF प्रोफाइल दे रखा था किसी पेशेंट का हु प्रेजेंटेड विद नेक रिजिडिटी, और फिर CSF एनालिसिस रिवील लिम्फोसाइट प्रेडोमिनेंस, ऐसा कुछ। तो बेसिकली अभी क्वेश्चन किस चीज पर है, ये भी CSF प्रोफाइल आपको इंडिविजुअल केसेस में पता होनी चाहिए। पायोजेनिक मेनिंजाइटिस में क्या होता है, TB मेनिंजाइटिस में, वायरल मेनिंजाइटिस में। तो बेसिकली अगेन अ वेरी वेरी एक्सपेक्टेड क्वेश्चन, इजी क्वेश्चन है ना। अगर राइट से हम लेफ्ट में जाएं, वायरल मेनिंजाइटिस और एसेप्टिक मेनिंजाइटिस, तो इसको सोचो कि सबसे राइट में है ना, तो ये सबसे लेड बैक है, सबसे लेजी है, तो यहाँ पे उतनी हलचल नहीं है। कहने का मतलब क्या है, CSF प्रेशर नॉर्मल रहेगा या स्लाइटली एलिवेटेड रहेगा। टोटल ल्यूकोसाइट काउंट होगा 25 से 500 पर mm³, ठीक है। प्रेडोमिनेंट सेल लाइफ लिम्फोसाइट्स, ठीक है। लिम्फो और न्यूट्रो को अगर मैं कंपेयर करूं, तो न्यूट्रोफिल्स के नाम में है ना कि न्यूट्रो, मतलब सोचो कि वो न्यूट्रलाइज कर देते हैं चीजों को, मतलब दे आर फैंटास्टिक फेगोसिटिक सेल्स। उनके कंपैरिजन में तो जो थोड़े काम कंपोज्ड शांत वाले सेल्स होते हैं लिम्फोसाइट्स। तो वायरल या एसेप्टिक मेनिंजाइटिस को मैं लेजी वाला मेनिंजाइटिस बोल रही हूँ, तो हम यहाँ पे ये सोचेंगे कि भाई यहाँ पे लेजी वाले सेल्स को का पार्टिसिपेशन रहेगा, मतलब लिम्फोसाइट्स। और ग्लूकोज भी यहाँ पे नॉर्मल है, ठीक है। और टोटल प्रोटीन्स की अगर हम बात करें, टोटल प्रोटीन्स 20 से 80, 20 to 80 mg पर डेसीलीटर, मतलब कि नॉर्मल या स्लाइटली एलिवेटेड। तो यहाँ पे ज्यादा कुछ ऐसे ना प्रॉब्लमेटिक चीज, आई मीन प्रीसीजर प्रोफाइल की उतनी नहीं है। अब बात तो नंबर 1 ये हो गया, ठीक है। वी आर गोइंग फ्रॉम राइट टू लेफ्ट। TB मेनिंजाइटिस पे आ जाओ, CSF प्रेशर मॉडरेटली एलिवेटेड, ठीक है। अब ये थोड़ा सा ज्यादा अग्रेसिव है इन कंट्रास्ट टू द वायरल मेनिंजाइटिस। टोटल ल्यूकोसाइट काउंट 10 से 500, प्रेडोमिनेंट सेल टाइप लिम्फोसाइट्स, ग्लूकोज स्लाइटली डिक्रीज्ड है यहाँ पर, टोटल प्रोटीन्स मॉडरेट टू मार्केटली इंक्रीज्ड। एंड सबसे ज्यादा अग्रेसिव हो गया हमारा पायोजेनिक या बैक्टीरियल मेनिंजाइटिस, वेयर प्रेशर इज हाईली एलिवेटेड मोर देन 180, टोटल ल्यूकोसाइट काउंट 100 से 10,000, एंड मोस्ट ऑफ दीज सेल्स, दीज आर मोस्टली न्यूट्रोफिल्स। ग्लूकोज इज डिक्रीज टू मोस्टली एब्सेंट। तो यहाँ पे एक्सट्रीम्स ऑफ चीजें हो रही हैं, और टोटल प्रोटीन्स मोर देन 45, ठीक है। any inputs on the stem of this question, और किस प्रकार और क्या ऑप्शंस दे रखे थे, एनीवन? प्रतीक, आरिफ, ओके। प्रतीक, ऑप्शंस इन दिस क्वेश्चन? Anyways, whenever you are able to recall any option, a humble request to all of you कि मुझे प्लीज DM कर दीजिएगा इंस्टाग्राम पे mj.micro पर, विल बी वेरी वेरी ग्रेटफुल। चलो आगे बढ़ते हैं। 10वां क्वेश्चन, Was there some question on viridin streptococci? ये 2-3 जगह से मुझे मिला, but exact question क्या आया था? It's okay प्रतीक, chill. चलो ये इजी क्वेश्चन था, ये अच्छी बात है. विरिडन स्ट्रेप्टोकोकाई पे आया था क्वेश्चन. ये 2-3 जगह पे आई गॉट टू नो, आई मीन आई सॉ सम ग्रुप्स की इस पे कुछ आया था क्वेश्चन, बट एग्जैक्टली क्या था नोबडी, आई मीन नोबडी कमेंटेड ऑन इट. विरिडन स्ट्रेप्टोकोकाई यू ऑल नो अल्फा हिमोलिटिक होते हैं, ओरल कमेंसर्स होते हैं. विरिडेंस इसलिए बोलते हैं क्योंकि दे आर अल्फा हिमोलिटिक, सो दे विल ब्रेक डाउन आरबीसीज पार्शियली, because of which biliverdin will be produced, which will accumulate around the colonies, resulting in a greenish discoloration. अच्छा, इसका endocarditis. So these are the MCC, most common cause of subacute bacterial endocarditis. क्या था exact question endocarditis पर? And there also remember MCC, most common cause of dental caries, है ना? एग्जाम्पल्स क्या है इसके? स्टेप इन ऑर्गेनिजम्स के स्ट्रेप्टोकोकस म्यूटेंस हो गया, स्ट्रेप्टोकोकस माइटिस हो गया, स्ट्रेप्टोकोकस सलाइवेरियस है ना? म्यूटेंट्स के अगेंस्ट द वैक्सीन भी अवेलेबल है. दिस इज द मोस्ट कॉमन स्पीशीज अमंगस्ट ऑल दीज प्लेथोरा ऑफ स्पीशीज इम्प्लिकेटेड इन डेंटल केरीज. तो एंडोकार्डाइटिस पे एग्जैक्टली क्या क्वेश्चन था कि व्हाट व्हिच काइंड ऑफ एंडोकार्डाइटिस दे कॉज, या फिर क्या, एंड ऑप्शंस. And by the way, अच्छा यहाँ पे let me also emphasize upon a very important thing कि there is nothing called as Streptococcus viridans. Please guys, viridans streptococci एक group है. There is no species of Streptococcus namely viridans. इसको Streptococcus viridans नहीं बोलते हैं, इसको viridans streptococci बोलते हैं. ठीक है, तो viridans एक group का नाम है. कई जगह इंटरनेट पे भी Streptococcus viridans आपको मिलेगा, which is totally wrong. Okay, clinical case of endocarditis and most common cause. Okay, Staph aureus, Enterococcus faecalis. What else? See, the history has to be complete for us to be able to comment on कि भाई कौन सा cause था. No, dental caries तो मैंने वैसे बता दिया आपको कि in the context of viridans. So if someone could later on also is able to recall the exact stem of the question, please let me know guys. तो चलो आगे बढ़ते हैं. A patient with history of rheumatic fever, कोई ऐसे पेशेंट था एंड ग्राम स्टेन पिक्चर ऑफ ग्राम पॉजिटिव कोकाइन चेन्स. ये अगेन देखो इनकम्प्लीट क्वेश्चन है. अब देखो यहाँ पे एक लूप होल क्या है. rheumatic fever क्या होता है? rheumatic fever is one of the immunological sequelae seen after streptococcus pyogenes infection. तो and it occurs and it's a sequelae of what? A sequelae of sore throat and not skin infection. ये आप सबको पता है. बट इस क्वेश्चन में कॉन्स्टेंटली आई मीन फ्रॉम 2-3 प्लेसेज आई गॉट टू नो कि भाई ग्राम सेन दे रखा था वो जीपीसीज इन चेन्स. सी यू कांट you can't culture the see ये जो होती है ना rheumatic fever या PSGN, they usually occur 2 to 4 weeks after sore throat or skin infection. जो PSGN है, PSGN can occur more commonly after a skin infection with streptococcus pyogenes, that is group A streptococcus, or less commonly after sore throat. तो दोनों ही conditions में rheumatic fever हो या फिर PSGN हो, we cannot isolate the organism or see the organism, because यहाँ पे कौन हमारा दुश्मन बन जाता है? हमारा खुद का ही immune system. All right, so I don't know why this question was framed. Nevertheless, तो जब उन्होंने ये बोल दिया कि ग्राम स्टेन पिक्चर ऑफ ग्राम पॉजिटिव कोकाई इन चेन्स, तो हमें क्या ऑब्वियसली मार्क करना है? स्ट्रेप्टोकोकस पायोजीन्स. प्रतीक कौन सा क्वेश्चन नहीं था ऐसा? ये 11th क्वेश्चन which I am discussing right now. So this picture, see, ये मैंने विकिपीडिया से लिया पिक्चर कि कोई ग्राम स्टेन वाली फोटो आई थी जीपीसीज इन चेन्स. Probably they wanted to ask कि कौन सा ऑर्गेनिज्म implicated, I mean कौन सा ऑर्गेनिज्म रिस्पॉन्सिबल है for this sequel to occur, rheumatic fever. Again, a humble request, if somebody is able to recall the correct stem, kindly DM me. चलो आगे बढ़ते हैं. A lady presented with curdy white vaginal discharge, which on gram stain revealed budding yeast cells and pseudo-hyphae. What is the likely cause? अब इसमें I could not get the other options. Will be very happy again and grateful अगर आपको options याद आ जाएं. तो ये straight forward वैसे question क्या है, क्या है ये infection? Basically vaginal candidiasis, इसके बारे में already हमने important pointers मैंने आपको बता दिए हैं. ठीक है, इसका ट्रीटमेंट, इसमें विफामिन टेस्ट पॉजिटिव नहीं होता है, वेजाइनल पीएच अनऑल्टर्ड होता है, डायबिटिक फीमेल्स में रहता है ये, कर्डी वाइट वेजाइनल डिस्चार्ज क्वेश्चन में ही बोल दिया है. अगेन देखो, कनाडा भी एक ऐसा टॉपिक है जो हम पढ़े बिना मैं तो बोलूंगी एग्जाम देने जाना नहीं चाहिए. इट्स वेरी वेरी इंपॉर्टेंट. द 2 C's ऑफ माइकोलॉजी, कनाडा एंड क्रिप्टो, वेरी इंपॉर्टेंट, और दोनों आए हैं इस एग्जाम में. ठीक है, extremely important. Candida albicans, the most common species of genus Candida, causing infection in humans. And remember, जो हमारा genus Candida है, this is yeast-like. This is yeast-like. Cryptococcus on the other hand is true yeast. फर्क क्या होता है दोनों में? Candida के केस में ना pseudo-hyphae भी मिलते हैं, pseudo-hyphae. अब Candida albicans क्या है? हमारा दोस्त भी है, मतलब it's a commensal on the skin, in the oral cavity, GIT, and the genital tract also. तो पता कैसे चलेगा कि commensal कब हमारा क्या कहते हैं दुश्मन बन गया? ठीक है, जस्ट लाइक समटाइम्स फ्रेंड्स भी हमें बिट्रे करते हैं, तो कई बार हमारे जो ये माइक्रोस्कोपिक फ्रेंड्स हैं, मतलब कमेंसल्स, दे कैन आल्सो बिट्रे अस व्हेन दे स्टार्ट कॉजिंग, व्हेन दे बिकम रिस्पांसिबल फॉर डिजीज. तो स्यूडोहाइपे अगर हमें किसी सैंपल में मिलते हैं ना माइक्रोस्कोपी पे, दिस इज अ वेरी वेरी इंपॉर्टेंट क्लिंचर इन डायग्नोजिंग these commensals as the culprits behind the disease. मतलब कि स्यूडोहाइपे अगर दिख जाते हैं, मतलब कि the commensals have started to invade the tissue. तो pseudohyphae otherwise नहीं दिखेंगे अगर तो Candida albicans disease नहीं कर रहा है, लेकिन अगर ये दिख गए माइक्रोस्कोप में, it means it is indicative of tissue invasion. Please remember this. Yes, प्रदीप, क्रिप्टो पे अभी हमने ऊपर किया ना डिस्कस क्वेश्चन. एस्परगिलस, ओके, ऑप्शन बी एस्परगिलस. ओके, थैंक यू प्रतीक. ठीक है, तो ये अगेन सिंपल क्वेश्चन. And last question for this recall. Again, guys, this is not a complete recall. So I could gather 13 questions so far. Looking forward to gathering more questions and subsequently, as told to all of you, एक detailed recall भी PW MedEd पे किया जाएगा. So guys, this very question, coral red fluorescence on Woods lamp examination is seen in infection with Corynebacterium minutissimum. ये क्या करता है? Erythrasma. It's an example of what? A diphtheroid. A diphtheroid. Diphtheroids are what? They are important skin commensals. And sometimes they can be present also in throat as well. ये तो question for sure था. Anyone can help me recollect the other options, B, C, D? मंसूर, इस क्वेश्चन में आप कह रहे हो इमेज आई थी कोरल रेड वाले क्वेश्चन में? Okay, thank you so much for your input. अच्छा, color was asked. अच्छा, coral red पे ही question आया था. Okay. All right. So nevertheless, the question was very easy and I'm sure आप सभी ने correct mark किया होगा. ठीक है guys. So this is again an incomplete recall. ठीक है, तो these are the questions which I could gather. So mj.micro Insta handle पे आप मुझे please DM कर दीजिएगा अगर आपको कोई भी और questions याद आते हैं, या in currently discussed questions के stem कुछ याद आती है, question की language याद आती है, या options याद आते हैं, will be extremely thankful and grateful. And before I say bye to you, just want to tell you that don't bother about the result. ठीक है, अभी थोड़ा chill मारो, इतना important exam दिया, इतना बड़ा exam दिया है. Now don't bother about the result. एक अच्छी सी break लो and all will be well. Arey, relax, Pradeep. You have done your bit, you have done your best. Now leave the rest to the Almighty. And मैंने एक मैसेज भी इंस्टाग्राम पे कल डाला था कि दुनिया का कोई भी एग्जाम आपकी वर्थ डिसाइड नहीं करता और ये कभी भी निर्धारित नहीं करता कि आप कितने सक्सेसफुल होगे. ठीक है, तो एक एग्जाम था, आपने दे दिया. जस्ट होप फॉर द बेस्ट. अभी ब्रेक लो, यू ऑल डिजर्व अ ब्रेक, है ना प्रतीक? So I won't take more time of yours. Other faculties also are waiting. So guys, all the very best for the results and everything else in life. Thank you very much. Thank you.
Thank you, ma'am, for a very elaborate discussion of the previous year questions. I think we also touched upon the previous year topics. So students are ready with the topics as well as questions. So thank you, ma'am. Thank you. So next up, guys, we have Dr. Jazir, who will be taking us through the dermatology previous year questions. Dr. Jazir, am I audible to you?
Yes, sir.
Over to you, sir. Over to you.
Thank you so much, sir. So, dear students, I hope that you had a decent exam today. So, what I'm trying to do is I'll just go through all of the questions that has been come from dermatology. So, I hope that my audio as well as the video is all fine. So, I'll just without losing on any much time, I'll just go through the questions now. Okay. Yeah. So now, one of the questions that was asked was regarding buboes, isn't it? That also comes under the genital ulcer disease. So in which two conditions do you remember that we have learned about bubo? Now, what do you mean by a bubo? It means that there is a lymph node which contains pus. Okay, in other terms, it means that it is going to be suppurative lymphadenopathy. So suppurative lymphadenopathy, so from whatever I have got from the students is that it can be seen in two diseases. It can be seen in chancroid as well as in LGV. So in the exam, I guess that LGV is the option that was given. So the first question that is regarding buboes, the right answer would be LGV. Yes, Pratik, about lupus vulgaris also, I'll just come to that question. So somebody's messaging about molluscum contagiosum. I'm not very sure about molluscum contagiosum. If you know the right question, please give me the question in the chat box. Because with whomever I have discussed, nobody told me about molluscum contagiosum yet. Oh, thank you, Pratik. Yes. So in LGV, and no, granuloma inguinale, that is the old name for donovenosis. So don't get confused there. So here, if it is going to be buboes, the answer should be either chancroid or LGV. So in the question that was asked today, the right answer would be LGV. Okay? So now let's go to the next one that was asked. I think just now Mamta ma'am also discussed regarding the same thing, like coral red fluorescence. So we had a list of findings about the Woods lamp. Like whenever there is a diseased skin, when we use this instrument called as Woods lamp, there would be colored fluorescence. Colored fluorescence. And luckily, I guess that this is one question that most of you should have got it right, because coral red fluorescence, where is it seen? It is seen in a condition called as erythrasma. And how does the patient present to you with erythrasma? I guess it was an image-based question, right? So in erythrasma, what can you see is either over the axilla or over the groin of the patient, you can see that there is a hyperpigmented patch lesion. And this hyperpigmented patch lesion, if you do a Woods lamp examination, then what is the color that reflects back? The color that reflects back is going to be coral red in color. So I hope that none of you must have got this question wrong. Molluscum probably it should have been there in some of the option. So that is about this coral red fluorescence in Woods lamp. Then there was one more question which was always a repeat question for FMGE exam, isn't it? That is regarding pellagra. So I guess that this time it was not an image-based question. Instead, what I got to know from most of the students is that it was like a photosensitive rash. It was a clinical question where a photosensitive rash was mentioned, that too in the neck region. So what is the usual deficiency? The deficiency is going to be niacin deficiency, isn't it? So this is going to be niacin deficiency, and the right answer would have been pellagra. I guess this also was an easy question, which was pretty much expected in our previous sessions. Also, we always said, like in the FMG exam, always this topic is repeated. Acha, history was given. Okay, so there must be a history of some deficiency, isn't it? Along with that, a photosensitive rash, the correct answer would be pellagra. Now, another question was there, which many of you have told that there was again a clinical question or an image where the color of the rash was mentioned as purple colored rash along with pruritus. So purple colored rash, this one, violaceous rash or purple colored rash, whenever you find this thing, in most of the instances, what is the diagnosis? Diagnosis is going to be this one that is called as the lichen planus, isn't it? So in lichen planus, I guess this time they asked you regarding what is a treatment. So out of all the options, so some of them have recollected and said that one of the option was dapsone, which definitely is not the right answer. So one of the right choice was topical steroids. Topical steroids. So in case they have mentioned it as a purple colored pruritic rash in a patient, then the right answer would be lichen planus. And the question was regarding the treatment. So if it is regarding the treatment, the correct answer would be topical steroids, because all of us know that lichen planus, it is mostly a self-limiting condition. But how long does it take for a self-limiting thing? So it may take from 6 months to 2 years. So in many of the instances, what we have to do is that we have to treat lichen planus with some medication. And the first line of treatment is always topical. And in topical, the first line treatment is always going to be topical steroids. Thank you, Pratik, for confirming. G. Genital warts, yes, Krishna Kumar, I'm just coming to that question. That was also a repeat question. Like there was probably an image of some genital warts which was given, correct? So in this genital wart, the question that was asked was the treatment of genital warts in pregnancy. So we know that in genital warts, in all the normal cases, how do we treat them? So we can treat them with some of the agents, but these agents can be teratogenic. So because of the risk of teratogenicity, so we should be going for some safer treatment modality. Okay, so thank you, Pratik. Image was given. So if you have got a warty lesions in the genitalia, what is it called? It is called as condyloma acuminata. And what is the treatment of condyloma acuminata when it comes to pregnancy? So when it comes to pregnancy, the treatment would be cryotherapy. The treatment would be cryotherapy. So I hope that this cryotherapy was one of the options that was given, because we will not go for any other treatment modality like EMQ mode and all, because those are going to be teratogenic. Yeah, very good. So cryotherapy is going to be the right answer when it comes to the treatment of genital warts in pregnancy. Okay. And along with that, there were some of the other questions also. But what I felt was that most of these other questions, it can be considered as a just some time ago in surgery, we discussed about Fournier's gangrene, correct? So Fournier's gangrene, this is actually necrotizing fasciitis that is going to be localized, that is localized to the scrotum or the perineal area. So necrotizing fasciitis that is localized to the scrotum or perineal area, this is called as Fournier's gangrene. I guess an image was given this time for your exam, and I hope that you have got it right as well. Thank you for confirming in the chat box. Now, there was one question regarding leprosy. I'm not very sure about the exact clinical scenario. So most of the students are giving different clinical scenario. But in case this question on leprosy, if it has mentioned some nodular lesions along with hypopigmented patches. So what is the type of leprosy where we discussed about nodular lesions? Like we have nodular lesions over the face and multiple hypopigmented patches over the trunk. So is it going to be tuberculoid, BT, TT? Which type of leprosy? Yeah. So please remember that in case it is there a mention of nodular lesions, then it is more likely to be lepromatous. Okay, it is more likely to be lepromatous leprosy, because in lepromatous leprosy we can see both nodular lesions along with hypopigmented patches over the trunk. And there was one question regarding neurofibromatosis. Does anybody remember what is the question about neurofibromatosis? Because one of them told me that there were multiple options, like which of the following is not true about neurofibromatosis NF1. Like one of the option was autosomal recessive, then optic glioma, and others were given. Is it correct? Can anybody confirm? So in case autosomal recessive was given in the option, that would have been the wrong answer, because neurofibromatosis is going to be an autosomal dominant disease. Autosomal dominant disease. Okay? So that is a one more question. And another question, again, we can consider it as either in dermatology or in pediatrics, which I'm sure that this question come up in pediatrics as well, like a baby or a neonate who is having multiple pustular eruptions over the trunk. So this is considered to be, what is the diagnosis? These kind of pustular eruptions is going to be erythema toxicum neonatorum, that red color body, isn't it? Along with multiple pustular eruption, where usually no treatment is necessary. This is called as erythema toxicum neonatorum. So that was also one of the question. So any one of you remember any more questions from dermatology? I guess that is it. So some of them have told that there was a question about some gum bleeding. So another vitamin deficiency where there is gum bleeding, some symptoms regarding the involvement of the joints, etc. So in case gum bleeding was given, then probably the answer would have been vitamin C deficiency. So I guess these were the questions from dermatology. I hope all of you was able to answer. Okay, these lichen planus, condyloma acuminatum, all these things were repeatedly discussed even in our live sessions as well. So if there is anything that you would like to contribute in the chat box, I'll be happy to answer you. Otherwise, I'll not be taking much of your time because we have more and more subjects waiting. If that is it, then I will just wind up the session. So thank you so much. Over to Santosh sir.
Thank you, Dr. Jajir. That was a very wonderful session. So students, I think most of your dermat questions are addressed here. So next up, we have Dr. 𝐒𝐿𝐿𝐄𝐝. She is a faculty for orthopedics, and she will be taking you through the questions from orthopedics. Dr. 𝐒𝐿𝐿𝐄𝐝, over to you.
Hello, sir. Thank you so much.
You're live, ma'am. You can go ahead.
Yes, I hope the audio and video is clear. So now we're coming to the orthopedics. So there are not many questions from my subject, that is orthopedics, but we have one interesting question which I have put it for the last. But just going through some integrated questions from orthopedics. That is, one is the psoas muscle insertion that they have asked. So the insertion is at the lesser trochanter, which is one of the important flexors of the hip joint, right? And then there was always a question about anatomical snuff box. In July, it was asked regarding the scaphoid fracture in the last FMGE. Now it was the tendon which is asked, that is the EPL tendon which was asked. So I hope this was discussed by the anatomy sir. And then there was a question regarding the thumb joint, that is the saddle joint was the answer. And then there is one more which is related to orthopedics, that is integrated with the gum bleeding. That is the very easy answer, that is vitamin C deficiency. So scurvy is one important condition which we see in orthopedics also, which is relating to the deformities. That is the bow leg deformity which was mentioned in the exam, which was associated with the gum bleeding. So the answer is vitamin C, that is the scurvy, right? And so that completes all the integrated. Now coming to exclusively to orthopedics topic, we have this one called the osteoid osteoma. So the question was not completely clear, but they have mentioned that the biopsy was given or the X-ray, I'm not sure, but yes, the clue to this particular question was it was relieved by aspirin, right? It was relieved by aspirin or any NSAID which relieves this pain. So usually osteoidostoma, we see the night pains which are seen in the child, that is children of age group from 6 years to 15 years mostly. And whenever they complain of pain, and if this pain are usually at the night time and then they get relieved by giving aspirin, you can diagnose this as osteoid osteoma. So yeah, Krishna Kumar, that is the relieved with aspirin. Yeah, that is the answer. If this is the question, the answer would be osteoid osteoma. So this is one of the question. And the next one is the most favorite questions, and that is the deformity. So the gunstock deformity, which is usually seen with the history like this. So there will be a history of trauma, usually a kid of probably some 6 to 7 or 8 years. And then there will be a history of trauma that would be a chronic deformity. And now on examination, you will find this condition which is called as cubitus varus, that is at the elbow joint, right? And this is nothing but your most famous image-based question, that is the gunstock deformity. And the answer for this is the malunited supracondylar fracture. So malunion is nothing but there is a union, but the alignment is not proper, right? So in this not proper alignment, there will be a varus which is seen at the elbow region. And this is very, very classical. It is a previous year question, previous year topic. So it is most expected, and I hope everybody have done this question right? So the answer here it is the malunited supracondylar fracture. Usually in the lateral condyle also you will see one more union, that is the non-union usually, and this goes into varus. This goes into valgus, right? So this goes into valgus. So here the answer is supracondylar fracture humerus, that is the gunstock deformity. And the next one here, this is the tricky question which I wanted to discuss. That is, there was a condition, the clinical condition which was present, that is history of trauma. And usually in orthopedics, we are obsessed with the attitude of the limbs, right? So the attitude of the limbs, the most important, the most common attitude of the limb is FADE, that is flexion, adduction, internal rotation, which is usually seen in case of your posterior dislocation of hip. But here in the question, it was mentioned as flexion, abduction, and external rotation. That is flexion, abduction, and external rotation, right? So this usually we see it in the IC fracture, but the catch here is the limb lengthening. So usually when you see the IC fracture, it is Faber plus shortening, Faber plus shortening. When you see this word shortening, that is IC fracture. But when they have mentioned this Faber plus lengthening, the answer would be the anterior dislocation. So the anterior dislocation of the hip. And again, same, this is a repeated PYQ. So previous year topic, not the exact question, because the question would always be on posterior dislocation. But this time it is on anterior dislocation, where you have to look for the specific feature of this, the lengthening. So in case of anterior dislocation of the hip, it is flexion, abduction, external rotation with the limb lengthening. And you feel the head on the anterior aspect. So what would be the complication? Usually it is related with the vascular complication. So this is related to the vascular complication, if at all they have asked. And if it is posterior dislocation, it is the nerve complication, that is the sciatic nerve which is at fault there. So this is about orthopedics. And there is little confusion of the GCT, whether it was given or not, I'm not pretty sure, but I hope you will all do the GCT well, because that is also an expected question, right? So that's it from the orthopedics end. Thank you so much. And I hope you have all done really well. Have a very, very happy and a very good sleep for tonight. Okay, bye. Thank you. Over
Thank you,
to
ma'am,
Dr.
for a very
Santosh.
crisp and concise recall. I think that has answered the questions or doubts that our students had. Thank you, ma'am. Next up, guys, we have Dr. Rajesh Jambulkar, who will be connecting us with now, and he will be taking us through the biochemistry questions, and indeed very important topic. Dr. Rajesh, am I audible to you? Dr. Rajesh, am I audible to you?
Yes, sir. Hello,
Okay,
sir.
sir. Over
Hi,
to you.
Santosh, sir.
Hi, sir. Over to you.
Yes. Okay. So, hello, everyone. This is a superficial discussion about the FMGE 2024. Okay. There are 10 to 12 questions which are from the biochemistry, and entire focus is on the vitamins, but it is not only from the biochemistry, but it is integrated topic, vitamins. So as usual, the vitamin topic, it is frequently asked and most important topic, but it is related with the pediatric, it is related with the medicine, it is related with the skin, and it is integrated with all other subjects. That's why it is important topic. So this is a superficial and short discussion, because my colleagues are waiting there for this recall. Hope you are doing your best now and enjoying now. So see, the G6PD deficiency is linked with which pathway? This was the question. It is linked with the HMP shunt. As such, the condition is asymptomatic, but when pro-oxidant drugs are given, for example, primaquine, sulfonamide, nitrofurantoin, dapsone, or favabins, when they are given, they increases the synthesis of free radicals or reactive oxygen species, And because this enzyme is deficient in the HMP shunt, there is no production of NADPH. So that hampers the RBC membrane and hemolysis occurs. And that's also jaundice occurs. So that's why it is known as G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. And this is the rate limiting enzyme of this pathway. Okay, this was the first question. Some students says the question was on the rate limiting enzyme of the HMP shunt. Okay, so hi Krishna, hi Pratik, आरिफ, आप लोगों ने अच्छा इनपुट दिया है, उसके वजह से ये रिकॉल लेना हमको इजी हो गया थोड़ा बहुत. Then second question was the Castle's necklace shaped dermatitis is a feature of niacin deficiency. That is 3 classical Ds, that is diarrhea, dementia, and dermatitis. These are present in the niacin deficiency. As niacin is connected with the tryptophan, these features are also there in the heart nerves disease where tryptophan absorption is hampered. Also in the carcinoid syndrome, because tryptophan is diverted for the serotonin production. Also in the maize and the jowar eating population as a staple diet, because in maize niacin it is present in the bound form, and in the jowar the high leucine content inhibit the enzyme QPRT, which is important from tryptophan to niacin conversion. So this was the question, Castle's necklace, whether it was niacin is derived from, it is from the tryptophan. Hi Krishna, the question was niacin is derived from, it is from the tryptophan, if that was the question. Okay, but there is lot of इसके ऊपर काफी सारा discussion हुआ है, and the Castle's necklace was told by many students. Okay, so niacin is derived from the tryptophan. Now ये मुझे कंफर्म नहीं है, ये क्वेश्चन एक दो लोगों ने ये क्वेश्चन बताया है. बर्निंग फिट सिंड्रोम वाज ड्यू टू डेफिशिएंसी ऑफ, इट इज ड्यू टू डेफिशिएंसी ऑफ पैंटोथेनिक एसिड, विटामिन B5. There is pain, paresthesia, and feeling of hotness in the legs. That was discovered by the scientist Gopalan, that the Indian scientist. And the disease was burning fit syndrome. ये था क्या क्वेश्चन? बर्निंग फिट सिंड्रोम पे क्वेश्चन था. हाय आरिफ, प्रतीक, कृष्णा. नॉन कोडिंग सीक्वेंस, हाँ वो लिया है हमने, जस्ट वेट. Then bleeding gums and rosary is seen in deficiency of, this is a easy question. It is vitamin C deficiency, which affects the collagen synthesis. Vitamin C is required for hydroxylation of proline and lysine. So it is important for the rigidity of the collagen. So vitamin C deficiency, vitamin C is important for the hydroxylation reaction in the collagen synthesis. That's why vitamin C deficiency causes the fragile blood vessels that causes the bleeding gums. Okay. Transport form of ammonia from brain to liver. If it is brain or if it is intestine to liver, the answer is glutamine. The answer is glutamine. And if it is from the muscle, the answer is alanine. Remember that this is from the urea cycle or ammonia metabolism. So this is glutamine is the transport form of ammonia from brain and from intestine to the liver. But from muscle to liver, it is in the form of alanine. Collagen type example. Okay, what was the exact question related to collagen? Now see, this was the simple question. Lactose is made up of glucose and fructose, galactose and glucose, glucose and mannose. The answer is galactose and glucose. It is the bond between galactose and glucose, that is beta 1,4-glycosidic linkage in between galactose and glucose. Lactose, it is made up of galactose and glucose. तो जितने भी easy questions थे वो generally याद नहीं रहते एग्जाम के बाद. So this was easy question. Lactose is made up of galactose and glucose. See, this was the question related with the sequence. If the sequence of nucleotide on RNA, this is RNA, is 𝐒𝐴GGUA, what is the complementary sequence on the coding DNA strand? Coding DNA strand. Remember this, just wait. Coding DNA strand. Whatever may be the sequence, यहाँ पे दूसरा sequence भी रह सकता. See, this is DNA, double-stranded DNA. Now this is template strand. If this is template strand, okay, it is in 3 to 5 direction, 3' to 5'. This is 5' to 3'. This is coding strand. This second opposite strand is known as coding strand. This strand is known as coding strand. Now here question is on the coding DNA strand. Now mRNA is produced on this strand. Okay. And the coding strand and mRNA strand, this strand and this strand have the exactly similar sequence, except there is uracil in the RNA. So this is a sequence in the RNA, and this strand is coding strand. Why this strand is known as coding strand? Because it has same sequence as that of this newly synthesized RNA. So it is same as that of this sequence, only this U, this will replace. Okay, this U will replace by the T. So CAGGTA, this is the answer. Okay. And if it is template strand, this is answer. It is complementary. Now there was question on the purine ring, but exact question मेरे पास आया नहीं अभी तक. So purine ring, और यहाँ पे कुछ तो भी exception था, ऐसा बच्चों ने बताया. Source of individual atoms of purine ring. These are the sources of different atoms of the purine rings, and it is numbered. It is numbered in anti-clockwise direction. If there is pyrimidine plus imidazole ring, 9 number of atoms there. If there is pyrimidine and imidazole ring together, it is a purine. And if it is only pyrimidine ring, it is pyrimidine. Okay. So 6 amino purine is the adenine, and 2 amino 6 oxypurine is the guanine. So adenine, guanine, these are the purines. So it is dependent on the ring structure. यहाँ पे जो क्वेश्चन था वो मेरे तक पहुंचा नहीं. लाइपोप्रोटीन, Arif or anyone, do you know the question? Amino acid in purine. The question on amino acid in purine. Just wait. So these are the amino acids in the purine. Aspartate will give N1, glycine will give C4, C5, and N7. Glutamine will give N3 and the N9. So these are the amino acid: aspartate, glycine, and glutamine in the purine structure. The glycemic index, the food which is nearer to the glycemic index 1 was asked. And remember, these foods, glucose, galactose, trehalose, maltose, lactose, isomaltose, which is closer to the glucose, will give the glycemic index 1. What is glycemic index? It is a number assigned to carbohydrate containing foodstuff with reference to the glucose. With reference to the glucose, it is area under the curve after giving the 50 gram of the glucose and 50 gram of the taste food into 100. So white rice, potatoes, bread, soft drinks, sugary soft drinks, and sugary foods, they have the glycemic index nearer to or closer to the 1. The dietary fibers, vegetable, these are the foods with low glycemic index. Which of the following, ये already discuss हुआ है physiology में. Which of the following glucose transporter is insulin dependent and present in skeletal muscle, heart, and adipose tissue? The answer is GLUT4. We'll not discuss this in detail. Then a confusion है whether there was question on the fluoride bulb or gray top tube. Just confirm that. Niacin is synthesis by which amino acid? It is tryptophan. Lipoprotein. Just wait. Cholesterol storage disorder is xanthoma, familial hypercholesterolemia. Remember, whenever it is LDL raised, when there is raised LDL, raised cholesterol with tendon xanthoma, tendon xanthomas. As there is increase in the LDL cholesterol and cholesterol, there is risk of coronary artery diseases, there is risk of atherosclerosis. This indicate the disease. Which disease? It is familial hypercholesterolemia. It is type 2. Type 2A. In the Fredrickson classification, it is type 2A. Hypercholesterolemia. Okay, there is increased risk of atherosclerosis. There is increased risk of coronary artery diseases. Okay, And if there is chylomicron and TG levels, they are raised, it is lipoprotein lipase deficiency. If it is along with the eruptive xanthomas and the risk of pancreatitis. Vacutainer, the fluoride bulb, gray cap tube. It is known as fluoride bulb, contains sodium fluoride, potassium oxalate into 1:3 ratio that inhibit the enzyme enolase enzyme of glycolysis and maintain the glucose level in the sample so that we get the true value of glucose, plasma glucose. It inhibits the enolase by non-competitive irreversible inhibition. Okay, and for the from this topic, the order of draw is also important. Okay, there was question on folic acid, which is already discussed by the Ranjit sir, and B12 also discussed by the Ranjit sir. Just wait. Surfactant, this question was discussed by the Vivek sir. Surfactant, that is dipalmityl lecithin. There was case on the surfactant topic. So this is all about the biochemistry. Santosh sir, over to you. Just wait. Yes. 3 amino acids were mentioned. How much glucose we will give to check glycemic index? It is 50 gram of the test food compared with the 50 gram of the glucose. That is the formula to calculate the glycemic index. Which content will use in the grade tube for the glucose test? It is the fluoride, sodium fluoride, potassium oxalate in the ratio of 1:3. Okay, so this is all about the biochemistry. Over to you, Santosh sir.
Thank you, sir.
Thank
That
you.
was a very wonderful discussion, and I think we have touched upon most of the questions that have been asked from biochemistry. So next up, guys, we have Dr. Shonali Chandra. She is a faculty for OBG, and OBG generally has a bit of tricky, complicated, even at times controversial questions. So let us welcome Dr. Shonali Chandra. She will take us through the recalls of OBG. Dr. Shonali, am I audible to you? Welcome, ma'am.
Yes, am I audible?
Yeah, ma'am, you're audible and you can take over now.
Yeah. So yes, yes, as Dr. Santosh was saying, Obs Gynae becomes sort of tricky, and what we saw in this FMG also, I would say some questions were tricky, but thoda bahut you could have attempted that. Familiar topics were there that were asked. A lot of integrated questions were asked in this FMG from Obs Gynae. So since this is a very fast and immediate recall that we are doing, right? So some of the options may be missing. I will ask help from my students. Those of you who are watching, okay, please correct wherever you think that we have framed it incorrectly, or given us the options as well. So the first question which we recalled was that there is a multiparous woman from low socioeconomic status. The partner is a truck driver. And it was a fairly straightforward question. Screening for cervical cancer is done by what they were asking. So the correct answer to this question we all know is Pap smear, right? Pap smear is a cervical screening test. And CA-125 is not used for cervical cancer screening. It is, raised in ovarian cancer patients, right? So ye to bilkul out ho gaya. And laparoscopy is such an invasive procedure, it will not be used for screening for anything for that matter. And I don't recall the fourth option, maybe what was given. You can give me an option if anybody of you remembers. But the answer is Pap smear. So screening in follows the same pattern, right? Pap smear hai, we have HPV DNA testing, right? We have visual inspection with acetic acid or visual inspection with Lugol's iodine. These are the screening methods for cervical cancer. Now, the next question is most common organ affected in genital tuberculosis, right? Fairly straightforward, often asked, repeated question, right? So in genital tuberculosis in the female, most commonly part affected is fallopian tube, right? And after fallopian tube, the second most common is the endometrium. And I don't know if endometrium was in the option or uterus was in the option, but ovarian involvement is the third most common. And cervical involvement is possible, but it is again rare. Cervical involvement, vulva involvement, these are very rare with genital tuberculosis. So this was very, very straightforward one-liner question. Okay. Now, next question. A woman had shoulder dystocia during delivery and McRoberts maneuver had failed. So what should be done next? Okay. So suprapubic pressure is applied along with the McRoberts maneuver. Okay. So if McRoberts maneuver fail, so suprapubic pressure will not do anything, है ना? So suprapubic pressure is done along with McRoberts maneuver. अभी McRobert ही fail हो गया तो फिर suprapubic का कोई मतलब नहीं है. We go ahead with the rotational maneuvers. ठीक है? When McRobert maneuvers fail, the next step is to go for the rotational maneuvers. And there are two rotational maneuvers जिसमें हाथ साफ होता है, जो जिसमें trained होता है वो यूज करता है. So Wood's corkscrew maneuver is a rotational maneuver. Rubin's maneuver is a rotational maneuver. तो ये यूज होता है. So the correct answer is Wood's corkscrew. या तो इंटरनल रोटेशनल मनूवर होगा RA0010, या तो वुड्स नाम दिया होगा, या इंटरनल रोटेशनल मनूवर्स ये यूज होते हैं. ठीक है? तो वुड्स कॉर्कस्क्रू इज अ टाइप ऑफ इंटरनल रोटेशनल मनूवर, ये यूज होते हैं. और ये ज़ावानेली मनूवर इज द मनूवर जिसमें बेबीज हेड इज पुट इनसाइड, पुश्ड बैक इन एंड देन डिलीवर्ड बाय सिजेरियन सेक्शन. अब इतना अग्रेसिव मनूवर तो नहीं करेंगे इमीडिएटली. सो दैट इज समथिंग लास्ट रिजॉर्ट. ठीक है? Gaskins all four is knee chest position by the woman. और फिर सारे मनूवर्स वापस से रिपीट करो नी चेस्ट पोजिशन में. दैट इज Gaskins. वेरी लास्ट रिजॉर्ट. ओके. सो ये ज़ावानेली, Gaskins, ये सब लास्ट रिजॉर्ट के. और लास्ट रिजॉर्ट मनूवर्स कौन से होते हैं? फ्रैक्चर ऑफ द क्लैविकल ऑफ द बेबी, है ना? तो फ्रैक्चर दी clavicle fracture, clidotomy, cut the clavicle. ये सारे last resort maneuvers हैं. Okay. All right. Fine. Okay. All right. Okay. So yes, I will be, if I speak in Hindi, I'll be speaking in English also. So don't worry about that. Okay. So these are the last resort maneuvers. And so correct option is Wood corkscrew maneuver. And this is a type of internal rotational maneuver. Now, next question. Now, there's a 25-year-old woman who came with unprotected intercourse after 5 days, right? Most preferred emergency contraception. So I'm missing the fourth option. Okay, I don't have the fourth option. Now, in this question, the trick was, or the clue was, that she's come after 5 days. Okay. So after 5 days, the hormonal methods, they are not good. They will not be effective as much. Okay. So your levonorgestrel pill can be given as soon as possible, preferably within 72 hours or 3 days. Okay. There is another hormonal method, which is ulipristal. Another method, ulipristal. Okay, now that can be given within 5 days, Okay, so that is also out. All right. And you're saying that the fourth option was misoprostol. Okay, so if the fourth option was misoprostol, that is also a hormonal method. So hormonal methods generally after 5 days will not be effective, right? So OC will be out. Hormonal methods are out. And we know that the most effective method of emergency contraception is copper T, right? So intrauterine copper containing device that can be introduced up to 5 days also, right? So it can be introduced even after 5 days. All right. So IUCD becomes the most effective. That is the reason why it is the most effective also. It can be introduced after 5 days. All right. And please also remember Mirena. Mirena is not an emergency contraceptive. Remember that also. Okay. Now let's have a look at the next question. Now, this is, I'm again missing 2 options. I again request you people, the good ones, please provide me with the options. Okay, what do you think? Now, there's a low risk woman. That means no other high risk factors, I think, were mentioned in the question. She's 38 weeks in labor. At 1 p.m., cervical dilatation is 4 centimeter. What was mentioned was good contractions. So she's getting good contractions. And at 5 p.m., she's 6 centimeter dilated. What should be the next step in the management? So one thing I am certain about, okay, is at this point in time, what we do see is, okay, from 1 p.m. to 5 p.m. So in 4 hours, she has progressed from 4 centimeter to 6 centimeter. Okay, and the contractions are good. Okay, now in our discussions also, we have discussed that when attempting clinical questions, see, this is not straightforward modified partogram that they are asking you. And we discussed that for the clinical questions on labor management, we generally follow what is recommended by the ACOG, what is also recommended by the latest WHO guidelines also, right? So she is not beyond 6 centimeter. Okay, so she's still at 6 centimeter. So at this point in time, this would be considered as latent phase only. So this is according to the clinical ACOG guidelines. Okay, where we said that from 0 to 5 centimeters, she's still in the latent phase. And when she has crossed more than 6 centimeters, then she goes into the active phase, right? Fine. And when she is in the active phase, then we say slow progress, right? Or arrest in dilatation. Then these diagnoses are made. So at this point in time, even if you don't remember this, there's no problem. If you use logic and common sense, there's no high risk factor. The progress is there. Progress is definitely there, right? From 4 centimeter to 6 centimeter, and contractions are good. So at this point, immediate cesarean section is definitely not an option. And what we should do is, I would say, allow to progress. Now, I don't have, option number C and D. Otherwise, I would have been able to discuss this question a little more better. Was it oxytocin? I'm not sure. Was it ARM? I'm not sure. So even if oxytocin was in the option, the contractions are already good, right? So I would not say oxytocin. ARM to be asked as an option, if they're asking ARM as an option, they would have provided you some information about whether membranes are present or not. So the question and the recall is sort of incomplete. So that's why it's getting difficult. But okay, ARM plus wait for 4 hours. So Ankit, if that is there, then that could also be an option. ARM plus wait for 4 hours, if that is an option. ARM plus wait for 4 hours. Then what was the status of the membranes given? Membranes were present or not? Membranes were present or not? Okay, Divya is saying it was ARM also, wait for 4 hours with oxytocin. Baba, oxytocin nahi chalega abhi, because no oxytocin. With good contractions cannot be made best contractions. If the contractions are good, there's no need for unnecessary oxytocin. So oxytocin is out. So if the option was ARM plus wait plus oxytocin, if this was the option, then this is also out because oxytocin is not needed. Was the fourth option assessed for malposition or CPD? Was the fourth option assessed for malposition or CPD? Was this in the option? Was this in the option? I'm waiting, Divya, Ankit, those of you who have been responding, was this in the option? ARM, wait for plus oxytocin, you have given one option to me. The other option you're saying, we're not still ready with the fourth option. So until we have the fourth option, it becomes very difficult to judge what the answer to this question should be, actually. So if assessment for malposition or CPD was mentioned, this would have been the priority thing. This would have been a better answer if this was the option. So I'm not sure if this was the option. So if you're saying if this wasn't the option, then I would say allow to progress. Okay, so shall we move ahead? Because as far as I remember, only these 4 were there. Okay, Divya. So you're saying that this wasn't there. Okay, so this wasn't there. See, okay, let's clarify this once and for all. If watching for CPD and malposition, if that wasn't in the option, then you will also have to tell me if membranes were given present or not. Because if membranes are already ruptured, then ARM has no use. ARM can't be done if membranes are already absent. If membranes are already absent, their ARM cannot be done. I think the best answer to choose is allowed to progress. Allowed to progress. Because both kind of interventions are fine actually. ARM and oxytocin depending upon contractions. Oxytocin is out because contractions were already mentioned as good. Okay. So we'll move ahead with the next question then. Maybe at a later point in time when we get the full recall with the full stem of the question, all the options, then at a second point in time, we'll be able to discuss this question even better. All right. Now the next question, fairly straightforward question. If anybody recalls any options later part, in the end also you can give me your feedback. Now, the maternal part of placenta is made up of what, right? So the answer to this question was decidua basalis. Okay. So you know that the placenta arises from two sources, fetal and maternal, right? The fetal part of the placenta is the chorionic frondosum. We know that chorionic frondosum. Chorionic frondosum forms the chorionic plate. So I think one of the options was chorionic plate. One of the options was chorionic plate, right? And decidua basalis is the maternal component of the placenta. The other maternal component in the placenta is the maternal blood in the intervillous spaces. Okay, maternal blood in the intervillous spaces is another component. I think that was not in the option. I think fourth option was, I think, decidua parietalis. Okay, you know that decidua parietalis is this. The rest of the decidua is the decidua parietalis, right? And the decidua capsularis, remember that? This is the decidua capsularis. This is the decidua capsularis. Decidua capsularis, decidua parietalis, and diffuse later to form the decidua vera, right? So anyways, this was a straightforward question. Answer is decidua basalis. So we'll move ahead. Again, straightforward one-liner question. What is the dose of iron folic acid prophylaxis in pregnancy according to the Anemia Mukt Bharat scheme? This is also a repeat question. 60 milligrams of elemental iron and 500 milligrams of folic acid. This is supposed to be taken daily. This is a single tablet containing both the drugs, right? And it is to be given for 180 days. 180 days starting from the second trimester. From second trimester onwards, right? So answer is straightforward, okay? One-liner question. Now, next question. Male partner treatment in women with male partner treatment needed in women with which of the following infections? Okay, so the woman is having a genital infection and male partner treatment is needed in which of those? So Candida is usually not a sexually transmitted infection, so it's not needed. And bacterial vaginosis is not a sexually transmitted infection, so not needed. You could have gotten confused between herpes and trichomonas because both are sexually transmitted infections. Okay, but partner treatment is definitely needed in trichomoniasis. So that is your answer. Okay, with herpes, once a person, whether a woman or whether a man, once a person gets infected with herpes, that person remains infected for life. Okay, and what happens is patient keeps having repeated or recurrent episodes of ulcerative lesions on the genitalia, and that episodes needs to be treated. Okay, so when you have a woman with herpes, identified a woman with herpes, her partner will be tested for herpes. Okay, but if the partner is asymptomatic, at that point in time, there is no need for partner treatment. Got it? Right? So that is the logic. Okay. Now, next question. Woman with curdy-white vaginal discharge, pseudo-hyphae seen on peripheral, pseudo-hyphae seen on smear. So I think this could be the wet smear of the discharge, or it could be the KOH smear, whatever was mentioned. The moment you see pseudo-hyphae, the moment you see curdy-white vaginal discharge, we have done this again and again. Answer is candidiasis, right? So genital infections is such a commonly asked question and often repeated question, okay? So, and this was discussed by the Dr. Mamta as well earlier, I was watching, right? So we've discussed this in the recent, FMG revision that we had, right? So with bacterial vaginosis, you have a thin gray white foul smelling discharge, itching is absent, right? Clue cells are present on wet smear, and whiff test is otherwise positive. The gold standard is gram staining, but that is something that is usually not done in clinical practice, right? Candidiasis, curdy white discharge, fungal pseudo-hyphae can be seen. Vaginal pH is acidic. Okay, and trichomoniasis has this greenish white for the discharge, greenish yellowish, strawberry cervix or vagina, and these motile flagellated organisms with tennis racket appearance, they will be seen on the peripheral smear. And like you said, Amsel's criteria is used for the diagnosis of bacterial vaginosis. Amsel's criteria is used for the diagnosis of bacterial vaginosis. That was another question, right? Right, you are. Okay. Now, next question. A pregnant woman complains of dizziness, or I don't know, the language of the question was dizziness or fainting, right? So anyways, complaints of dizziness on lying down that improves on turning to one side. This is a repeat question. This is a repeat question. Possible explanation: a gravid uterus puts pressure on the inferior vena cava, because a gravid uterus is slightly tilted towards the right side. It is slightly dextro-rotated, isn't it? So IVC compression is the possible explanation. What does it cause? It causes the supine hypotension syndrome, isn't it? Supine hypotension syndrome. So the BP falls when lying down, isn't it? And that's why it improves when the woman turns to her side, okay? Now, next question. Gold standard investigation for endometriosis. Endometriosis is becoming their favorite topic in FMG these days. They're asking about symptoms. They're asking about cyst management. They're asking about treatment. Endometriosis is a hotshot topic these days. Anyways, gold standard investigation for endometriosis, repeat question. We know it is laparoscopy. Okay, the endometriotic deposits, they are best seen on laparoscopy, right? And that is how the diagnosis is made, in the gold standard investigation, right? Now, next question. Now, let's see. I'm not very sure about the last option for this question. Okay, now this is a question on male infertility. Now, let me tell you, for those of you who will be, giving, for those of you, yeah. So for those of you who are, answering my options, please correct me if the option, the number 4 that I have mentioned in the question is correct or no. Okay, if this was the option. So there's a male infertility workup patient and the semen analysis report is given 6 to 7% morphology, which is normal morphology, because morphology, normal morphological form should be at least 4%. So this is normal, okay. 42 million total count, right? So total count in the 42 million range is also, in the normal range, isn't it? Because see, the average sperm total count is somewhere around 160 to 120 million, right? But for the WHO criteria says that at least 39 million, right? So 42 million sperm count is also fine. Then motility 29% is definitely low. This is decreased. Motility 29% is definitely low. And Divya, you're rightly saying 25 million count per ejaculation. Yeah, 25 million count per ejaculation. Sperm count 25 million per ejaculation. How can it be the 4th option? 4th option was a condition, or what was the 4th option? What was the 4th option? They had asked you the diagnosis. So the motility is decreased. The motility is decreased 8% morphology was there. Okay. So even 8% morphology is normal morphology. 8% morphology, if you say, then that is also within the normal parameters. Okay. And you're saying 25 million count per ejaculation. Okay, 25. And there was another question regarding these syndromes. Okay, okay. Okay, so I've got, are you saying, Mir, that I've got two questions mixed up? Is that what you're saying? Is that what you're saying? Are these two questions mixed up? Mansoor? Okay, so both of you, Mansoor, Mir, and Divya, are of the opinion that the two questions are mixed up. Okay. All right, all right. So let us just discuss then that what was the question regarding these options that you are saying? What was the question regarding these options? Okay, another question, it was sinusitis, infertility, recurrent URTI. Then that is carcinogener. Then that is carcinogener. Male infertility. Yeah, you're right, RA. Sinusitis and recurrent respiratory infections. That is carcinogener syndrome. Okay. Yeah, so that is this. Right. And what about this question on semen analysis? What about this question on semen analysis? I think maybe then the question on semen analysis is which parameter is abnormal. Then motility 29% is definitely low, and that is an abnormal parameter. Okay? Fine. Motility, total motility should be at least 40%, right? So motility 29% is definitely low. So these were two separate questions. All right, got it. Chalo. Next question. Now, for a woman with mental retardation, who will give consent for MTP? MTP, again, we've seen the recent trends. Okay, we've done a MedEd NExT. I've done an entire update on MTP also. So for women with mental retardation, who will give consent for MTP? The law says, since they are asking about the MTP Act, okay, the Act, in the language of the Act, says legal guardian. That legal guardian could be a husband. Okay, that legal guardian could be a parent also, right? And so that's why I will not choose partner as the answer. Herself, she's not in that state. If she's, if she's deemed unfit mentally to give a valid consent, then she herself cannot give the consent. Doctor is in no position to give consent for the patient. So the language says legal guardian. So I would choose that answer. Okay. Next question. Now, this was tricky. The moment I saw this question, I think if these were the options, this was a really tricky question. Sorry. So again, I would like to ask Deepak, RA, Mir, and Divya, you're giving me a lot of good feedback. So tell me, 22 weeks pregnant woman with contraception failure, I don't know if OCP was mentioned, contraception failure, requesting for MTP. According to the latest MTP Amendment Act, what was the options? 24 weeks was mentioned. Now, this is again discrepancy. Yaar, bachcha, kya kare isme? 22 tha ki 24 tha? Okay, punishable offense, non-adherence to months, registered medical practitioner, government hospital. Okay, so if there is non-adherence to months, then it is a punishable offense. If a registered medical practitioner is not doing the procedure, okay, if a registered medical practitioner is not doing the procedure, then it is a punishable offense. Meaning, if I am not a registered medical practitioner, I don't have a valid degree, I cannot do. Okay, like for example, if one has to do a surgical procedure, surgical MTP, and one does not have an Obs Gynae degree, I cannot do. Right? Like that. Okay, so yeah, Sunil, your answer will change. Week idhar udhar ho jayega to. Right. So you're asking me, yeah, so this was not the question. So again, a lot of discrepancy regarding the question. Anyways, right. So you have to tell me, I'm answering what RA is mentioning to me. RA is saying punishable offense, non-adherence to months. Okay. So if one is not adhering to months, it's a punishable offense. Registered medical practitioner is not doing the procedure, it's a punishable offense. It has to be done in a center approved by the government. Okay. So by default, the district hospitals, the government institutions, the medical colleges, they are registered. But if it is a private setup, and that private setup has to perform MTP procedure, that has to take permission from the government, a certificate from the government. Right? Okay. All right. Yes, RA, registered medical practitioner. Let's say if it is an MBBS registered medical practitioner, that person needs to have a house job or house surgeon experience in Obs Gynae for at least 6 months. That is also correct. Okay. And anyways, now that I've put this question here, let us see. With 2 doctors' opinion, the MTP can be done between 20 to 24 weeks. Okay. And it can be done if congenital anomaly is there in the fetus, then it can be done till 24 weeks. Okay. And there is no role of a permission from a hospital superintendent. But if in exceptional circumstances, like there's a congenital fetal anomaly, if there is a fetal anomaly and it is more than 24 weeks, then permission needs to be taken from a medical board. Okay, fine. So if the question was framed like this, 22 weeks pregnant woman with OCP failure requesting for MTP, according to MTP Amendment Act, the MTP could be done if congenital anomaly in the fetus is there. For contraception failure, let me tell you, MTP is allowed till 20 weeks. So if the indication is contraceptive failure, you can't do it beyond 20 weeks. For the first 20 weeks, opinion of one doctor is enough. So for contraception failure, MTP is allowed till 20 weeks, right? And there was an option mentioning court. वो court वाला अब नहीं होता. Now the MTP Amendment Act, the patient need not go to a court. वो medical board है. It is medical board now. Okay. Sometimes even now, I mean, rarest of rare circumstances, if even a medical board refuses and the patient goes to court, that is another matter. Right. So, Sunil, I agree. It's a tricky question. I have a question in front of me, but you guys are telling me that it wasn't framed like this. So, you know, again, it's recall what can be said about this question. But we've discussed all possible options with you, right? So we've discussed all possible options with you. All right. Any doubts regarding this question? Any more doubts regarding this question? Otherwise, I'll move to the next question. Okay. If this was the question, let me repeat my words. If this were the question, okay, Mansoor saying it's the same, but exact answer, please. If this was the question, 22 weeks pregnant woman with OCP failure requesting for MTP, for contraception failure as an indication, you can't do. Okay, for contraception failure, MTP is allowed only till 20 weeks. She will have to fit into some other indication. Okay, so 22 weeks pregnant woman, contraception failure, no contraception failure, doesn't matter. If congenital anomaly in the fetus was there, then only I would consider doing. Just for contraception failure, it is not allowed beyond 20 weeks. Okay, chalo. Hypertensive pregnant woman on treatment of asthma, which medication is given? Now, this is pharma plus Obs Gynae mixed question. So we all know that labetalol is the drug of choice, but pharma mixed here, labetalol causes bronchoconstriction, so it cannot be used in a woman who is already getting treatment for asthma. So labetalol is out. Captopril or ramipril, whatever was given, these are ACE inhibitors. They are contraindicated in pregnancy, not given. Nifedipine is safe. Nifedipine is a first-line drug. Okay, it may not be the drug of choice, but it is still a first-line drug, and there's no contraindication for asthma as such. So nifedipine is the choice. Next question. Pregnant women with ultrasound showing placenta near cervix at 20 weeks. So she's only 20 weeks and there's, placenta near the cervix or marginal or whatever language was given. Okay. What is the next step in management? The next step in management will be, we will repeat the scan at 32 weeks to reconfirm the location. Okay. Maybe at 32 weeks, the placenta is no longer near the cervix. Okay. Right. So we will wait and we will repeat at 32 weeks. Whether we do a vaginal delivery, that will depend upon where the placenta is ultimately at that point in time. Now, in the third trimester, near to her time of delivery, at that time, what is the location of placenta? That will decide the mode of delivery. So whether normal delivery, whether cesarean, it will be decided at a later point in time, not right now. Okay. So wait and repeat ultrasound at 32 weeks. That's your choice, and I'm not having the last option here. So if you have the option, please give it to me. If you remember, recall. Yeah. All right. Okay, Mansoor, if it is 20 weeks or it is 22 weeks or it is any time in the second trimester, it doesn't matter. We will have to repeat the scan again at 32 weeks. Okay, that will not change your answer. Next question. So you were mentioning there was a question on Turner syndrome or yeah. So a young girl. Now I'm again, now again, quick recall has been done. So I don't know if these were two separate questions. Okay, but I know something was asked on Turner syndrome like this. So a young girl with delayed puberty and absent secondary sexual characters was diagnosed with Turner syndrome. What is the karyotype? So I think one question was when they had asked the type. I think these were two separate questions. Question number one was what was the karyotype? So karyotype is 45XO. Okay. And the other question was what additional feature can be seen? Okay. Okay, Deepak, thank you. I'll just quickly go back. He's saying the last option was scan at 38 weeks. Yeah, so that would not be the answer. No, scanning at 38 weeks is too late. 38 week scan is too late. Think about it. You want to do a scan at 38 weeks and, in the meanwhile, she bleeds at home in the third trimester. No, so we have to do it at 32 weeks. Okay, 32 weeks is the answer. Coming back to the question, Turner syndrome, what additional feature can be seen? So one was mentioning about monosomy X. So ye ho gaya na bacha, monosomy X. Monosomy X, 45XO, monosomy X, same thing. Okay. What additional feature can be seen? So in Turner syndrome, what are the features? Vichy short stature, webbed neck, right? Wide spaced nipples, shield chest. Okay, cubitus valgus, infantile external genitalia. There's an infantile uterus, streak ovaries. Intelligence is usually normal. And at a later point in time, these women are also prone to have, thyroid disorders, autoimmune thyroiditis and hypothyroidism, cardiovascular anomalies like bicuspid aortic valve, coarctation, renal anomalies like horseshoe kidney, osteoporosis later on in life because they have no source of estrogen in their body. Okay, so this covers, I think, widely spaced nipples was the option that was correct. That is what feedback was given to us by most of the students, that from all other options, widely spaced nipples was the answer. Okay. Next question. Woman undergoes abortion at 11 weeks, POG, RH negative. What is the dose of anti-D? Now you'll have to give me a feedback. You'll have to give me a feedback. I know for sure that they had mentioned 11 weeks POG. They had mentioned RH negative and they had asked for the dose of anti-D. Okay, whether or not they had mentioned abortion, I'm not sure. Whether or not they had mentioned abortion or not, I'm not sure. But that doesn't actually matter because the dose of anti-D is determined by the period of gestation. So dose of anti-D in the first trimester, any procedure also if you're doing in the first trimester, you're doing surgical MTP in the first trimester, medical abortion in the first trimester. So before 12 weeks, okay, before 12 weeks, the dose of anti-D is 50 micrograms. Okay, so you're saying 100 micrograms was also in the option. That is not the dose. Full dose is 30 micrograms. So beyond 12 weeks, if any sensitizing event happened, beyond 12 weeks, abortion happens. Beyond 12 weeks, you do amniocentesis. Beyond 12 weeks, abruption happened. Beyond 12 weeks, anything happens. Okay, and also during delivery, then you have to give full dose. So full dose is 300 microgram. 300 microgram is the full dose. Okay. How can it be? Agar yaar, if 11 weeks tha amniocentesis nahi ho sakta, we don't do amniocentesis at 11 weeks. If 11 weeks was there, we can't. It must not have been amniocentesis because amniocentesis is not done. Is not done in the first trimester. We don't do amniocentesis. Okay. In the first trimester. So 11 weeks ke saath ho sakta. If you are saying there was a procedure, maybe it was chorionic villus sampling. Okay, the dose of anti-D below 12 weeks of gestation is 50 microgram for a sensitizing procedure. Okay. Next question. Correct sequence for physiology of lactation, or maybe the language of the question was possibly, in breast milk secretion, but they had asked about the correct sequence of events. Events were mammogenesis, lactogenesis, galactokinase, galactopoiesis. So this is the correct sequence. The correct sequence is A, B, C, D. Okay. For recall, I have mentioned them one after the other. They may have been given, in another order in the question. Okay. So mammogenesis is preparation of the breast tissue. Okay, growth of breast alveoli, growth of duct, preparation of breast tissue that happens throughout pregnancy. Mammogenesis, that happens first. Then lactogenesis, synthesis and secretion from breast alveoli starts, lactogenesis. Then galactokinesis is ejection of milk, okay? And galactopoiesis refers to maintenance of lactation. So this is the correct sequence. This is the correct sequence. And that was the answer. Mammogenesis, lactogenesis, galactokinesis, and galactopoiesis. Next question. Management of uterine inversion. Okay, so I think the options were name of procedures. Okay, I think the option was name of procedures, and manual reposition by Johnson's method is something that is the first procedure that we do. Manual reposition by Johnson's procedure. Other procedures for uterine inversion are tried when manual reposition fails. Like for instance, other procedures for uterine inversion are O'Sullivan's hydrostatic method. O'Sullivan's hydrostatic method, Halton's procedure, Huntington's procedure. These are procedures that are done much later. First Johnson's, then O'Sullivan's, then that also fails. Then we try the other abdominal surgical methods. So manual reposition, I think most of you must have attempted it correctly. Now, Deepak, you're saying there was one question about nuchal translucency done at which week? Nuchal translucency is done in the first trimester, anytime between 11 to 13 weeks, 6 days. Nuchal translucency is seen between 11 to 13 weeks, 6 days. Okay, fine. In POPQ system of prolapse classification, what is the reference point? Straightforward question. This is also a repeat question. This has been asked in EPG also. Hymen is the reference point of POPQ system of prolapse classification. Nobody expects undergraduate students to know the details of POPQ. This is pelvic organ prolapse quantification. Okay. and the reference point is hymen. Okay, now uterine inversion, you are saying blood transfusion was another option. So blood transfusion will be done, of course, will be done if the patient is bleeding. If the patient is actively bleeding, then of course blood transfusion will also be done. But so if blood transfusion was in the option, then I would say blood transfusion will be done if patient is bleeding. Blood transfusion will be done if patient is bleeding. If they have specifically asked about the procedure, then the procedure that we do first is manual reposition. Okay. Dr. Arif, ये POPQ system of prolapse quantification, I think इसी का, this was the landmark that they asked. I think this was the landmark or this was the reference point that asked whether anterior fornix, whether posterior fornix, the landmark or the reference point for the classification of prolapse types based on the POPQ system was hymen. The answer is hymen for that. Okay. Now, the next question is not basically straightforward a gynae question, but again, since NExT, we talk about that also. You can answer this from your knowledge of embryology also. Okay, NExT results from failure of neural tube closure by. So, neural tube closure gets completed by 4 weeks. Okay, so NExT results from failure of neural tube closure by 4 weeks, exact 28 days. Okay, okay, so we're still stuck up on the uterine inversion of question. Removal, okay, very good. I mean, you're giving me options. Removal of placenta. Removal of placenta. See, if uterine inversion has happened, and the placenta is still not separated on its own, okay, let's say uterine inversion happened, placenta is still attached, okay, then we don't remove the placenta. We reposition first. And then we will remove the placenta by controlled contraction. But priority is given to repositioning. Okay. Fine. All right. So we've received 3 options in this question. Okay, Dr. Arif, you're saying they gave image of NExT and one option was incomplete closure of neural pores. Okay. So if that was the case, they gave image of NExT. NExT happens because of complete failure of neural tube closure. Complete failure of neural tube closure will result in NExT. Okay. Complete failure of closure of neural pore. All right, because incomplete closure of this neural pore or neural tube gives rise to different sort of neural tube defects like encephalocele, meningocele, meningomyelocele, spina bifida. These are all different types of neural tube defects where there is, incomplete closure of neural pores. Now, depending upon how much of the neural pore closure took place, at what time, then it will be decided. Complete failure of neural tube closure will give rise to NExT. Okay. Next question. A newborn has swelling over the head after delivery. Identify this condition. Okay. Identify this condition. Okay. Arif caudal pole was there. Okay. See, cranial end. NExT is at the top. So failure of closure of the cranial end, not the caudal end. In the caudal end, then spina bifida. Nahin. So cranial end. All right. Now, newborn has swelling over the head after delivery. Identify the condition. Now, the options were cephalhematoma, caput succedaneum, subgaleal hemorrhage, or encephalocele. I think they had given us swelling to one side of the scalp. Okay. If the swelling is towards one side of the scalp, then it is cephalhematoma. Caput succedaneum is the midline swelling. Okay. Galeal hemorrhage, subgaleal hemorrhage is also can cross the suture lines, and encephalocele is also a midline swelling. So, so answer is cephalhematoma because it is towards one side. Okay. So caput succedaneum, as you can see in this image, was a midline swelling. Okay. It is above the periosteum. It crosses the midline. Cephalhematoma is below the periosteum. It does not cross the suture line. Next question. There's a 68-year-old woman with complaint of passing urine while coughing. What is the diagnosis? So I think the symptomatology was suggestive of stress urinary incontinence. Okay, so answer to this question is stress urinary incontinence. Stress meaning few drops of urine and involuntary leakage of urine happens when there are activities done like increase intra-abdominal pressure, like for example coughing and sneezing and laughing too hard as well. So this was the question. So if doing physical activity, okay, even if doing physical activity, same thing. Physical activity like exercising, physical activity like lifting weights, that also increase intra-abdominal pressure. So stress urinary incontinence, your answer would have been the same. All right. Next question, screening for diabetes in pregnancy. What is the dose of oral glucose load that is given? Answer is 75 milligrams. Okay. So we follow in the Government of India DIPSI guidelines also. If we are doing the international guidelines also, it is 75 milligrams. Okay. All right. So 75 milligrams, one step OGTT, even according to the Government of India DIPSI guidelines, or whether we follow the WHO guidelines, it's 75 milligram oral glucose load. Okay. Now, is there a question on GTN or choriocarcinoma? I'm not sure. So you'll have to tell me if there was a question on GTN or choriocarcinoma. Was there a question asking cannonball metastasis? Cannonball metastasis in the lungs, they are seen in GTN. Okay, they're seen in choriocarcinoma. Choriocarcinoma is the most common type of GTN. Okay, so if that was the question, GTN, or if or choriocarcinoma was the option, that is your answer. Okay. Next question. Was there a question on ovarian torsion and investigation for ovarian torsion? Was there a question on ovarian torsion and investigation? You'll have to tell me. Bacha, Mansoor, shoulder to shoulder, we've already discussed. Ovarian torsion investigation had they asked the best investigation or the NExT investigation? See, the investigation that we usually use in clinical practice is ultrasound Doppler. Okay. And Robin, you're saying testicular torsion. So now there is again a discrepancy. Was it testicular torsion? If it is testicular torsion, I'm not the best person to answer that question because it goes beyond my capability to manage testicular torsion, right? The surgeon will be able to tell you better. But with ovarian torsion or investigation that we use is ultrasound Doppler. Ultrasound Doppler is also most of the times, ultrasound can only tell us if there's an ovarian mass. Whether or not torsion is there or not, ultrasound may not be very helpful. Even CT scan for that matter may not be very helpful for ovarian torsion, right? So ovarian torsion for us is mainly a clinical diagnosis. We use the clinical findings of the patient, ultrasound Doppler, and if the clinical suspicion is very high, we operate on the patient. Okay. All right. All right. So USG Doppler would be the go-to investigation. USG Doppler would be the go-to investigation to begin with. Okay, in ovarian torsion. So that finishes my recall. If there are any last moment questions, please ask. Otherwise I will hand over to the next oncoming faculty. I will hand over to Dr. Santosh.
Hello, ma'am. Thank you for a very wonderful recall session. I think, guys, almost all the questions that had appeared in the exam have been touched upon by Dr. Shonali, ma'am.
Yeah, but we will have a
question
more,
that is not addressed, you can ping us on the Telegram and we will take it from there. Okay, so next up we have Dr. Manjunath, our faculty for forensic medicine, and he will be taking you through the MCQs from forensic medicine. Over to you, Dr. Manjunath. I guess I'm audible. You're live and you can go ahead with the questions.
Yeah. Am I audible?
You're audible. You can go ahead with questions.
Yeah. Thank you, Dr. Santosh. Without wasting time, let's discuss FMT questions asked in the exam. So the question number 1, it was about the seminal stain. The question was, dried old seminal stain can be identified which have not undergone putrefaction. Options are acid phosphatase, Takayama test, Teichmann test, Barberio test. As you know, Takayama test and Teichmann test, they are the test for the blood stain. So that is not the answer. So it is not Barberio test also. The answer is acid phosphatase. It is also known as Brentalamen blue test, one of the commonest tests for the seminal stain. So the answer is acid phosphatase. The question number 2, it was about the snake bite. Again, repeat question. We discussed many times in our classes. A 20-year-old boy with a history of snake bite drowsy and drooping of eyelids, breathing difficulty was brought at OPD. What is the next step you do? So here, history of drooping of eyelids, ptosis, that means it is a neurotoxic snake. So the immediate treatment is give polyvalent antivenom immediately. B is the correct answer. It is not incision and drainage. It is not the tight tourniquet. The answer is B is the correct answer. The question number 3, caliber of barrel in rifled weapon is. So the options are distance between two opposite lands, distance between two adjacent land, diameter of barrel, number of lead ball from 1 pound of lead. The caliber in case of rifled weapon is the distance between two opposite lands. So the answer is A is the correct answer. Not B, C and D. If the same question asked caliber in case of shotgun, the answer is number of lead ball from 1 pound of lead. That's about the question number 3. Question number 4. Consent for MTP, medical termination of pregnancy, in case of mentally retarded girl of age 22 is given by. So mentally retarded. So the answer is very, very simple. Legal guardian. It is not her partner, not herself, not the doctor. A funny question asked. The answer is legal guardian. Question number 5. Treatment of datura poisoning. You can see the datura fruit here. You can see the spiny projections over the fruit. It is nothing but thorn apple. As it contains hyoscine, hyoscyamine and traces of atropine, the treatment is physostigmine. So the drug of choice is physostigmine. It is not atropine. Atropine is used in OP poison. Sodium nitrate used in cyanide poison. It is not neostigmine. Answer is physostigmine. Cardiac arrhythmia is one of the common side effects. Next. Question number 6. Treatment of spinal poison, that is the strychnine poisoning. As you know, strychnine that causes convulsions. It causes rhizus, sardonicus, opisthotonus, pleurostotonus and all. So the answer is short-acting barbiturate is the correct answer. Flumazenil, that is used in benzodiazepine poisoning, that is not the answer. Atropine is the drug of choice in OP poison, not the answer. Physostigmine used in datura poisoning, not the answer. So answer is short-acting barbiturate. Question number 7 from forensic psychiatry. Patient believes that he is referred to by all the agencies, media and the person. It is commonly seen in schizophrenia, and this delusion is a disorder of thought that is known as delusion of reference. So the answer is B is the correct answer. It is not delusion of double, not Capgras syndrome. Nihilistic delusion, they are seen in depression, also known as Cotard syndrome, not the answer. Answer is B, delusion of reference. And the last question, the question about a patient came with a head injury and the diagnosis is, you can see here, crescent-shaped hemorrhage. Crescent-shaped hemorrhage, that is STH is the correct answer. STH, because of the bleeding from bridging vein. So that's it about the question from forensic medicine. Thank you, Dr. Santosh.
Thank you, Dr. Manjunath. That was short, crisp, and sweet. So students, I think you got the answer for most of the FMGE questions on forensic medicine. So thank you, Dr. Manjunath, for connecting with us.
Welcome, Santosh. Good night.
Yeah, if there are any corrections or more questions from the forensic medicine, you can share it with us on the Telegram. Dr. Manjunath would address
Yes,
it.
yes, sure.
Okay. So now Dr. Manjunath will be dropping off, and connecting with us next is Dr. Vinesh Srivastava. He is our faculty for anesthesia, and he will be taking us through the questions from anesthesia. Dr. Vinesh, welcome, and over to you. Over to you, Dr. Vinesh.
Good evening, sir. I'm audible and visible now? All fine.
Very much audible and visible. You can go ahead with the questions.
Yeah, I'm visible and audible, right?
You're visible. You're audible.
Yeah. Okay, sir. Okay, sir. Okay, students. So here we will start with the anesthesia recall session. What I could find out was almost 4 questions. Plus, there is one question which is like query with medicine and all. But I'll just discuss the questions as fast as I can. These are questions that we could find out. The first question, fairly simple question. Everyone knows this one. It's a question which has been repeated again and again. The first question is in epidural anesthesia. If there are any questions or doubts, you can ask me here itself. I'm looking at the messages also. So in epidural anesthesia, which of the following layers is not pierced? Options given were supraspinous ligament, interspinous ligament, arachnoid, and ligamentum flavum. So the correct answer to this question is option C, arachnoid. So when you speak of the epidural layers, of course, the first layer is skin, then you get the subcutaneous tissue, then you get the supraspinous ligament, interspinous ligament, ligamentum flavum. As soon as you cross ligamentum flavum, you reach the epidural space. After the epidural space, you get the dura, you get the arachnoid, and then there is a CSF where you give the spinal. So in epidural, when you're giving, what you're puncturing is the skin, subcute, supraspinous ligament, interspinous, and ligamentum flavum. You are not puncturing the arachnoid. So the correct answer here is option C. So the first question that we got from anesthesia. Okay. Next question. A young patient, again from the local anesthesia and spinal part of it as well, regional anesthesia basically. A young male patient was given brachial plexus block with 0.5% bupivacaine. The patient suddenly became hypotensive and had arrhythmias. Which of the following is the best first-line management for this patient? So the options given were invasive ventilation, intralipid infusion, soda bicarb, and dobutamine infusion. So I think I'm not very sure about the fourth option though, but 3 options were the same. The fourth option, not very sure about it. So the correct answer to this question is option B, intralipid infusion. Here, the patient has been given a brachial plexus block with 0.5% bupivacaine. So what has happened is, instead of giving the block into the tissue from where it is going at the nerve, what has happened? The block has suddenly gone, or the drug has gone in the blood vessel. So the local anesthesia drug has gone in the blood vessel. What you have given is bupivacaine. And remember, when we speak of bupivacaine becomes the most cardiotoxic local anesthesia drug. Okay, so this becomes the most cardiotoxic. In this case, you get convulsions at the same time as arrhythmias, and arrhythmias are seen very front. Normally, what happens in local anesthesia systemic toxicity, convulsions are seen before arrhythmia, but with bupivacaine, you find arrhythmias and convulsions occurring almost at the same time. And when you see at the management, this is the 20% intralipid, which is being used. Intralipid treatment is a new thing which is there. Apart from that, you can use boluses of ADR also. So not going into too much details, but the correct answer to this question is option number B, intralipid infusion. That was the second question. Dr. Devendra Singh says LA toxicity. Correct, Dr. Devendra. LA toxicity was the question. This was on local anesthesia systemic toxicity, right? And nowadays with bupivacaine, 20% lipid infusion is one of the frontline treatments for that. Okay. Next, question number 3. Which of the following agents has blood gas partition coefficient similar to nitrous oxide? Okay, so the options were halothane, isoflurane, desflurane, sevoflurane. But a lot of students also told me, sir, one of the options was xenon, but few of them said, no, it's there, it's not there. But this question is based on the inhalational agents. 2 years back, they had asked about the minimum alveolar concentration, and this time they've asked about the blood gas partition coefficient. So blood gas partition coefficient is about the solubility of the inhalational agents. So when you speak of the blood gas solubility, this is what determines the onset of effect, how fast it is working, and the recovery of the inhalational agents, onset and recovery. So when you speak of the solubility, it is inversely proportional to the onset and recovery. And so we remember, methoxyfluorine, halothane, isoflurane, sevoflurane, desflurane, nitrous oxide, and xenon. So these are the things. So if you will see what we remember, this is how we remember. So we go in this manner, right? So here you will find nitrous oxide is the one which is the least soluble out of them, which we are discussing over here, right? The solubility is not there. Methoxyflurane is the maximum soluble. This is the least soluble. Because methoxyflurane is maximum soluble, it has got slow action. And on the other hand, nitrous oxide has got a fast action. So that's why you'll find the closest question that comes here is desflurane. However, if they have given xenon as an option, I will rather like to stick with xenon. But from what the students have said, if the answer is desflurane is what was given, then the correct answer becomes desflurane. So Dr. Arif is saying, no sir, it's not there. Halothane. नहीं, halothane का same नहीं है ना. देखो, so there are two. Okay, so if there are other options, Dr. Arif kindly correct me. Dr. Arif Anwar is saying halothane. So halothane एक option तो है ना. See, one option given is halothane. That is there, no doubt about it. अच्छा, Dr. Halothane is there, xenon was not there. So these are the four options given to you, right? So ठीक है. Let's cancel the xenon part out. Okay, got it, Dr. Arif. Dr. Arif got it. So इसमें जो correct answer है ना, that is halothane, isoflurane, desflurane, and sevoflurane. 4 agents were given to you. 4 agents. So remember, out of these 4 agents, halothane, isoflurane, desflurane, and sevoflurane. Sevoflurane and desflurane. So halothane out of them is the maximum soluble. It becomes soluble in the blood. Because it is soluble in the blood, the onset of action becomes slow. On the other hand, desflurane is the least soluble. So therefore, the one which has maximum solubility will have more blood gas partition coefficient. On the other hand, desflurane has the least. Therefore, it is comparatively a faster acting drug in terms of onset. And that is why, remember, all of you remember, right? D for desflurane and D for daycare anesthesia. In case you want to use an inhalational agent, it is desflurane that becomes the drug of choice for daycare anesthesia, right? It's the fastest onset amongst all of them. So if these were the 4 options given, then the closest one that would come to nitrous oxide would be desflurane. So we will stick with option number C, desflurane as the correct answer. Okay, next question. Which of the following is not an indication to use BiPAP? Obstructive sleep apnea, unconscious patient sedation, high PCO2, and low oxygenation. So BiPAP is a non-invasive means of ventilation. Non-invasive ventilation. Non-invasive ventilation means you are using it in a patient who is unable to breathe or having difficulty in breathing. So if the patient is having difficulty in breathing, it means the PO2 may be low, means the PCO2 may be high. So in that case, BiPAP for a patient, especially for a patient of COPD, would become a choice, right? So therefore, these options definitely are correct. I will be using it with low PO2, I can use it. For PCO2 also I can use it. At the same time, it is one of the treatments for obstructive sleep apnea, people for that. But in an unconscious patient or a patient who's heavily sedated, you can't be using BiPAP because it is non-invasive means of ventilation, which means the patient will be breathing spontaneously on his or her own, which means the BiPAP, what it is doing is, it is just helping or supporting the breath of the patient, right? That means patient has to be breathing spontaneously if you're using the BiPAP or if you're using a CPAP. You cannot be using it in an unconscious or sedation patient. So therefore, the correct answer to this question is option number B. In an unconscious or a patient who is heavily sedated, you cannot use BiPAP. But for other things, obstructive sleep apnea, high PCO2 and low PO2, you can use BiPAP, right? Dr. Devendra Singh says B. Correct. That was the correct answer. One more question, right? And this, I did not get the options correctly, but I think even medicine also it will be discussed. Emergency management of the following ECG. An ECG was given, and this turns out to be mostly ventricular tachycardia. The options given were adenosine, amiodarone. 2 options, I don't know. Now, this normally, yes, of course, it will fall into medicine point of view. But if you look at the ACLS points, remember, if you're getting ventricular tachycardia, guys, you can classify that into two types, na? Patient having pulse or patient not having pulse, maybe pulseless. So let's take the first point is if the patient is pulseless or if the patient has pulse. If the patient is pulseless and patient gets pulseless ventricular tachycardia, for that, you will defibrillate the patient. Defibrillation. That is the first thing you will be doing in emergency. You get pulseless ventricular tachycardia, you will defibrillate. Now, if you get pulse in the patient, guys, this goes into two types. Whether the patient is stable, or let's put it this way, patient is unstable, or the patient is stable, depending on the hemodynamic parameters. If the patient is unstable, in this case, you will go first with a cardioversion. Sorry. You will be using a synchronized, basically, synchronized cardioversion and adenosine. Right? That becomes for unstable ventricular tachycardia. Dr. Arif says, sir, ST elevation was seen in DCG. Okay, I'm just giving this point so that maybe doctor, it will be get medicine of discussion hoga to tumhara clear ho jayega. Let me just finish off 1 second. I'll just finish it off. If it is stable, in that case, guys, all you are doing is basically vagal maneuvers. The same adenosine can be used here also, and infusions of amiodarone can be started. Right? So I'll not go into too much detail, but these were the 2 points which I did not get. So I was thinking, in case it is pulseless, then maybe defibrillation or cardioversion could have been given an option. And if they are given a clinical scenario, then maybe the question changes. So that was the things from my point. When we get proper question, proper stem, proper options, we'll come again with all these things. But these were points from my anesthesia point of view that I could discuss. And over to you, Dr. Santosh. So I'm done with this. Thank you, guys. If there are any questions, you can ask me.
Thank you, Dr. Vinesh. I think you have touched upon the key points that
thank you, guys,
needed to know.
So if there's any question, I'm there.
Yeah, so Dr. Vinesh will be holding on for a few seconds. If you have anything to shoot, you can shoot on the chat box. So if there are no more questions, then we will move on to the next subject.
Right, sir.
Okay, so I guess I think most of the students' queries are addressed. So we will move on to the next person. So our next faculty in line is Dr. Murugan. So he's a faculty for preventive and social medicine. And as you all of know, that PSM always takes a heavy weightage to the FMGE exam. So he will be taking over. Dr. Vinesh, you can drop off. Dr. Murugan will take over. Dr. Murugan, over to you. So you can start with the questions. You're loud and audible. Your video is clear.
Okay. Thank you, sir. Hello, students. Am I audible?
You're audible, sir.
Okay. Hope I'm audible. Okay. So we have some more questions are there from this PSM. Okay. As far as we are concerned, most of the questions, almost all the questions we have discussed in the video as well as in the class. So we'll start with the first question. Okay. What is this disaster cycle sequence? I'm not giving options. Okay. Whatever I got, based on that, we have starting it. So disaster, we will have impact will be there. This is the sequence. Impact, response phase, relief phase, rehab phase will be there. Then we can take some mitigation measures. Mitigation measures we have. Then preparedness. Okay, so the sequence should be there. If this is the sequence, then this is the answer. Okay, so it should be the first. It should start with impact, followed by response phase, relief phase, rehab, mitigation, and preparedness, guys. Okay, it's a straightforward question. Okay, which is answerable, easily answerable. Okay, fine. Next. The next question is global hunger index. Which are the following is not part of it? Okay, fine. So global hunger index, okay, is measure the hunger index based on these 3 parameters. So these are the 3 parameters we use. Okay, proportion of undernourished children, less than 5, under 5 children nutrition. Okay, less than 5 years. Percentage of children less than 5 years or undernourished in terms of stunting or wasting, and under 5 mortality rate. Okay, these are 3 parameters that is part of it. Anything that is given beyond this, it is considered not part of this parameter. Okay, so only these 3 are part of this. Okay, global hunger index. India is not performing good in this global hunger index. This we have discussed in the class itself, guys. Okay, we have the video. Triage. It's a straightforward question. Which one indicates highest priority? You can answer it. Yes, red means highest. Yellow means medium priority. Green means ambulatory. And black means dead. Okay. So I think that was the question, means highest priority means red is the highest priority, guys. Okay, fine. It's a straightforward question which has been asked multiple times. Fine. A case control study, options were given. Which among the following is not true according to that? So it starts from where to where? It starts from cause to effect or effect to cause. That is the first option. It starts from effect to cause. Okay, it is useful for rare diseases. Useful for rare diseases. It is one of the option was there. So it is also called as what study? Case control study, case reference study. So we can find odds ratio in it. Okay, odds ratio. I think the question was cause to effect or effect to cause. Okay, so it is more of effect to cause. Effect to cause is case control study. Fine. In Anemia Mukt Bharat, last time in your exam, the question was, what is this 6x6 matrix? Okay, last exam. Okay, so 6 beneficiaries should be there. 6 interventions should be there. 6 institutional mechanisms. That was your last exam question. This time the question was pregnant women. What is the dose of this IFA tablets, iron and folic acid tablets in pregnant women? So 60 milligram of elemental iron and 500 microgram of folic acid. This has to be given daily from 4th month to term. That is 180 days. This is prophylactic iron. This is prophylactic iron. So the answer is this one: 60 milligram of elemental iron and 500 microgram of folic acid. This direct question. Fine. Identify this instrument. Okay, you can put it in the chat box. Okay, what is this instrument? Anyone? What is this instrument? Yes. So what is this instrument? Yes. This is sling psychrometer. Okay, this is sling psychrometer. What is the purpose of it? Okay, you can hold it in the hand and you can rotate it. You can rotate it. Okay, what is the purpose of it? Okay, it measures humidity. Okay, sling psychrometer. Okay, so it measures humidity. Okay, fine. So is there any other instrument was asked in this? I think what I heard from students is sling psychrometer. Okay, as it has these 2 thermometers will be there. Okay, wet and dry bulb thermometers will be there. Okay, any other instrument? Fine, no. What is this graph? This is line diagram, guys. Time is there. Line diagram. Identify the graph. So this is line diagram. Line diagram. Line diagram. What is it? Is used for what data? It is used for quantitative data. It will tell you the trend of the events over a period of time. So time will be there. This you can measure it, guys. This you can use it, time. By seeing the time, you can say that what is this graph? Okay, this is line diagram that measures trend of the event over a period of time. Okay, fine. Next. A syringe attached with the needle. Okay, the question is on biomedical waste management. Question. The syringe is there with needle. The question they said, as per students. Okay, hope this is correct. With needle means what? Okay, it should go to sharps, guys. Okay, it should go to sharps. Sharps means it should go to white. But the question just to say only syringe. Syringe alone means it can go to red. But since they say with needle, it should go to white color bit. That is what the answer they are expecting. White color bit. Fine. Which question was there out of this? Either JSSK or NSSK was asked. Okay, or both was asked. Okay, kindly tell me. JSSK, what is the purpose? Okay, we want to provide pregnant mothers and sick infants. Okay, sick infants, we want to provide free services, guys. Free services, free transport, everything free. Okay, so that is JSSK. Okay, so I'm not sure which one was there. Some students are saying JSSK, some students are saying NSSK. Okay, whether both was there or not, that you have to tell us. Okay, fine. So pregnant and sick infants, so free service, everything free. Okay, free OPD, free treatment, free blood, free transport, everything is free is given for JSSK. Under JSSK, these are the beneficiaries. One is that pregnant mothers and sick infants. What is NSSK? NSSK is to train healthcare workers. Train healthcare workers, okay, in basic newborn care. Basic newborn care and resuscitation. Okay. Basic newborn care and resuscitation. Okay, that is NSSK, guys. NSSK, basic newborn care and resuscitation. Okay, fine. So you can tell me which one was there. Okay, whether JSSK or NSSK was there. You can put it in the chat. Fine. Next. Okay, similarly, we have another question that some students are saying SMR was there. What is standardized mortality ratio? This is a form of indirect standardization. Okay, this is a form of indirect standardization. Okay, if this was there, the formula is that for calculation is observed deaths by expected deaths. Okay, multiplied by 100. This was there. This is the formula to calculate it. Observed deaths by expected deaths multiplied by 100. SMR, standardized mortality ratio, which is a type of indirect standardization. Okay, fine. So some students are saying proportional mortality ratio is also there. Okay, proportional mortality ratio. What is proportional mortality ratio? I want to find out what is the percentage of deaths are cardiovascular disease. Okay, what is proportional mortality rate ratio is that number of CVD deaths, cardiovascular disease deaths by total deaths multiplied by 100. Proportional mortality rate, this is not ratio, proportional mortality rate. So number of cardiovascular deaths, that is any condition, particular condition numerator divided by the total deaths in a particular time. Okay, that is a particular year. So this is called as proportional mortality rate. In India, the most common cause of death is almost cardiovascular disease. Nearly 30% of deaths are cardiovascular disease. Out of these two, one was there. Okay, fine. This is the one of the tough question. Okay, but anyway, we have discussed this in class. Okay, that is what is this ANMOL app is related with what? Okay, this is we are using technology. Okay, what is this ANMOL? ANMOL means ANM online. So ANM is the worker. She is present in the subcenter. She will be present in the subcenter. She has to carry a lot of registers actually. Okay. So what is done is ANMOL is that there she was given on tab with app is given. What she has to do is that instead of putting all those things in the registers, okay, so now she has to enter, she has to go house to house and do a lot of works, lot of antenatal registers she has to maintain. Okay, eligible couples register, okay, post-natal register, lot of registers, under 5 registers, lot of registers she has to maintain. So in the tab itself, she can do the entry of all those things. Okay, so just more like a paperless work. So that concept is called as ANMOL. ANMOL is ANM online. Fine. This question have been discussed with other subjects also. What is this angular stomatitis and glossitis? Chapter is nutrition. Yes, what we will get is, yes, angular stomatitis, this is riboflavin deficiency. Riboflavin deficiency, you can find this. Okay, fine. Next. Bleeding manifestation comes. It's a very common question. Yes, this is vitamin C, guys. Vitamin C deficiency. Okay, bleeding manifestation comes and delayed wound healing. Both are vitamin C deficiency. Nothing new there. Fine. Niacin deficiency is the most often repeated question last 3 years. Okay, whether it's a NEET exam, FMGE exam, it has been asked multiple times. So what are the features the patient will have? Diarrhea, dementia, dermatitis. Diarrhea, dementia, dermatitis will have. The patient will have this Cassell's necklace, where it is common maize-eating population, guys. Okay, it is common in maize-eating population. Okay, this is one of the most repeated question. 4Ds. 4Ds, maize-eating population, a commonly asked question. That's fine. So what is this? Probably this one was asked. IMNCA, we have this diarrhea color-coded classification we have to follow. Following IMNCA, it's a scenario-based question. So what we will have is that we will have the suppose any child comes with diarrhea. What we will do? We will look for general condition. Okay, we'll look for general condition. We'll look for thirst. We'll do the skin pinch test. We will do, and we'll do sunken eyes. Okay, fine. So what we will do is that based on this, we are going to classify them as no dehydration. Everything is normal. Some dehydration we are going to divide. And severe dehydration we are going to divide. So we are going to categorize them into three. Okay, no dehydration, everything is normal. Some dehydration means patient is having sunken eyes, restless and irritable is there. Patient is eagerly drinking water. Okay, skin pinch test you do have to do in the abdomen. It goes slowly. And the last one is that severe dehydration. Patient is unconscious, not able to drink. Sunken eyes, skin pinch test goes very slowly. So if it is there, no dehydration, according to IMNCA, we have to follow color coding. Okay, so green color, which can be managed at home level. Some dehydration, we have to follow yellow color. And severe dehydration, we have to follow pink color coding. We have to follow pink color coding. Okay, fine. I think the scenario what they are given based on this, the answer is yellow, I think. Okay. The scenario what they are given is yellow color. So patient might be having sunken eyes, able to drink water, restless or irritable. Okay. So this is also we have discussed in the class. Okay. So these are some of the questions I was able to collect it from the students and I was able to explain it. Is there any other questions are there? Means please put it in the our group channel. Okay. So this is easy for us to go through. Okay. Thanks for listening. I hope you did well. Okay. So see you soon with good results, guys. Okay. Thank you.
Thank you, Dr. Murugan. So that was a wonderful session, and PSM being a very important topic, students had a lot of doubts and you addressed it very well. So thank you once again. So students, next up we have Dr. Dharmendra. He's our psychiatry faculty and he will be running us through the questions that appeared from his subject of interest, that is psychiatry. Dr. Dharmendra, am I audible to you? Am I audible to you, sir?
Hello, yeah.
Okay, sir. So you're audible and your video is clear. So over to you for the questions. I'll be dropping off now.
Okay, thank you. Thank you so much, sir. So very good evening. I hope everybody has done well, but now that is not the important MCQ. The important MCQ, what they have asked and what's the correct answer. So in psychiatry recall, I'll go directly to the one MCQ. The first one is the patient had a manic and the depressive episode and needs treatment. Which of the following causes the least weight gain? So basically, as you know, in class we discussed that we have a antipsychotic which have a high, risk of weight gain, moderate, and the lower. So basically, in high risk we have clozapine and olanzapine. Then these three options given, risperidone, quetiapine, and the chlorpromazine, they have a moderate risk. And the ziprasidone basically is a correct answer. It has a low risk. Apart from the ziprasidone, the aripiprazole is the another antipsychotic which has a, so in class also we discussed that least weight gain risk is with the aripiprazole and ziprasidone. So in this MCQ, the answer was ziprasidone. Some students were confused with the chlorpromazine, but no, chlorpromazine having a moderate risk. It's a typical, usually we say typical having a less than atypical, but the chlorpromazine having a moderate risk. So in this MCQ, the correct answer is ziprasidone. The next MCQ, a 60-year-old male patient believes that his thoughts and feelings are controlled by some external agency. This time, they, rather than giving the option delusion of the somatic passivity or delusion of control, they have given the delusion of influence. So nihilistic delusion, it's a delusion of nihilism, or we say the Cotard syndrome. The patient think that nothing exists. It's the part of severe depression. The delusion of persecution, we know that patient think that
somebody wants to harm me or kill me. And Othello syndrome is a delusion of infidelity, that partner having a suspiciousness, the partner thinks that he is cheating or she is cheating on me, unfaithful to me. A delusion of influence, usually the another name of delusion of influence is basically the somatic passivity. Delusion of passivity or somatic passivity, or we call it a delusion of control. Delusion of control. So the MCQ was 60-year-old male patient believes that his thoughts and feelings are controlled by some external agency. So basically, dear students, what happened in delusion of control or delusion of influence, patient thinks that his actions, emotions, feeling, thoughts are controlled by external agency. So the correct answer in this MCQ was the delusion of influence or delusion of control or somatic passivity. The more the options will come, we'll see but I think many students are giving this delusion of influence. So that was the option, the correct answer. In next MCQ, a patient presented in emergency with chest pain and no medical cause was found, and patient told the basically 10 days ago he was robbed on gunpoint in his house. When doctor wanted to discharge him, he refused to go back to his home. The family member told his pre-morbid condition before this incident was normal, likely diagnosis. So basically, the history is only 10 days. Before, already examiner mentioned that pre-morbid condition was absolutely fine. So basically, pre-morbid condition is fine, then the schizophrenia is ruled out. There is no history of disorientation, or the cardinal feature of delirium is the disorientation, the patient having a memory issues, others. So there is no delirium can't be the answer, even in sleepy stage. The avoidant personality, the pre-morbid condition is fine, then you can't make a diagnosis of personality. So avoidant personality also ruled out. So the option, the correct answer was in this MCQ was acute stress disorder. Basically, we have a trauma and related disorders. And in trauma and related disorder, we have acute stress reaction, and we have a acute stress disorder, and we have a PTSD. Okay, the only difference, acute stress reaction, we are making a diagnosis usually, the reaction, we are making a diagnosis up to 3 days, then up to 1 month we are making a diagnosis of acute stress disorder, and the PTSD we are making a diagnosis between 1 to 6 months. Okay, so that MCQ you have to see that what the duration is. In this, the duration is given that patient having this 10 days ago this one incident, and because of that he is refusing. And I think some students were saying the options were palpitation, that some anxiety symptoms were there. So the answer in this MCQ was between like 3 days to 1 month, usually we say acute stress disorder. So the correct answer was acute stress disorder. One MCQ was there, if somebody can remember, if there are more options, we can discuss about it. But the MCQ was like a sudden spasm of muscle, the torticollis on antipsychotic. So what's the management? So basically in this MCQ, we usually give the anticholinergic, like the drugs like trihexyphenidyl. We are giving the benztropine, and we give the even injection also, we can give the promethazine, or we say the phenargan, or we say promethazine. Okay, so IV benzotropine also we can give. So if accordingly, what the option, usually some students were saying that IV benzotropine was the option. So benztropine we can give, anticholinergic drug, we say the centrally acting anticholinergic drug we give. Basically acute dystonia, or it's one of the earliest, within the 2 weeks you having this side effect after starting antipsychotic. So trihexyphenidyl, IV benztropine, injection phenargan we can give. So accordingly, what was the option? Accordingly, you can choose in this MCQ. One MCQ was that the patient consuming substance, he sees the red color when hearing radios. So what usually, which substance patient was consuming? So in this, basically you see the patient see the red color. Basically it's a visual hallucination, and hearing radio is what? It's an auditory hallucination. Auditory. So patient basically sees the So there are, like we say, the functional hallucination and we say the reflex hallucination. Only difference between functional and reflex hallucination, that in one mode, in functional hallucination, basically the stimulus in one mode, having or that trigger the hallucination in same sensory modality, and in reflex hallucination, so we having a reflex hallucination and we having a functional hallucination. In reflex hallucination, patient having a stimulus in one sensory modality and hallucination in another sensory modality. And in functional, we having a stimulus and hallucination in the same sensory modality. So basically in this, in this MCQ, basically patient having a reflex hallucination, patient hearing the radio, auditory, and then there's a visual, basically red color. So there are different sensory modality. So patient basically having a reflex hallucination, and reflex hallucination usually we have in hallucinogens. And in hallucinogen, the correct answer was LSD, lysergic acid. Lysergic acid was the correct answer, correct option, because it's a one type of hallucinogen, and hallucinogen, they cause the hallucination. In LSD also, some students were saying there's also the palpitation or increased heart rate was also given in the MCQ. So in this answer, the correct answer was the LSD, lysergic acid. One MCQ was, it's a basically forensic psychiatry. One MCQ was that the mentally unstable patient having a, goes for the MTP, the consent taken from. So who will give the consent? Basically, this MCQ they have taken from the Mental Health Act. Okay. So basically, suppose tomorrow person is not able to give the consent, is not capable, doesn't have a capacity to give the consent, then the one option we have nominated representative. Okay. And if nominated representative is not in an option, then the second option you can choose the relative. Okay, in sequence it's given. If relative is not in option, then you can choose the caretaker. Okay, so you can see what was the option. Accordingly, you can choose. I think forensic faculty already discussed it, but you just see the correct options will come. Then again we'll go. But this is Mental Health Act. Also we discussed in the class, and it's an important, small but important topic. So the first option should be the first correct option should be nominated representative. If not given the option, then the relative, and then the caretaker. One more MCQ, I think they have asked. The child was 6-year-old having a repeatedly tapping movement. He was having lack of, attention. The not attentive in the class. Which drug should be given? So basically, the examiner is talking about the attention hyperactivity, ADHD, attention deficit hyperactivity disorder. So I told you that if the age of the child is 3 to 6 years, or we say less than 6 years, then the drug of choice is, atomoxetine. And if the age is more than 6 years or 6 years above, then the drug of choice will be methylphenidate, because methylphenidate, the serious side effect of methylphenidate is what? Growth retardation. So below 6 years, we usually avoid the methylphenidate, but the age is 6 years or above, then usually we say. So some students are saying that they have asked the drug of choice. Some students are saying the MCQ was given as I have written, and that they have asked the drug. So if the 6 year or above, the drug of choice is methylphenidate in the ADHD. So this MCQ was from the child psychiatry. One MCQ was the 20-year-old boy presented with a seizure. Further evaluation, he had a symptom of depression and mania. So what's the drug of choice? So basically, if this MCQ was in a same way, so basically the patient having a bipolar disorder and simultaneously comorbid medical condition is what? The seizure. So which drug which mood stabilizer basically we use? You know that we have a sodium valproate. Sodium valproate basically is a good mood stabilizer, and it also an anti-epileptic drug. So if the history is given of depression and mania, for further evaluation, but already the patient presented with the seizure, then we can go for the sodium valproate. Sodium valproate we can use as a mood stabilizer for bipolar disorder, and it will be effective in epilepsy or seizure. So if this was the MCQ, then answer you can go for the valproate. So these were the MCQs in the psychiatry. So the first MCQ answer was the ziprasidone. The second is basically the delusion of influence. The third is acute stress disorder. The fourth is basically if the option is given IV benzotropine, anticholinergic drug basically. The next is LSD, hallucinogen. And in this, you have to see the options. Once I will get the correct option, then we'll talk about it. And then methylphenidate for ADHD and valproate for the seizure disorder. This is from the psychiatry side. Santosh sir, I have done.
Okay, sir. Thank you for recalling the questions. I think students, you got your answers. If there are any more doubts, please you can connect with us on the Telegram, and Dr. Dharmendra would address your queries. So for now, Dr. Dharmendra would be dropping off, and next in line we have Dr. Himanshu Gupta. He is a faculty for radiology. I think all of you are familiar with him, and he will be taking us through the radiology questions. Dr. Himanshu, am I audible to you?
Yes, sir. I'm
Okay, so
audible.
over to you, so you can take over and go through the questions. You're loud and clear and audible.
Thank you, sir. So guys, the first question that was asked from the radiology, it was the very important question. You could see multiple round opacities in both lung fields. So this is basically your cannonball metastasis. So we should know that these cannonball metastasis, this is seen in endometrial carcinoma, prostatic carcinoma, choriocarcinoma, and synovial sarcoma, right? Now, you should also know what is an important differential for cannonball metastasis. That is your pulmonary hydatitis. So which was again not mentioned in the question. Now, second question that was given, it was your opaque hemithorax. Opaque hemithorax. So guys, this opaque hemithorax, you have to see the position of the trachea. Is the trachea deviated to the side of opacity? Is the trachea central, or is the trachea deviated to the opposite side? So guys, there are various differentials for these conditions. So in our question, the trachea was shifted to the same side, and that is shifted in a patient with total lung collapse or atelectasis. If the trachea is in midline, that will be seen in a patient with consolidation. And if the trachea is shifted to the opposite side, right, to the opposite side of homogeneous opacity, that will be seen in a condition with pleural effusion, right? And these are the other conditions in which you can find the trachea shifted to the opposite side. Then there was a question on road traffic accident, very important image asked in most of the exams. So you have to see the shape of the bleed, If the shape of the bleed is concavo-convex in shape, right, that is a subdural hemorrhage. If the shape of the bleed is biconvex, that is a extradural hemorrhage. And if you are seeing hyperdensity within the brain, that is a intraparenchymal bleed. And if there is hyperdensities along the basal systems, that will be seen in a patient with subarachnoid hemorrhage. So in our question, there was a crescentric shape bleed, concavo-convex shape bleed, that is your subdural hemorrhage. Now another question, there was history of distended neck veins, hypotension, and diminished heart sounds. An X-ray was given. In that X-ray, you could see the heart size is enlarged and it is giving a water bottle appearance. So this appearance, this is characteristic of pericardial effusion, right? Another very important sign that you see in pericardial effusion on lateral chest X-ray, that is your 𝐒𝐿-𝐂𝐿 sign. Now, another question that was asked on the CCT abdomen anatomy, you were asked to identify the liver, pancreas, and spleen. So on the right side, you can see a solid organ, right? That is enhancing. This is your liver. On the left side, you are going to see the spleen. In the midline, you are going to see an organ that is just anterior to the portal vein. This will be your pancreas, right? So this was the question on abdominal anatomy. And another question that was asked on the breast ultrasound. So you were asked, what is the lesion that is being shown to you? So that was the case of fibroadenoma. So how do you differentiate between a fibroadenoma and a cyst in the breast? So you can see that a fibroadenoma will be a well-defined lesion, right? And it is not going to show any posterior acoustic enhancement. Whereas a breast cyst, you are going to see it will be an anechoic cystic lesion and it is showing posterior acoustic enhancement. Whereas a breast carcinoma, you will see that the lesion will be irregular in shape and it is not going to cast any posterior acoustic enhancement, right? So guys, this was all from radiology. So all the best for your results, and I hope that you are going to do well. Thank you, sir.
Thank you, sir. Thank you. So, guys, I think the questions were pretty simple and straightforward as expected, and I hope you have answered all the radiology questions. So, Dr. Himanshu will be dropping off now, and next we will be connected by Dr. Sharat Balaji. He is a faculty for pediatrics, and he will be taking us through the pediatrics question. So, pediatrics, just like medicine, surgery, and Obs Gynae, often comes with some clinically oriented questions. Some questions will be tricky. So, let us see what Dr. Sharat has got for us. Sharat sir, am I audible to you?
Yeah. Am I audible?
Okay, sir. Over to you. So I'll be dropping off, and
Shall
once
I
you're done,
start?
thank you.
Shall I start, Santosh?
Yes, sir, you can start.
Okay. Am I audible and visible now?
You're audible, sir. Yes.
Okay, then. As far as pediatrics is concerned, mixed bag. As far as pediatrics per se, it is very, very simple and straightforward questions. Some questions they had included in SPM. Some questions they had included in OG also. Let us see. So what is my first question? Congenital biliary atresia should be suspected when jaundice crosses option A 2 weeks, option B 2 months, option C 2 days, and option D 2 years. So what is the correct answer? The answer is very, very simple. Whenever a child is having some jaundice, you need to rule out whether it is a pathological jaundice or physiological jaundice. A physiological jaundice usually lasts for less than 2 weeks. A pathological jaundice usually lasts for more than 2 weeks. And with respect to congenital biliary atresia, it is usually conjugated bilirubin rather than unconjugated bilirubin. So it is usually a conjugated bilirubin per se. When will you say this conjugated bilirubin? When your total bilirubin, when your conjugated bilirubin is more than 20% of total bilirubin, then you will suspect cholestatic jaundice. So very, very simple. The two causes for prolonged jaundice, that is jaundice which lasts for more than 2 weeks or two. One, whether it is a sick baby, other one, second one is non-sick baby. Sick baby means it is usually neonatal hepatitis. Sick baby means neonatal hepatitis. Your inborn errors of metabolism and torch infection plays a role, whereas non-sick means you have two things. One is choledochal cyst. The second one is extrahepatic biliary atresia. So I repeat, a congenital biliary atresia should be suspected when your bilirubin crosses, pathological jaundice crosses more than 2 weeks. Second point, and your conjugated bilirubin should be more than 20% of the total bilirubin. The answer for this question is A, more than 2 weeks. Second question. Anencephaly occurs due to inability of the neural tube in which of the antenatal life? Actually, it was also discussed by Dr. Our OG madam. Anencephaly, it can be due to failure of closure of the cranial end. You have cranial end, you have caudal end. Failure of closure of cranial end is your anencephaly. Failure of closure of caudal end is your neural tube defect. It can be a myelocele, meningomyelocele, or it is a open spina bifida occulta. So anencephaly occurs due to inability of the neural tube, that is anterior end of the neural tube, the cranial end of the neural tube, by about 24 to 28 days of intrauterine life. But we can say the answer for this question here is 4th week. I repeat, the answer for this question is 4th week. Then identify the structure. Third question, identify the structure. Omphalocele, gastroschisis, umbilical cyst, and one more option we really don't know. But in this question, the intestinal contents are there in the sac. So the sac is present. Whenever you have a sac, it is more in favor of an omphalocele. When absent sac is a feature of gastroschisis. And remember, omphalocele arises through the umbilical opening. It arises through the umbilical opening, whereas your gastroschisis arises to the side of the umbilicus, usually on the left side of the umbilicus. And since there is a sac, the entire intestinal comes out, so there will not be any obstruction. There will not be any obstruction in case of ampholysis, but gastroschisis, unless otherwise proved, they often born with the intestinal tract obstruction. This child has got a sac which is not ruptured, and the intestinal contents are there, and umbilical cord is attached to it, and it arises through the umbilical opening. So this must be a case of an ampholysis. Next question. Stranger anxiety appears at. We all know that by 6 months, stranger anxiety appears, as well as transfer of objects from one hand to another hand. This appears particularly by about 6th month, stranger anxiety. Next question. Angular cheilitis, stomatitis, and glossitis in which vitamin deficiency? B1 usually is associated with the dry beriberi, that is your peripheral neuropathy. Wet beriberi, that is your cardiomyopathy, as well as it can present with the infantile aphonia. Which one? B1 vitamin. B2 vitamin is usually associated with that is your riboflavin deficiency, that is often associated with cheilitis, stomatitis, and glossitis. B6 deficiency. B6 deficiency again is associated with peripheral neuropathy. Most often it occurs as a result of drugs such as anti-tuberculous drug, particularly your isoniazid. Whenever any child is on INH, the child should be provided with pyridoxine. And finally, B12. What is the manifestation of B12 deficiency? We all know B12 deficiency usually manifests with megaloblastic macrocytic anemia. Megaloblastic macrocytic anemia. Which one? B12 deficiency. So the answer for this question, angular stomatitis, cheilitis, and glossitis in which vitamin deficiency? Riboflavin, that is your B2 deficiency. Identify the milestone. One hand transfer, as we discussed already, by about 6 months, hand transfer of objects between one hand and another hand appears. By about 9 months, immature pincer grasp, and by about 1 year, mature pincer grasp. By about 6 months, radial ulnar grasp will be present. Ulnar grasp will be present. So 6 months, transfer of objects. 7 months, ulnar grasp. 8 months, radial grasp. 9 months, immature pincer grasp between thumb and your index finger. And finally, by about your 1 year, pincer grasp will be matured. So the answer for this question is A. Transfer of objects between one hand to another hand is at 6 months. Bleeding gums in which vitamin deficiency? Vitamin A is associated with vitamin A is associated with night blindness, xerophthalmia, keratomalacia, etc. Vitamin B is associated. There are so many B complex vitamin. B1, as we discussed already, B2 discussed, B6 discussed, B12 discussed. One more B vitamin is biotin. Biotin is associated with alopecia and neuroregression. And the pantothenic acid, as you all know, associated with the burning feet syndrome. Vitamin D is associated with the cardiomyopathy, hypocalcemic rickets, and bony deformity. Vitamin C, we all know that it is associated with the poor wound healing. Associated with the poor wound healing, as well as bleeding from many sides, particularly your gums. It can also produce cerebral hemorrhage. It can also produce your hemopericardium, because there will be absence of hydroxylation of collagen involving your blood vessels. So bleeding of gums occurs particularly in vitamin C deficiency, scurvy. Previously, people used to say it occurs predominantly in sailors, but as far as in pediatrics, it is in autism children or children with special needs. Then identify the condition. Is it cephalohematoma, caput, or subgaleal hematoma? Remember that it is at the side. It is over the parietal bone. Cephalohematoma occurs as a result of a fracture involving the parietal bone because of forceps delivery, and it usually appears over the parietal bone. This swelling occurs over the parietal bone, as a result of which we can vote for cephalohematoma here. If it occurs over this side, over the presenting part, then I can say it is called caput. A cephalohematoma usually arises after 1 day. whereas your caput arises on the day of birth, at birth itself. The subgaleal hematoma, the child will be very, very, very sick, and the entire calvarium will be having a swelling, and the child will be presenting with shock. The important clue is the swelling will be present to around the orbit as well as the around auricle. That is your subgaleal hematoma. So this is from my side. There are so many overlaps between subjects. If you have some other questions to ask, you can ping in our Telegram channel. Bye from me now. Thanks a lot, Santosh. It is over from my side.
Okay, sir. Thank you for such a nice and wonderful discussion. Sir, we will hang on for a few seconds. If students have any more doubts to shoot, we will address them. Otherwise, I'll take over for the medicine questions.
Okay.
Sure. Students, if you have any questions to Dr. Sharad Balaji, you can shoot it. He'll be here for a few more seconds, and then we will be taking up with medicine questions.
Are there any questions?
Okay, so if there are no questions, then I'll take it over from you, sir, and then we will continue with the medicine session. So guys, coming to the final part of the discussion, so we will be taking up with medicine questions now. Just like surgery, Obs Gynae and Pediatrics, medicine will also be complicated with controversial or tricky questions, but I'll try to make it simple. I'm quite pleased to tell you that we had done some live sessions on the YouTube a couple of weeks prior to the examination, and we also had an MCQ discussion called as FMGE Spotlight. So whatever questions I have collected so far, all of them, almost all of them could be addressed from those 5 or 6 live sessions that we had done. So in the 10-15 hours of preparation, you could have tackled most of the questions coming from medicine. Okay, so let me start with the first question. This was a question number 1. Okay. Can you confirm me if the question was in the exact same frame, or if there are any changes, let me know so that I can correct the question. Okay, so the question was about a chronic smoker, and there was a pointer here that patient had hyperpigmentation and had central obesity, and RBS was mentioned, which was obviously increased, right? So we have central obesity and hyperpigmentation and hyperglycemia. So if I have to think of endocrine disorders, first thing that should come to my mind is probably Cushing syndrome. That is where I would think of hyperpigmentation. Diabetes remains a differential diagnosis. And then they have mentioned that they had done a high-dose dexamethasone suppression test, which failed to suppress the ACTH production. So ACTH remained elevated despite high-dose dexamethasone suppression test. Okay, so now it is clearly a case of Cushing syndrome when they're talking about dexamethasone suppression test and all. But the question is whether this Cushing syndrome is because of the ACTH producing pituitary adenoma, or because of the exogenous administration of steroids, or whatever other options were there, right? Now, the key point here is to look at the hyperpigmentation. Why hyperpigmentation happens in some patients with Cushing syndrome? Please remember, when ACTH is produced, it is produced as a prohormone. It is called as pro-opiomelanocortin, or POMC, which gets later cleaved to produce a melanocyte stimulating hormone and ACTH. So this melanocyte stimulating hormone can stimulate your melanocytes to produce increased melanin, and that causes hyperpigmentation. And ACTH also stimulates melanin production, right? So in any endocrine disorder where you're thinking of hyperpigmentation and there is some link to ACTH, you can relate to it. High ACTH is usually responsible for hyperpigmentation in Cushing syndrome. Similarly, if you have an adrenal gland dysfunction, primary adrenal gland dysfunction or hypoadrenalism, there also ACTH goes high, and there also you can have hyperpigmentation, right? Now, from where this ACTH can come, either it can come from an ectopic source, or it can come from a pituitary adenoma, right? Now I have to make a choice between these two. I guess ectopic was not an answer in the options, And even if it was there, to differentiate between ectopic source of ACTH and the pituitary adenoma, we would require a inferior petrosal sinus sampling, and that is not mentioned in the question. And because pituitary adenoma is much more common than the ectopic source of ACTH, that would be the answer to go for, right? So the answer for this question is a pituitary adenoma producing excess ACTH responsible for the Cushing syndrome, what we call as Cushing's disease. Okay. The next question, I'm not sure if students are confused between the two questions or this was one question. One student told me that there was a direct straightforward question asking where do you get absent, why distant? Another student said that there was a question about hypotension, muffled heart sound and distended neck veins. Okay. So if the question is talking about hypotension, muffled heart sounds and distended neck veins, it is Beck's triad, right? And where do we see Beck's triad? We see Beck's triad in patients with cardiac tamponade. Okay. And if that was a history and they're asking you what is something that you're not going to see on the JVP, then you will not be seeing the Y wave, right? Or if they're asking you what is seen, then you will be seeing absent Y descent. And for making it simpler for you, I think I had told you in the previous FMGE sessions also that there's a simple mnemonic to remember about cardiac tamponade. That is no, thank you, right? So in cardiac tamponade, there is no Y descent in tamponade. No, thank you, right? If you had attended that session, you could have got this question right. Okay. Now, next, one more question was about the Reiter syndrome, which Dr. Ranjit has addressed it. So I will be skipping it, but you know, right, which HLA is associated with Reiter syndrome. There was another question on anemia with decreased ferritin and increased TIBC. That is clearly iron deficiency anemia. And that has also been addressed by Dr. Ranjit. Okay. Then there was a question on Conn syndrome. So if anybody can provide me options, it would be a bit easier for me to give you more precise answer. I don't know if the question was what is not seen in Conn syndrome or what is seen in Conn syndrome. Most of the students said what is not seen in Conn syndrome, and one of the option was metabolic acidosis. Now, what we see in Conn syndrome is hypokalemic metabolic alkalosis, right? So if there was an option of metabolic acidosis and they're asking what is not seen, then obviously that would be the answer, right? Metabolic acidosis is not seen in patients with Conn syndrome. Simple and straightforward, right? Okay. Then there was one more question on aphasia. They were asking where do you see non-fluent aphasia? And the answer is again pretty simple. That is Broca's aphasia, right? So in case of Wernicke's aphasia, you get hyperfluent or fluent aphasia, right? So fluency is affected when there is a motor component. Either you can see the non-fluent aphasia and Broca's aphasia or your transcortical motor aphasia. Only two conditions you get non-fluent aphasia. So that's again a pretty straightforward question and quite anticipated question because almost every alternate year I've started seeing questions on aphasias. This time it was simple, straightforward one-liner. You might as well get clinically oriented questions where you have to recognize that this is a story of a particular kind of aphasia. Okay. So there was one more question about the electrolyte abnormalities in patients experiencing the refeeding syndrome. I think Dr. Sandeep has discussed it in detail, but I'm again going through it. I am not very sure exactly which 4 options were there in the refeeding syndrome. Okay. Now, what exactly happens in refeeding syndrome is you have 3 hypos, classical 3 hypos. Hypokalemia, the potassium will be certainly low in patients with refeeding syndrome. Hypophosphatemia. In fact, if you ask me to pick one among 3 hypos, I would go ahead with hypophosphatemia. Phosphate will be low, right? And the third one is hypomagnesemia. So every time we recognize someone as having refeeding syndrome, these 3 plus 1 micronutrient deficiency, that is thiamine, right? Thiamine deficiency, hypokalemia, hypomagnesemia, and hypophosphatemia are concerns in patients with refeeding syndrome. Now, what happens to calcium? Some patients, in fact, have hypercalcemia. Okay, hypocalcemia is not known to occur. Either you will have normocalcemia or hypercalcemia, right? So if the options we're talking about, hypocalcemia or hyperkalemia, those would have been the correct answer. And as I interact with the students of late, I have realized that hyperkalemia was one of the option, and that would be clearly the answer to go for. We don't expect to see hyperkalemia in patients receiving TPN after prolonged fasting. Okay. Then there was one more question on which drug excretes sugar in urine, and that you all know answer. That is one of the SGLT2 inhibitors, right? I'm not very sure if the question was particularly mentioning a SGLT2 inhibitor class of drug or just the SGLT2 inhibitors as a class. Anyway, that would be the answer, and I'm sure all of you are familiar with that. Okay. Then there was one more question coming up, which has been addressed in pharmacology as well as Dr. Binish under anesthesia, that is drug of choice for ventricular tachycardia. And I think Arif was telling somewhere in between that there was ST elevation, right? So please remember, for few years ago, we used to think of 𝐒𝐿-9 as a drug of choice if VT is being considered in patients with ischemic heart disease, and that too, primarily we used to use it as a preventive medication. Okay, but what latest studies have shown, especially last couple of years, is that 𝐒𝐿-9, especially used in patients with ischemic heart disease with a preventive intent, trying to prevent ventricular tachycardia, indeed increase the risk of mortality, and we have totally given up on it, right? So the drug of choice for VT is clearly, now in current context, would be amiodarone, right? Our broadest spectrum antiarrhythmic. Amiodarone would be the drug of choice for VT. Only one condition, we will be moving away from amiodarone, that is when you have a polymorphic type of VT called as Torsades de Pointes, right? So can anybody tell me what is the drug of choice for Torsades de Pointes? So whenever you have Torsades, the drug of choice would be magnesium, right? Magnesium would be the drug of choice for Torsades de Pointes. Otherwise, any other case of VT, amiodarone would be preferred. If amiodarone is not available or there are contraindications, you can choose 𝐒𝐿-9, right? Amiodarone over 𝐒𝐿-9. 𝐒𝐿-9 is no longer first preference, even if the question was about an ischemic heart disease and ST elevation. Okay. Then there was one more question where students said that there was an ECG, probably ECG was of SVT, or whether there is a mix-up of VT and SVT questions, I don't know. But if there was a question of ECG with SVT, clearly showing that there is narrow complex tachyarrhythmia with absent P waves and regular RR interval, then that is clearly a case of paroxysmal supraventricular tachycardia. And in that case, we are all familiar. What is the drug of choice? The drug of choice would be adenosine, right? Adenosine intravenous, preferably through central line. Okay. Then there was one more question that student shared me, that there was a question asking, where do you see intention tremor? I think tremor we predicted as a very important topic for the coming exams, and we made sure that we discussed about tremor in almost all sessions. We have also watched some of the videos of tremors for you to register it in mind. And where do we get intention tremor? Yes, we get intention tremor in patients with cerebellar lesion, right? Cerebellar lesion. We call it as action tremor or intention tremor, right? Like when you try to test for the finger nose test, basically you're trying to unmask an intention tremor. When they try to intentionally touch the examiner's finger, the tremor kicks in. That's what we call as intention tremor. Okay. Then there was one more question about weakness, which is increasing in the evening associated with ptosis. And I don't need to really elaborate on it. All of you know that would be a case of myasthenia gravis, right? If they had mentioned vice versa of it, that weakness is more in the morning and as the day progresses, it decreases, then probably we could have considered the possibility of Lambert-Eaton syndrome. But in this case, it is myasthenia gravis, and I'm sure most of you have answered it right. Okay. Then another question, patient with hemiparesis, which resolved within 4 to 6 hours. What score is used to predict the future risk of stroke? I have done a separate session on scoring systems, and because we kind of predicted that this is going to be important and we are anticipating one question. And as expected, the question came. This is what I had addressed in the YouTube live session on scoring systems, right? So whenever you're thinking of a TIA and you have to assess the future risk of stroke, we use a scoring system called as ABCD2, right? ABCD2. And that's the answer to go for. And I guess all of you have answered that. ABCD2 score, right? The CHA2DS2 VAS score is used for deciding the anticoagulation in patients with atrial fibrillation. I guess that was also addressed by us in the scoring video module, right? CHA2DS2 VAS score also we had discussed. Okay, so mostly I would say the exam was on the anticipated line, nothing much different. Okay. The question number 14 that I'm projecting here might have certain controversies because I have heard different versions of it, right? Now, anything I change here will change the answer for sure, right? Okay, so this is what I could compile from students' recalls. Hi, Krishna. Hi. Okay, so there was a patient with fever and disorientation, had an episode of convulsion and neck rigidity. Yes, at this point of time, we are thinking of possibility of meningitis. CSF will be done. CSF showed 300 cells. And out of that, 50 to 70% were polymorphonuclear cells. That means it is a neutrophilic predominant, right? And I think if I remember correctly, some student was telling me the duration of symptoms was 3 days. So this is acute meningitis with CSF showing polymorphonuclear cell predominance and slightly elevated protein. And when we look at the CSF sugar, it is 50 with blood glucose 95, slightly decreased blood glucose, neutrophil predominant, right? So whenever we talk about decreased blood glucose in CSF, two things should come to your mind. One is pyogenic meningitis or bacterial meningitis. Second one is tubercular, right? Now, tubercular 3-day history, bit unlikely. Generally, you will have subacute to chronic presentation. And the second thing is, in case of tubercular, you may not have polymorphonuclear predominance. Rather, you will have lymphocyte predominance. So if the question was exactly in the same stem as this, then the answer would be pyogenic or bacterial meningitis, right? Pyogenic meningitis or bacterial meningitis. But as I've already told you, if I flip things here, right, I change it from polymorphonuclear predominant to lymphocyte predominant, the answer changes, right? If I change the sugar values or if I change anything here, the answer would change. So please be aware about it. Okay. Then last question from my side. This was a question where patient had headache, which is unilateral, which is associated with photophobia, and it aggravates on skipping breakfast. And they were asking, what is the diagnosis? Okay, so if that's what they're asking, right, then this is a very straightforward question. I think we have learned about headache in detail. We know how to approach, right? Whenever you think about a primary headache disorder, first thing that should come to your mind is unilateral or bilateral. If it is bilateral, tension type of headache. If it is unilateral, you have differential diagnosis of migraine, cluster headache, and other trigeminal autonomic cephalgias, right? Now, examiners will give you additional clues to differentiate. If it is cluster headache, they will mention alcohol as a trigger. They will mention male gender. They will mention the seasonal clustering, right? And autonomic symptoms, the redness of eye, the stuffiness of the nose, right? Tearing or lacrimation, rhinorrhea. Those things are not there, so cluster becomes a bit unlikely, right? Then there is accompanied photophobia. If you remember our YouTube discussions, we had discussed it there about the photophobia as a feature of migraine, photophobia, phonophobia, nausea, vomiting are very common with migraine, and all of that points towards this being migraine. So migraine would be the answer. Nausea, vomiting present well. So it's clearly a case of migraine, right? So around 15 questions I've been able to recall so far. I'm sure medicine will have more questions. Some of them are also being addressed by our physiology, pathology, pharmacology faculty. I will compile a detailed list and the appropriate answers. Whatever I'm sharing here, if you notice that the stem was not exactly like that or options were not exactly like that, so please do let me know so that I can give you a corrected answer so that you are also familiar with what is the true answer and what you have answered in the examination hall. Okay. And having said that, before I conclude, let me tell you that our fate is already sealed. You have answered. So there is no need to worry about what is going to happen, right? We cannot go back and change whatever we have answered. So there is no need to fret about, oh, I should have done this, I should have done that. Please remember that all we are striving for is getting 150. We don't need to be right on every question. We need not have correct answer for every question. If you got that 150 number, we are sailing through. And looking at the paper, I predict that we will have a very good result this time because most of the things were on the expected line, right? We were expecting questions on ABG. We were expecting questions on scores. We were expecting question on headache. We were expecting question on tremor. Most of them have appeared. So I can proudly say that almost 100% of the questions were from our YouTube sessions and the MCQ discussions we had done. So with this, I'm signing off, guys. Please stay connected with me on the Telegram and share all your questions so that I can give you a full-fledged final compilation of all the medicine questions that will help you as to know the answer as well as your next generation of students to better prepare for the exam. And before I close this session, I must thank our PW team comprising of Dr. Raman Singh and Dr. Haraprasad Mishra and also Aditya Sharma. They put out a very good technical support so that all 19 faculties could come live one after the other and solve your doubts and give you the questions as well as answers. And also our student team comprising of Jigar Bhanushali, Dr. Anto, and Dr. Vivek. All of them have helped us to compile the questions. They have created a pool of students who helped us to put this out together in front of you. So I'm extremely thankful to all of you and all of the support team, and especially students, guys. The recall wouldn't have been possible if all the students hadn't put out their queries or their confusions in front of us. So thank you for this opportunity, for being there in front of you with all this session. And with this, I'm signing off, guys. And in the comment section, there will be a pinned comment which will give you the link to the Physics Wallah's app, YouTube channel, Telegram, and other social media handles, where we will be posting the refined question stems and the exact answers after refining with consultation with students. Right? Thank you, guys, and have a good time. Have a good sleep. You deserve a sound sleep, regardless of your tensions and how I did in the exam. You deserve a sound sleep. Sleep well. Tomorrow is a Sunday. You can get up late and then have a blast. I will be connected with you through Telegram and PW channel. Thank you.